So good morning, everybody. It's fantastic to see that as we strive to stick to time, you all have cooperated with us. So it's yet another national summer CME of pediatric infectious diseases, month of April, Kolkata, and we all welcome you. It's a pleasure to have you with us, and it's right 9 a.m. and we intend to start on time with your cooperation. Time is valuable for everybody, and we do not want the later speakers to feel that they have been cheated by time constraints. So we will start on time. Now, in the meantime, may I request Dr. Ritobroto Kundu, who has been associated with Pediatric Infectious Disease chapter right from its inception, and who has been one of the pillars of scientific activity of pediatric infectious diseases, just to welcome you all. So may I ask Dr. Kundu, please.
My special welcome goes to the delegate. Because of the delegates, 500 plus thronging the hall right from the beginning till the end. It's a pleasant sight for the speaker who is going to deliver it. So again, I welcome you all in this summer CME, and we promise you to deliver something which you can carry back. Just not to listen and forget, but to listen and remember. And we will start very soon. Some of you are already on the breakfast. And again, thank you.
With this, may I, Dr. K.K. Arora here? Yeah, he was just here. I saw him. So, before we start, those who are having breakfast may still have the breakfast in quick time and come back. You can have your tea, coffee later, because it will be round the clock tea, coffee, so you can have it later. Now, to start with, few house rules that I would request to you, your cooperation. One is, please keep your mobile soundless. We value your time, of course, and help us in maintaining time. There is e-poster in the conference 1 hall. Do peep in at the e-posters. It will encourage the juniors. We have about 60 e-posters. Tea, coffee will be there round the clock in foyer 1, which is where some of the exhibition stalls are there. And of course, as you are aware, outside is too hot, so please stay back till the end. And do join us in the evening for a fun-filled program and dinner. Not to forget that we start tomorrow sharp at 9 a.m. Do not please embarrass us by asking for credit hour certificates early, because what has happened is that the National West Bengal Medical Council, they were quite amazed to see that we have asked for 650 certificates. So they have kept it on hold. They have got it back because they were doubting that why they are taking so many certificates, whether they are going to distribute it for free. So it will be handed over to us later tomorrow only. So we are unable with folded hands. With this, we have Dr. K.K. Arora, who is the Secretary of Pediatric Infectious Disease Chapter. The chairperson will be here sometimes soon, but may I request Dr. K.K. Arora to please come and just introduce this summer CME to the delegates. It's a pleasure to have you with us.
Good morning. I welcome you all on behalf of ID chapter, Pediatric Academy, Infectious Disease Academy. As you know, this National Summer CME, this is something which has been, I will say, a registered trademark of Kolkata. I have been attending this National Summer CME right from 2008, and I think it is all uninterrupted. It was going before that also, isn't it? So such a long, beautiful tradition. You are getting a feast every year, something new coming in ID, and these are the people who are just serving you best of their capacity and capabilities. I really thank the team West Bengal Infectious Disease Academy for this. Thank you, Dr. Jaideep, as well as thanks to Dr. Ritubrada and team for getting such a wonderful program every year. Do we have any? Now I...
No, inauguration is later. Inauguration is later.
Yeah. Now I ask Dr. Jaideep to continue the proceedings.
Thank you, Dr. Arora. Thank you for the kind words and reminding us that he has been attending from 2008. Actually, this summer CME is something like a tarpan to this great man, Dr. Tapan Ghosh, whom we lost in 2009. He was the torchbearer, and we are happy to continue this legacy. And many of you have met him, but those who haven't met him, you have missed a great soul who walked on this earth. But still, this is science, and we all will go with science. So let us not delay science further. So as I have already briefed you, so now let us start the science. So it's a power play. As you know, the T20 season is going on. The first 6 overs is the power play. And we have known bugs and unknown faces. The bowlers are known, but their repertoire has changed. So it's something like that. And to chart the ship through this turbulent sea, we have Dr. Prabhas Prashungiri, who is the in charge of Pediatric Intensive Care Unit at Institute of Child Health, Kolkata, to moderate the session. Prabhas, please come. And we have experts from Assam, Dr. Sailendra Das and Dr. Rupam Das, very close friends of us. Please come. Dr. Kaustav Chaudhary from Apollo Hospital, and Dr. Pratiksha Khatua, who is infectious disease specialist. So the stage is yours, Prabhas, please.
Panelists, please take your seat.
Good morning all. Thank you, Jaideep sir. So in this session of IPL and T20, we'll try to give some interesting cases to you in the next 45 minutes. Okay, so today's discussion will be on known bugs and unknown faces. So when we were undergraduate students, we were taught that rare presentation of common diseases are more common than the common presentation of rare diseases. So I will discuss about few bugs, those who have presented some atypical way. This journey will be through some real life case scenarios that I have encountered in our hospital. I have my learned panelists, Dr. Sailendra Kumar Das, Dr. Rupam Das, Dr. Kaustav Chaudhary, and Dr. Pratiksha Khatua. So going by case 1, this 9-year-old boy complains of fever for 3 days, swelling and pain over the right angle of mandible for same duration, abdominal pain with vomiting for 1 day, spastic movement of upper limb and lower limb for last 6 hours. Past history was nothing significant. Immunization history took all vaccines according to the NIS up to the age. On admission, child was alert and conscious. Spastic movement of the upper limb and lower limb. And we see that the wrist is lying in this posturing. So my question, Dr. Soilendra, what next investigation, clinical examination you want to do, and what next bedside investigation you want to do?
Thank you and good morning all. So before going for any clinical examination, I have to think in the mind what is the probable diagnosis. Here the patient is presenting with fever with swelling in the right mandible, along with abdominal pain and spasticity of the upper arm. So first I will think, is it a parotid swelling? If it is a parotid swelling, is it viral or bacterial? Because there is possibility of mumps, as the child is not vaccinated against mumps virus. Then if it is mumps...
So just tell me the next clinical examination you want to do.
So other than confirming the parotid swelling, then pain abdomen I will do the abdominal examination, and specifically if I think that this is pancreatitis or because of...
What is this posturing called?
This is called carpopetal spasm, and maybe because of it is hypocalcemia. And so I will do the Hostek sign and elicit the Hostek sign and Progeus sign. And the blood side investigation, to confirm immediately hypocalcemia, I will do ABG. And if there is hypocalcemia, the ECG is very important. So along with that, I will do the ECG and blood sugar.
So Hostek sign was positive. The ABG revealed a PO2 of 82, PCO2 of 25, bicarbonate of 17, pH of 7.42, and ionized calcium and 0.62. Dr. Rumam, very quickly, what's very striking in this blood gas?
Yeah, but bicarbonate is 17, so this is low, so there is acidosis, PCO2 is 25, so there is alkalosis, PO2 is almost near normal or a little bit low, and so there is metabolic acidosis and primary respiratory alkalosis, along with ionized calcium is very low, so 0.62, so this is hypocalcemia, this is showing also carbopetal spasm also.
So definitely the ABG is showing hypocalcemia. And Dr. Kustov, what is the importance of doing a ECG in this case?
So if you are getting that blood gas and it will take some time, and many centers don't have that the blood gas facilities also. So if it is not there, you can just go for the ECG to check for any evidence of hypocalcemia, which is a QTC prolongation that can give it idea that yes, this child might have hypocalcemia. We need to treat that also.
Yes. So other investigations have revealed that serum calcium was low, serum magnesium was normal, amylase lipase was sky high, USG whole abdomen of features of pancreatitis. Now, Dr. Pratiksha, what should be your diagnosis?
So now that we already have parotitis, like sir has said, this is most commonly caused by the mumps virus. The amylase lipase is almost 3 times the upper limit of normal, showing that this is pancreatitis. So this is mumps-induced pancreatitis, a very common complication that we see in mumps, following which pancreatitis caused the hypocalcemia, and hypocalcemia gave rise to the tetany. So the full diagnosis will be mumps-induced pancreatitis with hypocalcemia.
So definitely, so in mumps your amylase may be high, but your lipase will be normal. So definitely there is a pancreatic involvement, so your amylase and lipase will be high. That is a mumps that is causing the pancreatitis with hypocalcemia and landing to the hypercalcemic emergency. So take home, a so-called benign virus sent children to the ICU. We got 7 cases in the ICU due to the complication of mumps in the last epidemic, and definitely mumps demands respect. So case 2, this 5-year-old girl complains of papulopustular skin lesion with crusting of all over the body. History of on and off documented fever for the last 1 month with evening rise of temperature. There is some undocumented history of weight loss. We can see that papulosquamous skin lesions are there. No systemic symptoms except fever and mild lethargy. Systemic examination was normal. There was papulopustular and plaque-like skin lesions all over the body, asymmetrical with rough surface area. Some lesions are present with crust-like appearance. Lesions are painful in nature and associated with itching. So what should be our differential diagnosis, Dr. Salendro? Very quick.
So considering the history of chronic illness, along with the pattern of rash, and there is evening rise of temperature and weight loss. So there are very few differential diagnoses. First, in my mind, it comes is it a cutaneous tuberculosis in the form of lupus vulgaris or your tuberculin. But leishmaniasis also can be possible, and fungal infection, but in fungal infection the pattern of the rash is different. There is central clearing And can it be disseminated impetigo? But considering the history, impetigo is actually the acute illness. This is a chronic illness. So the first diagnosis is your cutaneous tuberculosis. Then there may be some autoimmune autoimmune disease like your sarcoidosis, psoriasis, or there may be skin malignancy. So these are the differential diagnosis in my mind, sir.
Definitely. So there are three types of broad categories of differential diagnosis: can be infectious causes, autoimmune and inflammatory causes, and some malignancy or drug races. These are the investigations. You can see that the CRP is on high, the platelet is normal, then high, total counts are normal, and ESR is high. No other clinical, no other significant features in the blood reports. So what next investigations you want to do, Dr. Rupa?
Yeah, from the above, the investigation has been done, not very much informative. So I like to go to see the X-ray if you're thinking of tuberculosis, and we might get some primary focus in the lungs, and we'll do TST. So it will give some informative, like some supportive evidence, not the confirmatory, but most confirmatory evidence we can get from skin biopsy.
Okay. So definitely in this case, the skin is the main problem that is causing problems. So skin biopsy is very much important. So did the chest X-ray? Chest X-ray showing some mediastinal lymph nodes, and the skin biopsy also report histopathology are suggestive of cutaneous tuberculosis or papillonecrotic tuberculosis, and TST was positive. So this is a patient that presented the fever, and the skin biopsy is suggestive of tuberculosis. So what else you want to do? Directly you want to start ATD or do you want to do something?
Okay, so already we are getting some hint that this is going towards TB, but we want to confirm it microbiologically, like according to the NTP guidelines, we'll have to get a microbiological diagnosis, not only for the diagnosis per se, but also to know whether we are dealing with resistant or sensitive
Exactly.
TB. So the skin biopsy sample should be sent for a CBNAT, should be sent for MGIT, and further we have seen lesions on the lungs, so we can also send a gastric lavage for the AFB staining, CBNAT and MGIT.
So most important part is that not only the histological diagnosis of tuberculosis, you need to demonstrate the microbiology. So for microbiological confirmation, you can send the histopathological specimen for CBNAT, but you have to send in the normal saline. But most of the cases have been sent to the formalin, so we cannot do a CBNAT, like in these cases. We have sent in the formalin, so we are not able to do CBNAT in the skin biopsy specimen. So went for a AFB and CBNAT for the sputum and gastric lavage, and it came out to be negative. So diagnosis is clinical diagnosis of pulmonary tuberculosis with cutaneous manifestation was done. CT thorax was done, that's showing the necrotic lymph nodes, further suggestive of the diagnosis. And ATD was started according to NTP guidelines. So it's a take home. TB can cause everything except pregnancy. So case 3, the 17-month-old baby girl admitted with complaints of high grade fever for 3 days, cough and cold for 3 days. On examination, he was febrile, he was desaturating, saturation was 82%, and chest X-ray showing this. So what should be your clinical diagnosis with these features of fever, cough, distress, and this chest X-ray? Dr. Salendra.
Yeah, from the history of fever and cough and cold, along with tachypnea and tachycardia, with low SpO2, the first diagnosis come in mind that this is some acute respiratory infection. And from the X-ray, there is pleural effusion and right lower lobe consolidation. So this is acute severe pneumonia is my first diagnosis, according to the findings.
So definitely the diagnosis should be a community-acquired pneumonia and some parapneumonic effusions. So they started the patients on meropenem, teicoplanin and flucloxacillin. USG-guided pleural aspirate has been done. It is exudative in nature, almost pus-like consistency. You can see it is almost pus coming from the pleural space. Cell was 3000 with 68% of neutrophil and 32% of lymphocytes. Sugar was almost undetectable. Protein was 3.1 and pleural CS was negative. So it did a PCR from the pleural fluid. It revealed a Streptococcus pneumoniae. And we are already on these antibiotics, meropenem, teicoplanin and flucloxacillin. Dr. Rumab, any modification of the antibiotics?
Yes, so Streptococcus pneumoniae, so I'll start definitely ceftriaxone. It's very good penetrations, oral like not parenteral penetrations. It's very good effective drug, so I'll continue this, and flucloxacillin I'll discontinue. And teicoplanin is not like not first line of drug when there is severe beta-lactamase resistance, and there is severe and some local antibiotic resistance pattern, then we can start, otherwise ceftriaxone will be okay.
So we have started to ceftriaxones, and as the pleural space, we have put a ICT and streptokinase has been given. But over the few days, there are a few changes in the blood report. You can see the hemoglobin was gradually falling, the platelet is falling, CRP is stuck, urea is increasing, creatinine is increasing. We are not giving any nephrotoxic agents. And the peripheral blood smear, we got something. So Dr. Kaustav, the patient is not improving, fever is there, we are getting some things.
If you see the whole case scenario, it begins with the pneumonia, which is basically diagnosed as Streptococcus pneumoniae, but now later on involving the renal system in the form of high urea creatinine, and along with that in the peripheral blood film, you are seeing cystocytes. So you all know that Streptococcus pneumoniae can cause D- type of HUS, so you have to keep a possibility once there is anemia, thrombocytopenia, along with cystocytes in the peripheral blood smear. And along with that, you are getting renal parameters getting deranged, and urine output is also getting deranged. So definitely this is an atypical HUS, possibly D-.
So definitely, here the pneumococcus is presenting with a very rare complication of HUS. So you can see the blood reports. So there was a worsening of sensorium and respiratory distress and led to mechanical ventilations. We have started the sled, required 6 cycles of sled, extubated on day 16 and discharged on day 12. So Dr. Pratiksha, how pneumococcal HUS is different from others and why plasma exchange is contraindicated in pneumococcal HUS?
So there are different causes of HUS as we know. We have infection induced, we have secondary causes, and we have atypical HUS caused by complement deficiencies and everything. But in case of pneumococcus, what happens is pneumococcus secretes neuraminidase enzyme, and this neuraminidase enzyme keeps removing the sialic acid residue that coats the RBCs and endothelium. So once these residues are removed, the T antigens that are normally present on the RBCs, they get exposed. And our blood already contains anti-T IgM antibodies. So what happens? These antibodies then attack the antigens and keep destroying the RBCs. So it is an immune-mediated hemolysis. So if we are doing plasma exchange, what happens in plasma exchange? We are putting plasma from outside, donor plasma. Again, this donor plasma, like any other plasma, will be rich in these antibodies. So the more you put donor plasma inside, again, new amount of antibodies you're introducing, it is further going to aggravate the situation and aggravate the features of your HUS.
Definitely. So it is, pneumococcal HUS is a different pathophysiology. It's not typically of a complement mediated or antibiotic mediated atypical HUS. It's not typically of a cigatoxin mediated HUS. This is totally different ballgame. So pneumococcal HUS is immune mediated, giving plasma fuels the fire. So what's the take home? Behind a simple pneumonia, something may lie silently. Recognize it today or pay the price tomorrow. We have seen many patients that's presenting with the pneumonia, and as the time passes by, it unfolds itself to some other complications. Case 4, the 8-year-old boy, low to moderate fever for last 7 days, pain abdomen for last 5 days, tender lump just below the xiphisternum. You can palpate the lump. Total count was high, neutrophilic leukocytosis, CRP was high, and USG showed the abscess in the left lobe of the liver. So MRI has been done. You can see that liver abscess is there, and it's all just below the skin. It's so much superficial. You can see the liver abscess is there. So what empirical antibiotic you want to start, Dr. Sailendra?
Yeah. So considering the pattern of the liver abscess, it is in the left lobe, solitary. The first diagnosis comes in my mind is it an amoebic liver abscess? But you cannot rule out pyogenic also. But usually in pyogenic, the total count will be very high and there are multiple abscesses. So considering both, I will start third generation cephalosporin, because most of the liver abscess, if it is pyogenic, it is due to Klebsiella pneumoniae, E. coli or Streptococcus or Enterococcus species. And in these cases, the third generation cephalosporin, ceftriaxone or cefotaxime will work good. I will add metronidazole, though it is not, if it is not amoebic also, it will cover the anaerobes. So my first choice of line of treatment will be third generation cephalosporin plus metronidazole.
So definitely in most of the cases of liver abscess, we start empirically with third generation cephalosporin, ceftriaxone and metronidazole. And if there is any high suspicion of staphylococcal infection, means some other focus is there, some pneumonia is there, skin infection is there, some soft tissue abscess is there, patient is immunocompromised, previous hospital admission is there, then we need to add some anti-staphylococcal therapy. So in this case, we started with cephalosporin, ceftriaxone and metronidazole. So what should be your next course of action, Dr. Rupam?
So already diagnosed is liver abscess. So my first priority will be, I'll put a ultrasonic catheter and drain the pus, and I'll send for a laboratory examination whether who is the culprit of this abscess.
So as this liver abscess is a bit large, sometimes we need to put some drainage So you can do two types of drainage. Directly you can drain it by putting a needle under USG guidance, or it's a large abscess with a big cavity, we have to put a pigtail catheter. In smaller abscess, you can just continue with antibiotic. So you have you can see the pus came out, ultrasound guided aspiration has been done. And to our utter surprise, we have sent the pus for culture grounds and everything came out to be negative, but the pus revealed a Streptococcus pneumoniae as a causative organism for liver abscess. So my question, Dr. Pratik sir, is it common Streptococcus pneumoniae causing liver abscess?
Okay, so we do come across liver abscess in our IPD practice, and most of the cases we have seen that it's caused by Staph aureus as the commonest gram positive organism. Among gram negatives, you do get E. coli, Klebsiella, and very rarely we have seen like the amoebic liver abscess. Strep pneumonia otherwise is not a very commonly seen organism for liver abscess.
So Streptococcus pneumoniae causing liver abscess is very, very uncommon. Only a handful of case reports available all over the world. So take home is one pathogen, deadly pneumococci, many faces, same organism with different battles. We can speak the whole day on the different aspects of pneumococcus. How can they present in the pulmonary as well as the extrapulmonary symptoms? It can present in many ways, from liver abscess to osteomyelitis to meningitis. Anything can be possible by pneumococcus. And we have seen a huge surge of pneumococcal diseases, especially in older children, those who are unvaccinated in recent days. In case 5, this 4-year-old girl, dengue fever with capillary leak with compensated shock. Managed with IV fluid boluses as per protocol. Stabilized, but fever persistent beyond day 8. That is a bit unusual for a dengue fever. On day 8 of illness, she developed a fever spike of 106.8 degree Fahrenheit, followed by GTCS and altered sensorium. So almost crashed in the ICU. He has been intubated and ventilated, loaded with AD. Within couple of hours, we got that she developed a refractory status epilepticus. So investigations over the last 8 days, lowest platelet was 42,000, now it is 98,000, so platelet is increasing. PCV was 49, now it is 39. SGPT, SGOT is also stabilizing. Highest ferritin was 13,000, initial day 2, now it is 5,600. And at present there is a mild coagulopathy without any evidence of bleeding. What happened and what further investigation you want to do, Dr. Kaustav?
Okay, if you see that initial presentation, dengue was responding, then subsequently having something like encephalopathy and then requirement and then status epilepticus, and which is refractory. So my possibilities will be deteriorating dengue after 7 days is one of the possibilities, whether secondary some infection is causing because this child is having fever, whether dengue itself is causing the encephalopathy by causing encephalitis, that is an expanded dengue syndrome possibility. Third possibility is as because there is a drop in the hematocrit from 49 to 39, so dengue bleed is there or not, that needs to be looked for. And any viral infection like dengue can cause autoimmune involvement of the brain in the form of ADEM. So my possibilities are these 4 and I need to evaluate for that.
So the fall of this hematocrit over last 3 or 4 days is not a sudden fall from 49 to 39. So for that we completely excluded, there was no bleeding manifestation, we have excluded the bleeding, CNS bleeding. So we have diagnosed that it's a dengue with some sorts of CNS involvement. So we have done an MRI brain that revealed that hemorrhagic infarct in the pons, right parietal cortex, few areas of the thalami, but not whole thalami or basal ganglia is affected, few areas of thalami. Bilateral parietal subcortical cerebral white matter and bilateral central semioval. So mainly the lesion concentrated 90% in the pons and the white matter, subcortical white matter. Deep grey matter involvement is very less, all minimal. So Dr. Pratik sir, what is your diagnosis and how we will going to treat her? The MRI revealed mainly white matter involvement.
So this is already, till now we have realized that this is a case of dengue encephalitis. MRI is showing florid features of bleed. So this is basically an acute hemorrhagic encephalomyelitis, which is a very rapid progressive case of ADEM. Like the most fatal, if you see the spectrum, it is on the more aggressive side. And here the treatment of choice is IV methylprednisolone and IVIG.
Yeah, definitely. Dengue fever is per se non-neurotropic viruses, but we have seen all these types of presentation of dengue All this. We have got dengue encephalitis, or got dengue meningitis, dengue-induced encephalopathy, nothing is there, but patient is totally encephalopathic, edema, polyneuropathy, mononeuropathy, intercerebral hemorrhage, GV syndrome, and ANEC. So, dengue can cause two types of immune-mediated CNS disorders. One is a classical edema, a less intense or subacute form of disorder, classical of edema. The patient presented with the dengue, completely recovered, went home, then again come with some neurological problem that is more subacute in onset. And another, like this case, a more acute and fulminant demyelinating disorders named AHLE or HM. So, the confusion is there that what is ANEC and what is AHLE. So, AHLE is the acute hemorrhagic leukoencephalitis like this case, and ANEC is the acute necrotizing encephalopathy. The core pathology, both are the pathognomic CNS disorders caused by the dengue, and the core pathology is different. In AHLE, there is a demyelination hemorrhage, and this is mainly necrosis. The area of involvement is mainly the subcortical white matter, and here is mainly gray matter. Mechanism here is the autoimmune, here is the cytokine storm. Relation with the severe variety of area is not related to edema. Course is hyperacute, fulminant, it's also same. Triggers is post-infectious on immune, it's viral, influenza and dengue. MRI hallmark is asymmetric white matter lesions with hemorrhage. It's a symmetrical thalamic necrosis, not only lesion necrosis. And treatment is always same, but the prognosis of AHLE is excellent if you pick up it early and treat with IV methylprednisolone IVIG, but it's a bit guarded prognosis when you get ANEC. So don't confuse between AHLE and ANEC. The pathophysiology is different, though the treatment is same. So learning points, though not neurotropic, dengue may involve CNS either by direct infections, dengue encephalitis, or immune-mediated edema or HLE. HLE is a fulminant demyelinating storm, ANEC is a necrotizing cytokine storm. Similar severity, but entirely different biology. So case 6, the 3-month-old male baby presented with cough and cold for 7 days, low-grade intermittent fever for the last 5 days, respiratory distress for the last 2 days. Was admitted at a PICU outside for 1 day and required HHFNC, referred to us. The birth history, 34 to 36 weeker, 1.6 kg, elusius, cried immediately after birth. There was a history of neonatal sepsis. At that time, LP was normal, admitted in NICU for 8 days, culture was negative at that time. So on admissions, there was severe respiratory distress with subcostal and intercostal retractions, saturation was very low, chest refill, bilateral wheeze, crepitations, CVS was normal, weight on admission was 2.7 kg, that is below 3rd centile, ABG refill, type 1 respiratory failure. So, it was put on HHFNC, but in spite of highest settings, had to be shifted to NIV for increasing work of breathing. So, this is the initial chest X-ray. An infant presenting with a cough, cold, fever, and respiratory distress. And the blood report revealed a moderately high CRP, a bit lowish platelet, and a normal total count. So, what is the provisional diagnosis and how will you treat him, Dr. Rupam?
So, going through the all clinical courses like investigations and X-rays, I think this is a 3-month-old baby, not gaining weight, so many problem in the neonatal period also. So, I think this is a severe acute respiratory infections with type 1 respiratory failure. And I'll prefer to give the ceftriaxone because it will cover streptococcus, and I'll go for some Erythromycin also, it will cover the atypical pneumonia also.
Exactly. So, though the chest X-ray a bit hairy opacities are there, not typical lobar consolidation has been seen. So, this patient has been started on ceftriaxone and clarithromycin, the upper respiratory biofir sent, it came out to be negative. When the next 48 hours, something happened. There was a refractory hypoxia, he has been intubated and ventilated, refractory hypoxia, it's been prone, and ultimately on day 3, you can see that almost bilateral whiteout lung has been put on high frequency oscillatory ventilation in our ICU. So you can see the blood reports over the day 3, day 6 and day 8, the hemoglobin was falling, total count was normal, platelet was falling, CRP just mildly elevated, there was transaminitis. So he could not be weaned till day 8, and we sent the biofire as well as the culture, everything came out to be negative. So, as the patient was not responding to ceftriaxone or clarithromycin, there was no evidence of secondary sepsis or severe bacterial infections. We have upgraded the antibiotic to meropenem and vancomycin, still the patient was not responding. Dr. Kostov, what are the possibilities? Day 8, refractory at days with this clinical feature?
So if you see this child, the respiratory component, which is pneumonia, gradually getting worse, and it becomes ARDS. Now we need to go for high frequency oscillation ventilation also. And then Bell biofire is negative. So possibility of the bacterial infection, and the most of the biofire, I think diagnosing that virus is also ruled out. So if you see, this child is 34 weeker, and it's 3 months, although in the correct age, but post-conceptional age is around like 1.5 months. So possibility of immunocompromisation is already there. So I will look for those viruses or bacteria which is not covered by the Bell. So there are certain viruses we can think of, like CMV virus, Epstein-Barr virus. So we usually look for those viruses separately.
So on day 9, I developed a pseudomonal VAP, that culture proven, recovered from that on day 14, but still could not be weaned. We have not yet identified the primary pathogen. So what next, Dr. Pratiksa? We are at a loss at day 14, intubated.
So we see that already this baby is having a stormy course from the beginning itself. 34 weeker, preterm, low birth weight of 1.6, and already day 14, still not able to wean. Most of our examination, like our blood reports are not that suggestive. There's diffuse infiltrates on the chest X-ray. There is thrombocytopenia, transaminitis. So again, we'll not think of the bacterial now, we'll think of certain viral infections. And like sir has already mentioned, think about certain viruses in case of immunodeficiency if you're thinking. So I will again here think about CMV. Why? Because it is involving your lungs as well as the liver. So in that case, we can think of CMV and send the blood PCR for CMV.
So at that point of, there is a strong suspicion of CMV. So if send a urine CMV, PCR was quite high, blood CMV was also positive. So diagnosis was severe CMV pneumonia. So now, what other investigation you want to do, Dr. Pratiksa? Very quick.
So again, because this is a case of, a very different kind of virus that we are getting in a child who has such a stormy course, immunodeficiency is on the cards. We'll work up this case for immunodeficiency. And at the same time, we'll also need to look up the eyes. We have to see if there is any CMV retinitis in this case.
So I have seen a deficient disseminated CMV. We need to think about the cellular immunity responses. So HIV has been done, PCR, that has been negative. Flow cytometry has been done, CD3, CD4, all came out to be normal. Eye checkup revealed a classical CMV retinitis. Unfortunately, I don't have the picture at this moment of time. So diagnosis is a disseminated CMV presented as CMV pneumonia. IV ganciclovir has been started, followed by oral vancomycin, extubated on day 21. NIV went to HHFNC, then to nasal cannula and primary to room air. Could discharge the patient after 7 days of extubations. That I don't know actually, I need to take. There may be some issues. Most probably IUGR was there, the liver cell flow was there most likely. So not responding pneumonia in a kid, especially with transaminitis which failure to thrive, think of CMV. If I get time, I can show you the series of CMV, disseminated CMV and CMV pneumonias we are getting in our eyes. We are almost getting 8 or 10 cases in the last 1 year, by the CMV presenting in a very atypical way. Now going to the next case, case 7, 5 months old baby boy, born of a non-consanguineous marriage, presented with fever and cough for 2 days duration, fast breathing and chest injuring for last 1 day, sick looking, tachypnea, impending respiratory failure, transferred to PICU, trial of HHFNC, failed, intubated, routine blood CS, culture was negative, BAL PCR suggestive of a enterovirus or rhinovirus. Very difficult to ventilate and wean, issues with both oxygenation and ventilations, needed very high ventilatory settings and proning, not able to wean on day 7 of mechanical ventilations, no secondary sepsis. So rhinoenter, whatever it may be, being believed to be an innocent virus, how common is the severe ARDS associated with it? Dr. Kostov.
So working in a tertiary PICU, we are getting lots of cases of this rhinoenter virus, and it's not anymore as innocent virus, or even the other viruses also. And once upon a time, adenovirus was thought of very innocent, but then it seems to be different. So what happened is that a virus which is innocent earlier, every epidemic, it changes its character. So one virus is causing typical like innocent, later on it becomes causing lots of ARDSs like adeno. You have seen adeno epidemic in 2019. Similarly for HRE, in last few years, what we found in last 1 or 2 years, that HRE is mostly behaving like causing asthma-like presentation. In infant, it causes like bronchiolitis, and sometimes it requires lots of support, respiratory support in the form of mechanical ventilation also. So for me, it is
exactly. For our PIs with the same experience for the last couple of years, if you take about the invasive mechanical respiratory support, HRE is the commonest virus. And if you take it at HHFNC NIV plus invasive support, RSV is the commonest. So ultimately, it has been extubated to NIV on day 14, of NIV on day 18, of HHFNC on day 24, of nasal cannula by day 28, went home on day 31. So a prolonged recovery. So-called innocent virus, severe ARDS, so many days of ventilation, prolonged recovery went on day 31. But the story does not end here. The same baby on second admissions after 2 months. Now he's 8 months. Again, he developed cough and sudden onset respiratory distress, received nebulization and some multiple antibiotic in peripheral hospitals. Further worsening of respiratory distress and transferred to our hospital. We saw that there's no weight gain in last 2 months. There's tachypnea, intercostal and subcostal retraction and bilateral crepes. Initially managed NIV, but later required invasive ventilations and ultimately high frequency oscillatory ventilations. Again, the chest X-ray revealed this bilateral opacities, and again the BL-PCR revealed same thing, enterovirus, rhinovirus. So this time also further difficulties in weaning, stuck in HFOV for next 7 days. First time there was no requirement of high frequency ventilations. This time it feels more difficult. Stuck on HFOV for 7 days.
So can we just go to the slide before this? So here we have a baby who is by this time having second admission, poor weight gain, requiring invasive methods of ventilation. By now the blood picture has started showing anemia, neutropenia. So again, when you have such patients who are coming to you with recurrent infections, with failure to thrive, requiring multiple hospitalizations, again, keep in mind the 10 warning signs as given by the Jeffrey Model Foundation, and we again need to think about an immunodeficiency over here. And again, we'll have to work up whether this is a case of immunodeficiency.
Definitely. At this moment of time, you need to suspect the immunodeficiency because disease starts at around 6 months and then recurrent infections. So blood and urine culture showing no growth, absolute lymphocyte count was normal, HIV DNA PCR was negative, TB workers was negative. IgE, IgG, IgA, both were low, IgM level was normal, CD3, CD4 was normal, CD19 was low, lymphocyte subset analysis was normal. So what should be your diagnosis, Dr.
Yeah,
Dupont?
going through all investigations, like almost all immunoglobulins are low except IgM, and B cells are low, they're low. So this is definitely some immunodeficiency disorder. So I think this is B cell defect or humoral deficiencies.
So definitely there must be some B cell defect or humoral immunodeficiency. So what should be your next course of action, Dr. Sailendra, for establishing the further diagnosis?
In B cell deficiency, there is no production of antibodies. So we have to give ready-made antibodies in the form of IV immunoglobulin. So this is the only solution.
So you have given IVIG, this child, a bit higher dose. So there is remarkable improvement after IVIG and extubated on day 21 after 5 days of IVIG. So what other investigations you want to send, Dr. Kostov?
So yeah, if you see that there is a humoral antibody and I think humoral immunodeficiency as well as hyper IgM is a possibility because this child within the 1 year presented twice and 2 times it was a severe pneumonia leading to mechanical ventilation and HFOV. So we got some cases like this and ultimately it turned out to be a case of hyper IgM syndrome in those. So I want to go according to this and
so
genetic sequencing will be.
So if you see the immunoglobulin levels, all the immunoglobulin levels was low except the IgM. So we sent the exome sequencing and it was revealed that hyper IgM syndrome was there. It's the X-linked hyper IgM syndrome. So diagnosis is the hemizygous mutation of CD40 ligand with X-linked recessive inheritance. Sanger sequencing has been done on the parents and diagnosis has been confirmed. So this is nothing but a type 1 hyper IgM syndrome. Allogenic hematopoietic stem cell transplantation done at the 1 year of age, and even after 8 months of follow-up, the kid is now doing well.
So yes, one thing like this age is very important. 6 months after because maternal antibody went off. So age is very important.
Very important, exactly. So take home, benign bug, severe manifestations, think of inborn error of immunity. So case 8, 3 years old kid, fever for 7 days with UTI symptoms and sore throat with cervical adenopathy. Bilateral enlarged tonsil with follicles and membrane. Brassy, barking and hoarse cough. Started having respiratory distress on day 7. There was severe stridor, shifted to PICU and became hypoxic. So started with just a tonsillitis, then severe stridor, hypoxic, PICU. So what should be a provisional diagnosis, Dr. Pratik sir?
So the features are suggestive of an upper airway obstruction, and that too a severe form of upper airway obstruction that is now going into an impending respiratory failure.
So definitely this is a severe upper airway obstruction and impending respiratory failure. This is not clear, but this picture has been taken when I was intubating this patient. You can see the membrane You can see this membrane, this eulous membrane that is starting from the pharynx, then going inside the tonsillar pads, going towards the larynx, through the laryngeal inlet, is going inside the trachea. Okay. There was no time to do a bronch, so just a quick photograph has been taken during intubating this child. The intubation was nightmare almost for this patient. This patient has been intubated, and after intubations, we got there's a collapse in the left lung. So we have intubated this kid, put on the ventilations. So what should be your next step, Dr. Kostov?
So this child presented with severe respiratory distress with upper airway obstruction, and then it is a severe laryngotracheal bronchitis with a thick membrane over there. So possibility will be obviously bacterial as well as virus. But having said that, it's intubated, and if you see the chest X-ray, it shows that there is a left-sided collapse consolidation and the mediastinal shift to the left side, as along with the right-sided is hyperinflated. So my possibility will be to identify the bugs, and we'll get that well as well as the secretion for investigations.
So the bronchial valve lavage almost revealed pus. It's not like pus. Actually, as we are suctioning, many membrane-like things are coming back. So the valve revealed adenovirus. The other things for diphtheria, streptococcus, staphylococcus all came out to be negative. So this bronchial valve lavage revealed adenovirus. So diagnosis is that acute adenoviral pharyngitis, tonsillitis followed by acute laryngotracheal bronchitis, and many other family members in the family has been suffered from the sore throat in the recent period of time. So acute febrile pharyngitis is the most common adenoviral infection in the school going children, but sometimes it can give rise to follicles over the tonsil, like acute follicular tonsil, and we got, in my experience, I got 2 cases of acute severe laryngotracheal bronchitis associated with adenovirus. So what starts as a benign sore throat can become an airway emergency. Adenovirus demands respect. So case 9, 7-year-old girl, history of fever for 3 days, vomiting and loose stool for 2 days, 1 episode of GTCS on day 3. Post-ictal test, GCS 9/15, severe dehydrations, hepatomegaly. So what should be your provisional diagnosis, Dr. Rupam?
Yeah, fever, seizure, altered centronia. My first diagnosis will be acute encephalitis syndrome. So whether we have to find out whether this is due to viral, bacterial, or autoimmune, or something parasitic. So we have to find it out.
Very straightforward. Fever, altered sensorium, seizure, acute encephalitic syndrome, and there was some diarrhea. So we thought that is enteroviral acute encephalitic syndrome, because most of the times enteroviral there are some episodes of diarrhea. So course in the PICU, routine investigation sent, including fever workups, ceftriaxone, doxycycline, acyclovir has been started. At 5 hours of admission, child had another episode of GTCS. At the time, CBG was low, so hypoglycemia corrected, and again the sensorium became a bit better. So though the initial presentation was suggestive of acute encephalitic syndrome, but sensorium was improving in between. So I have started injection levetiracetam. So blood reports revealed hemoglobin was 8.1, platelets was 90,000. CRP was 120, PBS showing tropozoites and gametocyte form of P5X, and P falciparum was negative. And sensorium was not that bad, GCS around hovering around 10, 11. So we are quite confused that what we are dealing with. Is a Vivax malaria is simply febrile convulsions, or it's a complicated falciparum malaria is not able to detect, or complicated Vivax malaria. So what should be your next course of action, Dr. Sailendra?
Yeah, from the course in the PICU and from blood investigation, and it shows Vivax. Though in Vivax, severe malaria is unlikely, but still I will consider it as severe malaria. So along with that, I will start RT-PCR as a first line to get immediate response.
So it's better to take it as a severe malaria and start with artesunate. But unfortunately, the patient admitted in the night, and the resident could not speak to us, and started on tab chloroquine for this patient. So after 10 hours of hospitalization, sensorium further depressed. Because when I asked the resident why you start chloroquine, he said, sir, the altered sensorium was due to hypoglycemia. After correction of the hypoglycemia, the sensorium was a bit better. So after 10 hours of hospitalization, sensorium further depressed from GCS 11/15 to 8/15. Now we got the other reports, like LFT revealed transaminitis, hyperbilirubinemia, urea creatinine was high, INR was deranged, it's in hypotensive, inotrope has been started, intubated, ventilated. So what should be your next course of action, Dr. Pratiksha?
So we see that this patient was started on tablet chloroquine, but after that also there was further deterioration and other organ systems have started getting involved now. The liver is, the enzymes are sky high over there, the kidneys are fried, so this is complicated Vivax malaria. Normally with Vivax we don't see, it is mostly we see it with falciparum, but Vivax can also cause complicated malaria. So in this case, it's better to switch over to IV artesunate.
So IV artesunate has been started. The patient developed modes with Vivax malaria. Vivax, benign malaria, benign. malaria. So anything to know, Dr. Kostov?
I think once it is a severe malaria, need not to think about that whether it's a vivax or falciparum, treat it like a mixed infection. So sometimes it is maybe associated with the vivax, but it may be hidden and it may not be detected. So in that case, we need to continue with the severe malaria protocol, and we need to go for IV artesunate that already been mentioned. But along with that, definitely as it is in AES, we have thought of the co-infections like even your scrub typhus or dengue or other bacterial infection also, and accordingly you need to cover it up.
So definitely two things, that hidden P. falciparum must be excluded before stamping or labeling this case as a complicated vivax malaria, and co-infection has been excluded. So co-infection has been excluded. Another 2 rounds of smear and antigen did not reveal any Plasmodium falciparum. So fever subsided after 3 days of artesunate, and but sensorium was fluctuating. What next, Dr. Rupam?
Okay, so fever is subsiding is good things, like not after giving artesunate, but sensorium is fluctuating, that we have to keep in mind, like we have to little bit worried. So we have to go for the find something problem in the CNS, so we have to do the MRI brain, and we have to repeat the blood infection, including the coagulation profiles. We have to find out some bleeding might be there.
So as the sensorium was not improving, I had to do MRI brain, and this MRI brain revealed that multiple hemorrhages in the brain parenchyma, you can see. But fortunately, there was no subarachnoid bleeding and no intraventricular bleeding or midline shift. So complicated vivax malaria with, vivax malaria with intracerebral hemorrhage, is it common?
No, it's not so common.
Not common. And is there any role of exchange transfusion in responding severe vivax malaria? Because there is a concept still not in vogue at that much of time, but in severe Plasmodium falciparum malaria not responding, we had to do exchange transfusion. We have done twice. Not at this moment we are not doing, because we are not able to see that much of severe falciparum malaria nowadays. So definitely extremely rare. And role of exchange transfusion in severe vivax malaria, no role, because it is not associated with hyperparasitemia. So parasitemia is usually low, and pathophysiology is not driven by high parasite burden. So take home, severe vivax malaria is a clinical wolf in a sheep's clothing. Recognize early and manage as falciparum. Case 10, 8 years old girl, fever for 5 days with cough, diplopia for 3 days, neck pain and lethargy for 3 days, altered sensorium for 1 day. GCS was E2, V4 and M4. Neck rigidity was present, Karnick sign, Brudzinski signs was present, deep tenodex plexus exaggerated. So total count was high, urea creatinine is altered, CRP was high. So definitely acute encephalitic syndrome, meningitis. So CSF study has been done, it revealed 435 scales, protein was 386, glucose 41, CVNAT negative, CSF biofran negative, gram stain negative, Janssen stain negative. So in view of poor sensorium and features of West ICT, girl has been intubated and mechanically ventilated, started on meropenem, doxycycline and vancomycin and acyclovir. Developed drug-induced AKI, vancomycin omitted and gradually started. MRI brain or suggestive of meningoencephalitis. The child was not responding even after 3 days of IV antibiotics. So for 24 hours of IV antibiotic, but he got that the elder sister of the family had some pneumonia-like features that got outside treated with azithromycins. So we sent a Mycoplasma IgM, came out to be positive. And this doxycycline actually started after 24 hours of admissions. Child clinically improved and extubated after 3 days. So how common is Mycoplasma encephalitis, Dr. Sailendra?
Actually very less. Some studies says 5 to 15%, but overall 0.1 to 0.2% of your Mycoplasma encephalitis, especially in adolescent and school-aged children.
Okay. So I'm not going to this slide because there are some other twists for this case. So there is a decreased visual acuity post day 2 extubation, progress to absent PL and PR within 24 hours, while sensorium became almost normal. So you shifted to the word, sensorium was normal, but sudden vision also was there. So what's happening here? What will be next course of action, Dr. Kostov?
So if it is a sudden onset and then once after improvement there is a deterioration, I would like to ask 2 questions. One is that where is that IgM, this Mycoplasma positive? Is it in the CSF or in the
blood?
It's in the blood. Okay. So if you see the Mycoplasma encephalitis, most of them there is a 2 types of presentation. One is more than 7 days of prodrome followed by Mycoplasma IgM positive in the blood, and along with that Mycoplasma IgM negative in the CSF. The prognosis is something different. Whereas if it is like CSF Mycoplasma IgM positive and Mycoplasma IgM is negative in the blood, and then the prodrome is less than 7 days, the prognosis is something different and they have a sequelae. So possibility of ADEM is high on the curve, and I need to look for the MRI pictures.
So VP revealed demyelinating type of bilateral retino-optic pathoid dysfunction, suspecting optic retinitis, MRI was done, revealed bilateral vitreoretinal detachment, query. with fluid collections, mild retroviral edema with optic nerve sheath distensions. USG B scan suggestive of bilateral exudative choroiditis with possible choroidal retinal detachment. So we are quite confused, retinal vitreous detachment. So toxoplasma, TB, syphilis and VKE syndrome ruled out. So we sought the opinion of an expert retinal surgeon. He revealed that OCT has been done. It revealed retinal vasculitis with mild vitritis. So 3 days of pulse methylprednisolone initiated, dramatic response, diagnosed as a case of para-infectious retinal vasculitis. So take home, in Mycoplasma, it is often the immune response, not the organism, that drives the disease. It's not just an infection, it's an immune trigger. I just will take 30 seconds. This is nothing a case of hepatitis A infections that are positive for hepatitis A IgM that presented conservatively, improved over 48 hours. Next, then 48 hours, develop altered sensorium and encephalopathy. So hepatitis A developed altered sensorium encephalopathy, suspect of hepatic encephalopathy. But we can see that ammonia was normal, INR was normal. That was very odd. I am not going to the panelist because all this ended time. The patient with hepatitis A is going to hepatic encephalopathy, but the LFT and INR has improved and ammonia is also normal. So we did a MRI brain, it revealed nothing but a demyelination in the whole MRI brain and spine. So finally, it's an edema, again post hepatitis A. So started with IVIG and steroid, and we can see what happened post steroid. The child has improved a lot. So take home, the virus may leave, but the immune storm lingers. Edema is a neurological ego. Thank you.
Thank you, Prabhash, for an excellent repertoire of cases, and thank you, experts. May I request Prabhash, along with the experts, to please move to the memento counter outside. So now, after the power play round, we have usually the consolidating session. And who else than Bhaskar Shenoy, the academician from Bangalore, academician par excellence. So Dr. Bhaskar will moderate a session on diagnosis of acute encephalitic syndrome, problems and pitfall. And to discuss with him, we have a pan-Indian representation, East, West, Central, South. So we have Dr. K.K. Arora from Central Zone, who is also the Secretary of PIDA, Dr. Sri Krishna Jian from Mangalore, Dr. Vaibhav Patel from Ahmedabad, and from East, Dr. Mihir Sarkar, who is Secretary of West Bengal Academy of Pediatrics. So Dr. Bhaskar, it's all yours.
Thank you, Jaydeep. Good morning. In fact, I will be talking about the diagnosis of AES, mainly concentrating on the problems and pitfalls. We will not talk more about the treatment or management, etc. And there may be some overlap between the previous session and ours. Doesn't matter, but the approach is different. So I have a expert panel. You can see, as Dr. Jaydeep told, we know that the acute encephalitis syndrome is acute onset of fever less than 5 to 7 days with altered sensorium or new onset of seizures excluding simple febrile seizures. So there are, when you approach the case, huge number of etiologies you have to keep in mind, and similarly the history has to be more. So the acute encephalitis syndrome is a syndrome, it is not a diagnosis, mind you, and has multiple etiologies. Why we should talk about AES is that the mortality is high if it is not recognized and treated early, and even if they survive, the neurodevelopmental sequelae is quite high to the tune of even about 50%. Some series it is little more than that. It's a major public health problem, and definitely such a condition needs early rapid diagnosis and empirical treatment, because initially you may not be able to give a perfect diagnosis and then treat it. So empirical we have to start, and then which has a high mortality and morbidity. This is the usual causes. It can be infectious or non-infectious. In infectious you have JE, which is more epidemic AES, and HSV, which when it is sporadic. Even rarer non-neurotropic viruses like dengue also can cause, Then in geographically, we can have rickettsial, scrub typhus, where these infections are very rampant. Non-infectious cases like ADEM or NMDA, all those things can occur. Of course, we all know that these are available in any of the standard textbooks. But the core features are that the fever, altered sensorium, seizures. So, as I told, the huge amount of those etiologies can cause. So, sometimes in the clinical examination, you may have some kind of what you call the clues. One is if there is a focal deficit, probably you are dealing with the HSV, so your way of diagnosis or investigation should point towards that. Sometimes TB, though TB doesn't manifest, rarely it manifests as a acute, not commonly. Movement disorders, if it is there, either it could be JE or autoimmune encephalitis, rashes in dengue or rickettsial, and sometimes, especially in Maharashtra or Chennai or Karnataka, northern Karnataka, this scrub typhus is rampant. We may have to look for Eschar, and behavioral changes, if they present with, it can be autoimmune encephalitis. So the clinical clues are there. So whenever there is a suspected AS, the four more important things. One is the thorough clinical examination, including the history, neuroimaging, analysis of the CSF, and then some of the serology, or some cases PCR. So what are the pros and cons of these? The thing is that there are problems and pitfalls. That's why this topic is given by the team. One is that the common pitfall is that we don't give much importance to the epidemiology, because that is very important. And symptoms are non-specific, as I told, overlap of etiology is there. Sometimes especially these JEs are more common in the rural areas, and there is a delayed presentation. Access to lab is very difficult, and especially the PCRs may not be available on many places. And there is an overlap of over-reliance on single test. For example, in HSV, if it is negative on day one, we should not rule out that, we should not rely on that on the day one. So similarly, there may be a delay in the empirical treatment. So, as I told, the non-specific presentation, epidemiology, overlapping features, missing autoimmune encephalitis, or sometimes there may be co-infection or mixed infections. So with that, the diagnostic facilities are not available. Sometimes we don't repeat the test. When there is a need, we need to repeat test. Just because the first test was negative, you can't keep quiet. So with that background, let us go for a few discussions. The discussions are mainly focused on the diagnostic aspects than other things. So 6-year-old boy, fever of 3 days with the convulsion, altered sensorium. He was febrile, drowsy. Posturing was there, bilateral extensor, the deep tendon reflex were brisk. So, Dr. Patel, what is the, how you approach this case?
Yeah, good morning, sir. So, definitely depending on the history, the 6-year-old child, so age is important. If we keep in the mind that certain viral infections are more common in this age group, a fever of short duration and presented with convulsion. So this, this is like by definition it's acute encephalitis syndrome, and as the child's GCS is 8, so considering according to the pediatric ALS criteria, it's a life-threatening condition. So we have to simultaneously stabilize the child and now assess for further etiological diagnostic agent.
Yeah, there is a huge case. So the infectious and which you have told. So when do you actually suspect JE in a clinical practice?
Yeah. So first I said the age, because like as the age advances, asymptomatic infections in the child generally gives immunity after 15 years of age. So most commonly from 3 to 15 years the JE is more common. Then as it's mostly transmitted by the mosquito, so post monsoon season and the areas where there is a rice paddy farming and livestock are there, the chances of transmission with the Culex mosquito and that intermediate host, they are the more favoring the transmission of the disease.
So age, epidemiology, the background, all those things are very important. So if you look at the diagnosis, then NVBAC diagnosis, the probable and confirmed case, the suspected case is one which is in close geographical or temporal relation to laboratory confirmed case of in outbreak. Whereas the confirmed case is presence of IgM in the serum or in the CSF, fourfold difference in IgG titer in the paired sera, virus isolation which is not practical in the routine practice, antigen detection by immunofluorescence or PCR. So, Dr. Vaibhav, which investigations you will go for? Just don't tell all the routine things, just highlight what is important in this case.
Yeah. So CBC as a basic to differentiate with other causes, then if liver involvement is there for other virus infections like dengue or leptospira or scrub typhus, so LFT I will go for, RFT I will do, glucose electrolytes monitoring, and specific to diagnose JE, I will go for CSF examination.
Okay. So, meantime, we have to give empirical treatment, that is the standard of care. We have to give ceftriaxone, artesunate in a area where their malaria is more reported, otherwise not required. But people have been giving even the doxycycline where the scrub and other things are very common. Acyclovir is one thing that generally as a empiric treatment is given. So, there is a need for empiric treatment in the AES. One is that because it is a neurological emergency. Second is that the treatment and evaluation has to proceed simultaneously. And there is a small window of opportunity between the diagnosis and treatment. This window between diagnosis and treatment is very small. So we have to be very proactive in taking this. There are problems, as I told. One is we don't give much importance to the epidemiology. That is very important. The second is that low cost microbiological tests are not available, and there is mimics are more. The facility for intensive care and neuroimaging may not be there in many places, and delay in coming to the medical care, and most of the times people are not doing lumbar puncture. As I told, lumbar puncture is the most important thing in addition to radiology. So this child came to the tertiary care, and then he was first he was taken the MRI. So, sir, Dr. Mihir, what is your opinion about the thing? Any clue from these MRIs or any further tests you want to do from this?
Yes, so the MRI, the neuroimaging and the serological test and the EEG that are very important to rule to get the diagnosis that will help in the infective encephalitis. Also, there are some entity now is coming with the infection triggered autoimmune encephalitis, the encephalitis syndrome. So this is the para-infectious. So the patient having the fever would look like a infective encephalitis, but they have the distinct MRI findings. So the MRI have a very important role here, not only for the diagnosis but also prompting the treatment. Okay, so here you can see that there is the bilateral thalamic involvement. So the all sequence of the MRI are important. Here you can see that the hyperintensity in the T2 flare images, and if you look at the diffusion restriction, there are some the restricted. So the fluid that is there. So the fluid that is the brightening in the DWI. So this the MRI can help. Also this patient, if there's some you can features of the IT syndrome that is now being is an entity coming out. So there are we can go to the aggressive immunotherapy in this patient who are having the features of like the AESD syndrome or the ANIC. So the MRI will have a very important role, and of course the other investigation that will go over are the serological investigation and the EEG.
So this MRI had bilateral thalamic and left parietal lobe involvement, and similarly there are some other pictures wherein the hyperintensity is in bilateral thalami and left parietal lobe, and these are other pictures where it's symmetrical thalamic involvement. And so the CSF was done later, and CSF glucose was elevated, protein was normal, gram stain and cultures were negative, HSV was negative. Now, Dr. Sri Krishna, what specific tests to confirm JE? Because now you have some clues that it may be JE, because the MRI also gives some clues. So, to confirm, what tests you will do?
We will have to do a CS. Anyway, we have done a CSF. The same CSF sample we will have to send.
Out of these four,
IgM.
which one do you prefer?
CSF IgM is the best test here.
So, why do you say CSF IgM is better, not PCR? Any reason? Why don't you do a PCR if it is available?
Yeah, CSF IgM, basically if it is present, it will tell us the acute CNS infection only, because your IgG can cross the plasma, your IgM cannot cross the blood-brain barrier. So that is more specific.
So, Dr. Sri Krishna says that IgM CSF is better than the PCR in J. That is because the way the immunological response develops, one is that the encephalitis onset, if you can see, by the time the encephalitis starts, the viral load would have started coming down, and then the antibodies would have started already. So, if you can see this particular picture, the CSF, here it is more clear. The viremia is short-lived. The viremia disappears very early, and the serum IgM and CSF IgM starts by the time the viremia comes down. So that is the reason why the PCR may not be very helpful in these cases, and IgM is very useful. So WHO recommends that testing of JV specific in the CSF is very important, which is highly specific for it, and the sensitivity and the specificity is about more than 95%. It can be detected more than 4 days after the symptoms, and if JE IgM is detected in the CSF, it denotes that CNS infection, because IgM is unable to cross the blood-brain barrier. That means if there is high IgM in the blood, that may not be the reason it cannot cross. There may be, the other problem with these things is that the blood IgM, there may be cross reactivity between the other flaviviruses like St. Louis or White Nile virus, etc., West Nile virus. So IgG, as you know, starts later, and it can persist even up to after 30 days, and about 30 days it peaks, and then by 6 months it can persist in the now the next question is, Dr. Arora, now that dengue vaccine is coming to the market in a short period, and these belong to the similar viral groups, do you think that dengue vaccination can have a effect on these antibody measurements?
Yeah, it's very likely, right, because they belong to the same class. So if somebody has taken, say, dengue vaccine, so it will be positive. Now the thing is that we are to see whether we are dealing with, when we are even doing test from CSF and looking for antibodies. So we should test the antibodies in a way which should be giving, say, exactly what we wish to have. So something like sandwiching, if we use the antigen of JE against these antibodies, and if they neutralize that, that will be the best test to detect it.
Okay. So there is a possibility that, because the envelope antigen is the most important thing in the immune response, and that is the target for the neutralizing antibodies. So because it is structurally overlap is there, there may be a possibility that they may interfere with the JE antibody test. And as I told, JE RNA may not be very useful, because as a part of the immune response to JE infection, the neutralizing antibodies are rapidly produced by the time the distinctive clinical symptoms are recognized. And as I told, the viremia in JE is short-lived. The viremia is often of low amplitude. Then sometimes we go for what is called a plaque reduction neutralization test, which is not routinely available, and sometimes it is done to confirm the JE specific neutralizing antibodies. So key takeaways from this case is that we need to have a early recognition and early suspicion, avoid diagnostic delay. So what are the problems and pitfalls from this case, Dr. Vaibhav?
So here, most of the diagnostic agents, they present in the similar fashion in the CNS involvement, like fever, altered sensorium, convulsion. So there is like specific clue to any specific virus is not there in such type of case. Second, sometime in managing the patients, we are forgetting to take in-depth history where they are coming from. So geographical distribution and age-wise distribution, generally we are missing that part. Sometimes the laboratory facilities are not available nearby which can diagnose the test perfectly, and we are starting the treatment somewhat delay, keeping the rationality in mind. Sometimes we are cocktailing therapy, we are not starting early, so that can cause also the delay in the response.
So take care of the epidemiology, do a CSF IgM. So next case, 3 years old, fever of 2 days, had a focal seizure for 40 minutes, and it was CT was done outside. They sincerely started ceftriaxone, acyclovir, intubated, and proceed. How do you proceed, Dr. Mihir?
Yeah, so the child is very sick. So first of all, you have to stabilize the child and then take the detailed history and the epidemiology, the clue, and the syndromic assessment with only the acute encephalitis syndrome or the multi-organ involvement along with rash or the other organ involvement, like that, to take the detailed history. And this patient has the focal seizure here, so the imaging will help in a greater way. So the CTGO is normal, but it may miss, so that we have to go for the MRI, and also have to keep in mind in the early phase of the disease that may not be picked up in the imaging, so that may take later on. So and of course the CSF analysis, after you exclude that there is a no raised ICP or the patient are very unstable, then have to go for stabilization, go for the CSF analysis. And as the patient is having the convulsion continuously for 40 minutes, even after the control of the seizure, there may be the non-convulsive epilepsy seizure. So that the EEG monitoring also be helpful to the lateralization and also for the diagnosis.
Now here CSF is done and it is clear, and it shows 189 cells and 128 red blood cells. What is your inference when it comes to CSF?
Yes, so you can see there are red blood cells.
Do you think it is a traumatic LP?
Don't think, because the specimen color was colorless. That is if you look at the color, that is the traumatic would have been the red. So it is the colorless, and then this RBCs definitely they have to take in a very significant way, and the total leukocyte count is high, though it is neutrophilic, when the monocyte is 25%. So the red blood cell count here, so you have to take up the etiology, so it's called the hemorrhagic encephalopathy, and the patient with herpes simplex virus, that we have to keep in mind.
So if there is a LP which was not traumatic and shows some red blood cells, so probably the clue is towards HSV. Any idea why only in HSV like syndromes there is red blood cells, not in other encephalitis? Any? So
there are hemorrhagic manifestations.
Yeah, it generally causes necrotizing and hemorrhagic lesions in the temporal and the frontal areas, and that seeps into the CSF, especially in this. There may be other condition, but most common condition of red cells in CSF without traumatic LP. So think of, it gives a clue that it can be HSV. So here MRI, as you told, MRI was done and fairly non-significant, and as you told, EEG also was done, and there were some periodic short waves, sharp waves, but not classical of anything. So child continued to have seizure. Krishna, how will you proceed at this stage?
Yeah.
Because MRI is normal, EEG is not showing very classical features, and there is CSF done. Yes.
The important thing here is child is still having convulsion, is convulsing, seizuring. So here, initially maybe the MRI might have done in the early stage. So always you should keep on revisiting our symptoms, revisiting the baby. So here we'll have to again think and again rework on our diagnosis. Only soft sign is EEG having sharp spikes. So here I think we might have to repeat a MRI in some time and monitor the child's progress.
So now the MRI was repeated after 3 or 4 days, and this is the MRI picture. There is some change from the day 1 MRI and today. What do you think now?
Yeah, here we can see definitely involvement of the temporal lobe. I think your arrows are pointing at the temporal lobe, and there is abnormal cortical edema suggesting underlying encephalitis. So now we
this
have
kind of MRI. What do you think?
here we are thinking more of your herpes simplex encephalitis.
Yes. So can MRI be normal in HSV, as in this case?
Yeah, it can be normal, sir, because sometimes.
So what are the classical MRI pictures? What is not HSV? What is HSV?
Okay. Usually they have a temporal lobe involvement, that is classically seen in HSV. If it is basal ganglion involvement, it is very, very unlikely to be HSV. That is one thing. Then based on the different involvement of MRI patterns, we may be able to tell on the different viral etiologies which can cause our disease.
But mind you, in neonatal HSV, the picture may be different. It may not be the classical MRI picture which we say, and more diffuse and multicystic white matter involvement may be there in these neonatal HSVs. So these are few other pictures, and the most common area of involvement is medial temporal lobe. So any other, Dr. Arora, we say MRI is not 100%. These pictures may point towards HSV, but there may be other reasons. What are the other possibilities when you see?
So when we talk of having similar picture in other encephalitis, so all herpes group, in fact, if we include, say, EB virus encephalitis, HHV6 encephalitis, varicella zoster encephalitis, even for that matter, in influenza virus encephalitis, and even in rabies encephalitis also we may have a similar type of picture. So just looking at MRI, it is not 100% that it is herpes, but of course, even looking at this group, it is even if there is a doubt, it is better to start acyclovir, continue acyclovir, rather than stopping it.
Sir,
because this is giving a very good clue, and being a treatable disease.
People say that MRI gives a clue to various these things. Can you just highlight few MRIs, few conditions where MRI is classical or typical? So HSV already we have told that it is a medial temporal, then frontal lobe, especially the orbital surface, then JE we discussed, then in thalami and substantia nigra, and EV71 can have abnormalities in dorsal pons, medulla, midbrain, and cerebellum. West Nile virus, they involve the deep gray matter and brainstem in most of the cases. White matter lesions mimicking demyelination may be there. Dengue can be sometimes normal in dengue encephalitis, or can be scattered focal lesions may be there. Chikungunya more involves white matter, multiple punctate supratentorial, and ADEM multifocal abnormalities in subcortical white matter, thalami, basal ganglia, and brainstem, and anti-NMDA receptor encephalitis that affects the medial aspect of the temporal. So, looking at the MRI, usually the radiologist will be able to give a clue to the possible etiology. So, MRI is the most important thing. And as you told, as Sri Krishna told, we have repeated the EEG after a few days. So, when the EEG and MRI are normal, it is better to repeat. So, this time it showed some clear pattern, that is periodic lateralized epileptic discharges. That PLED is classical of
herpes.
HSV. PLED is classical. So, Vaibhav, what are the role of EEG in the diagnosis of these encephalitis?
Yeah, so as mentioned, the herpes virus is prediction for temporal lobe involvement. So sometimes in the early phase of the disease where we are not able to get any clue or MRI is normal, then EEG will guide us to differentiate the anatomical location of the origin of the disease, and that can point towards that herpes may be the one of the etiology, because it will show the plaid-like of pattern.
So what I mean to say is that plaid, if it is there, it definitely points more towards HSV. But the initial phases, as
Maybe
in
normal,
this case,
yeah,
it may be normal. So here CSF PCR, it confirmed HSV1. Now, Dr. Mihir, suppose the negative PCR is there in early stage, does it rule out HSV?
No, because if the clinical suspicion is strong and this kind of neuroimaging finding, we have to continue acyclovir, because there are, if we do the CSF within the first 2 to 3 days, or the patient having empirically getting acyclovir, after a long time of acyclovir you are doing the CSF analysis, then the PCR may be, the CSF PCR may be negative. So we can, if there is strong clinical suspicion, if you have done it very early, then do it later within the first 10 days, then it will might be positive. So we have to look at the clinical picture, the other imaging findings. So we should not stop the acyclovir on the basis of only single CSF PCR analysis.
So point well taken. So initial 24 or max 36 hours PCR may be negative, though it is highly sensitive and specific test, 94 to 96%. And if there is clinical suspicion is strong, MRI points, and there are some clues in the EEG, then continue acyclovir and then try to repeat it after 4 days. That is the usual recommendation. Now, Krishna, sometimes HSV1 is there, HSV2 is there. In the PCR, you may get HSV2. Does it make a difference whether it is HSV1 or 2?
For our treatment, it does not make any difference, sir. So, only thing what we should understand is HSV1, we get that classical MRI changes like the temporal lobe involvement. Your HSV2 is a basically neonatal disease, but it has a devastating, like it has a more of demyelinate, like a white matter infiltration course. It does not have a specific temporal lobe association.
Okay. So generally it doesn't make much difference. The only thing is HSV2 is more common in neonatals and those who are immunocompromised. Yes. Other than that, the clinical picture, the radiological picture may be same. So treatment acyclovir, we know, I will not talk about the treatment, but this case acyclovir is appropriately recommended doses and recommended duration acyclovir given, and they completed the whole course of 21 days. Now, 2 months over, after 2 months of completion, suddenly he became encephalitic with behavioral changes, chorioathetoid movements, facial dyskinesia, and non-purposeful movements. And the seizures they described as a vacant stare, had rapid deterioration with the repetitive orolingual brachial movements, admitted to PICU with all the anticonvulsants, acyclovir, and inotropes, etc., etc. So, Dr. Arora, what are your thoughts about the possibilities? What is happening now?
Now, if we see that the patient has already had herpes, now 2 months have passed. So one thing now comes, now he is coming again, like AES type of a picture. So are we dealing with herpes only? That is number one. Or there is something new, because now the symptoms have changed altogether. So it is looking now more like an autoimmune type of a thing. So still, because herpes was positive there, so first thing is to rule out herpes and treat it on the lines which they have already started. Was started on valproate and acyclovir and everything, that is fine. So now we have to confirm, we should get a CSF again and look for herpes antibodies.
What are the tests you are going to do with the CSF now at this point of time?
Because if at all, if herpes is there, the herpes IgM should still be positive in CSF.
See, one is that in this child, MRI, of course you have to do a MRI, which came out as normal. CSF analysis, 10 cells with the 60 glucose and 29 protein. All viral panels, we have to send a autoimmune antibody panel, and then EEG showed right temporal epileptic form, and then FDG, that is fluorodeoxyglucose PET was done, and that showed hypometabolism in the right parietal, bilateral occipital areas. So this is the MRI showing asymmetric, multifocal, subcortical white matter with the bilateral thalamic hyperintensities. And you can see in the FDG PET the hypometabolism. So this child clinically, with all the background of investigation, autoimmune encephalitis was suspected, and pending the reports of the autoimmune antibody, methylprednisolone was started, not improvement, along with that IVIG was given, and still the sensorium was altered, and plasmapheresis and then steroids were continued. And acyclovir also was continued, but by the time the report came, and then we stopped. So what further tests, because by that time, as I told, the CSF autoantibodies, the CSF was positive for anti-N-methyl deaspirate receptor, that anti-NMDR antibody, which was positive. Over a period of time, the child improved in next few days. They continued with steroids and then discharge. So this is a case of anti-NMDR encephalitis following HSV. So, Vaibhav, can you just give a brief on what is this anti-NMDR antibodies or anti-neuronal antibodies, and highlight few things?
So basically, pathophysiology behind this autoimmune encephalitis is there are two phases. First is the sensitization phase, and the second is the effector phase, where the first virus or any bacteria organism enters the body, the autoantibodies start developing from that, and after some time, say about 2 weeks or from 2 months, the effector phase will start, and that will damage the nerve cells, either the neuronal surface synaptic cleft receptor or the surface protein. Like synaptic cleft receptors, if we say that is GABA receptor or voltage-gated potassium channel like that, or NMDA receptors. And anti-surface protein, that can be glutamic acid decarboxylase, that will be the GAD receptor or MOG antibody. So that kind of the target, like molecular mimicry, the target will be affected by the autoantibody, and depending on the area of involvement, the symptomatology will be different. Like if NMDA is there, then there will be more of limbic system and autonomic disturbance presentation would be there. In case of like GABA receptor antibody, then generalized activity will be depressed, and voltage-gated potassium channel accordingly it will affect. Most of the common, like in practice, we are seeing the anti-NMDA and the MOG antibody, that are the commonly we are saying.
In pediatrics it is a MOG and anti-NMDR. These are the two common things. So when to suspect?
So when the natural course of the disease is expected to be over, like in the viral infection, it should take at least 7 days or like maximum 10 days to over, and after that, with sufficient due in between that time, we encounter the symptoms, and even that the study has shown that depending on the age, like if the child is around adolescence, 15 years or less, then the chances of limbic system temporal involvement and seizure type more common. That includes autonomic disturbance, then orofacial abnormal movement, gustatory problem, speech problem, unilateral paralysis. That can be the presentation of autoimmune encephalitis. And if child is more than 15 or 18 years, then psychiatric symptoms are common presentation.
So a child who has encephalopathy, who has movement disorders, psychiatric symptoms, or emotional instability, or autoimmune disturbances, think of autoimmune encephalitis. So differentiation, Dr. Mihir, see, this child didn't have fever, but sometimes 3 weeks back or 1 or 2 months back, they had some kind of infection and they would have forgotten. And then suddenly it comes to you with the signs of autoimmune. So you have a difficulty in differentiating between a infective encephalitis and autoimmune encephalitis. What are the pointers that differentiates?
Yes, so the pointers is differentiation when there is very acute presentation. Otherwise, if the patient have classic features like the psychomotor involvement, movement disorder, then the downgrade of the school performance, then followed by encephalopathy, convulsion, if this classic, then it is not a problem. But if the patient have the very acute presentation with some sort of low-grade fever followed by the acute encephalopathy, convulsion, refractory convulsion, then it is the problem. Then we have to keep in mind that besides the infective cause, there may be this autoimmune or the post-infectious demyelinating lesions. So these are mostly the post-infectious, and there are some entity called the para-infectious, that is infection is there along with fever, there is hyperinflammation inside the brain that is leading to some acute encephalitis state. So that and the distinguishing will be if we look at the MRI finding, typical distribution and the history, the MRI finding will be here the mode of a patient with autoimmune encephalopathy. The NMDR will be the subcortical white matter involvement, and if you look at the infectious, then there will be varied presentation. The deep gray matter may be involvement like that we have seen in the JE, or the patient with temporal lobe involvement in the HSV. So there may be typical pattern of one of the viruses, but in ADEM there will be mostly the subcortical white matter. And also the CSF analysis, you will find that there may be some pleocytosis, lymphocytic pleocytosis, but here will be findings maybe the lymphocytic and the RBC that we have found in the in HSV. So the PCR will help you out in the patient with the infective etiology. If this are ruled out, then we have to go for the anti-autoimmune encephalopathy panel like already have mentioned. So that's
Krishna,
how I can.
Yeah, I will ask Krishna one question.
Yes, sir.
See, these autoimmune antibodies may not be positive in all cases. So absence of antibodies may not always rule out. So there are what is called as seronegative conditions. So how do you manage, or when do you suspect these seronegative but suspected autoimmune encephalitis?
Yeah, so around 50% may be positive and 50% might be negative. So we have to rely on the clinical features which we have discussed in this case. Like there will be child presenting with acute encephalitic syndrome. Along with that, there might be more of neuropsychiatric manifestation. Then here we have already done a CSF. There some additional CSF will be of more help. Like we can do CSF oligoglonal band. It tells us intrathecal inflammation. So there will be CSF oligoglonal band, though it's not specific, but can be seen in your autoimmune encephalitis along with elevated CSF IgG index, which also suggests intrathecal inflammation. Or along with the clinical picture, we can go into autoimmune encephalitis.
Yes. So it is not that the dilemma or the problem is that it is not positive always. There are a group of what is called as seronegative group. This child was treated and with the prednisolone IVIG. So this is the flow chart how you should follow the clinically suspected autoimmune encephalitis, investigate and then treat it. So with that, the next case we will go because of the lack of time. One more case I can discuss. So 6-year-old from rural area, fever, headache, and then he was stuporous and white cell counts, everything was normal, sent CSF done, and CSF showed 187 leukocytes and glucose 28 and protein 66. And these are the MRI picture. Dr. Arora, this actually shows white matter hyperintensivities bilaterally involving periventricular white matter and central semi-oval. So with that MRI, ceftriaxone was started with the acyclovir and ceftriaxone was started, and on second day the microbiologist calls you and says that gram-negative coccobacilli bacilli were identified in blood and CSF. How do you proceed?
No, here it's a very good clue which the microbiologist has given, and this is very rare to get. In fact, and it's hardly, I will say you are very lucky to have such a clue from microbiologist at such an early stage. So this is giving a possibility of a brucella species, and although brucella even by itself is very difficult to culture, even being fastidious organism, you have to keep a high index of suspicion if you are suspecting brucella. So you have to tell your microbiologist that I need to have this culture for a very prolonged time. But
Yes.
here it's very fortunate
Yes.
that there is a clue. So this is
Yeah.
straightforward.
See,
giving us the diagnosis.
isolation of brucella from the blood itself is very difficult. And you have to keep for a longer time unless you suspect and tell the microbiologist, it's not possible. And the isolation rates are very less. And isolation from CSF itself is very, very uncommon. Literature says around 10% or less than that. And luckily we could get the positive brucella here and it was treated. And one thing is the history. So retrospectively, after seeing this report, we took the history. There was a history of ingestion of unpasteurized milk products, and that, so as I told, serum agglutination test was done for brucella, and that was also positive. It was treated. Other case, 8-year-old, fever 4 days, headache, seizures, then poor GCS. How will you proceed, Dr. Vaibhav? So this child didn't have any other things, like the basic investigations were normal. And the resident or the registrar on duty on the night, he found that there is something. And
so this is the pathognomic of scrub typhus. If we are able to see, then we are lucky, because in Indian population, because of the texture and color, generally it is not seen or missed. And sometimes, most commonly it is to be seen in the skin fold and the area of the neck and that.
so confirmatory test
It's CSF IgM for scrub typhus.
So CSF IgM again is very confirmatory, because the blood IgM cannot pass into the CSF blood-brain barrier. So if it is positive in the CSF, that gives very good this thing. It was a scrub encephalitis. So the problem and pitfalls is that this eschar may not be there in always, epidemiological importance, and it is sometimes very difficult to differentiate from tubercular meningitis also. So with that we come to the end, then few more cases. So to conclude, diagnosis of AES is challenging because of various reasons which I enumerated. Etiology is huge, geographical or epidemiological history is important. Initial tests sometimes may not be positive even in a typical case, and if it is negative, then probably you have to repeat, and including the MRI and CSF. CSF is must, MRI is must, EEG in some cases. So clinical judgment when choosing the most appropriate treatment, and your clinical judgment when the tests are negative will help to improve the patient outcome, reduce the mortality and morbidity. Thank you so much for the patient listening, and I should thank the panelists, because the questions were not earmarked. I have not allocated questions, and impromptu they could speak so well. Thank you so much.
Thank you, Bhaskar, for giving us 2 seconds extra. And may I call upon the moderator and the panelists and Dr. Bhupi Manucha to kindly hand over their mementos to the memento stand. The next program will be a keynote address, and our chairpersons are Dr. Atanu Bhadra and Shivachan Singh.
So good morning. We are reaching the cream of the conferences. This is the cream because we will have the keynote addresses now. And for the first keynote address, I'll ask Dr. Shivachan Singh to call on stage Professor Ritabrata Kundu, who along with Dr. Tapan Ghosh was instrumental in developing ID study and ID chapter in West Bengal, in Eastern Zone, and all across the country.
Thank you, Dr. Tanuda. Good morning, everybody. And first in the series, this speaker is Dr. Ritabrata Kundu. He is well known to you, Professor of Pediatrics at Calcutta ICH, and well-known ID experts. So he'll be speaking on Mycoplasma, an important disease of Mycoplasma, myths and facts. So I request him to start his session.
So it is a journey, different types of cases we came across. My sincere thanks to Dr. Prabhash Roshan Giri, who is our PQ in charge. Most of the cases belong to him. So all of you know Mycoplasma lacks a cell wall. So that's the reason why most of the beta-lactam antibiotics are not effective. It not only causes pulmonary infection, it can cause encephalitis, hemolysis and host of other infection. And unfortunately the immunity is not long lasting and asymptomatic carriage even for months after therapy. So, but the diagnosis is also not very up to mark because serology, the antibodies, IgM antibodies on which we diagnose might be false positive, false negative, and they remain positive for 6 months. That means your positivity of IgM does not essentially means it's a recent infection. And you can carry the bacilli in your nasopharyngeal place for more than 4 months. So again that's the problem. And routine laboratory is not much of a help. The platelet neutrophil may be normal, but CRP and ESR is usually elevated. But some patients shows positive Coombs test because of the hemolytic anemia. So there are common thoughts and beliefs. The most common thought is that Mycoplasma is a walking pneumonia, it's a trivial infection, and pleural effusion occurs commonly, but hardly it leads to necrotizing pneumonia or empyema. Skin manifestations usually occur along with respiratory symptoms. Gastroenteritis, hepatitis, cardiac problem and pancreatitis are rarely present, and CNS presentations like encephalitis, edema are rare, and immunomodulators have no role in the therapy. So it's a walking pneumonia, trivial infection, will respond to oral antibiotics. So here is our case, 9-year-old male child comes with 10 days of fever, who is treated with amoxiclav, azithromycin, but no improvement. Then treated with ceftriaxone, meropenem, vancomycin for 3 days, no improvement, and shifted to ICH. In ICH, the total count was 4,500, CRP high. We did a pleural tap which showed 2,100 cells, LDH was very high, protein was 3.2, CBNAT was negative. And then we did a test and Mycoplasma IgM was positive. We started on IV doxycycline. After 2 doses of IV doxycycline, the patient was afebrile and we planned for discharge. But just before discharge, the patient developed severe acute abdomen. And this is what you see. You can see the pancreatitis. So pancreatitis is another important complication which you can have with Mycoplasma. Amylase lipase was high, and from the Nelson textbook of pediatrics, mild hepatitis, gastroenteritis, pancreatitis, acute glomerulonephritis, involvement of the eye, serious cardiac complication, rheumatic-like fever, these are all associated with Mycoplasma, so it's not a trivial disease. So next case, 11-year-old morbidly obese child came with cough for 7 days and fever. Respiratory distress he had. It was, his total count was again not high, but CRP was high. This was the X-ray which shows mild patchy pneumonitis. And we couldn't put the child on high frequency or non-invasive ventilator because of the OSA and morbidly obese. So the next day, the Mycoplasma pneumonia came out, and we started on IV doxycycline, but cardiac arrest and succumbed. One of the reasons of this case death might be because of this morbid obesity, but Mycoplasma can even cause death in a child. So lobar consolidation are very rare in Mycoplasma. This is our common belief, but in fact, this is Ivan Maji. We have come with the lobar consolidation, respiratory distress 3 days, cough for 7 days. Who was admitted outside, given Mero-Vanco, not responded, referred to us. So he came to us, he saw a characteristic classical lobar pneumonia, tachypneic. His SpO2 was 86, put on high frequency, and zone and TICO was added, and upper respiratory valve was negative. But later on we found this rash. TLC count was 6,700, CRP 168, and by seeing the rash, Mycoplasma IgM was positive, we started on IV doxycycline. So these are the very common skin manifestation of Mycoplasma, which you don't get in all the cases, but in certain cases may you definitely get. Erythematous maculopapular or vesicular rash, bullous, purpuric, glove and stalk rash. Also you can have target lesions, and some cases of Mycoplasma can even develop Stevens-Johnson syndrome. So this was Ivan, and we started on IV doxycycline, gradually it resolved. So now you will be lobar or consolidation segmental is as high as in 37%, not, and parahilar or peribronchial infiltrates is 27%. And reticulonodular infiltrates in 21%. Mycoplasma is the differential diagnosis of miliary mottling in the lungs, because good number of 21% has such, and patchy infiltration is 15%. So lobar, in fact, maximum cases of Mycoplasma causes lobar pneumonia. So third common belief, all Mycoplasma responds to azithromycin. Let's see what has happened. So this was a case, one 8-year-old girl, cough for 6 days, fever, TLC was not that high, CRP high, put on IV ceftriaxone and added IV ticoplanin on day 3, and this was the X-ray of the child. You can see the pneumonias. So next on the day 4 total count, CRP 150, Merobanco was started, upper respiratory biofire was negative. So again CRP was further 250, SGPT high, Val Gramston CSF negative, but Val biofire shows Mycoplasma when we started the patient on IV azithromycin. But IV azithromycin didn't help. In day 6 the child landed up in PICU, there was no improvement with IV azithromycin. And then the child also started developing this maculopapular rash, target-like lesions. So we switched over to IV doxycycline, and there are numerous reports from all Southeast Asian countries where Mycoplasma pneumonia shows resistance to macrolides, and this is another, several studies have shown their resistance. And the conclusion of the study, children receiving early oral doxycycline have shorter duration of fever and hospitalization in macrolide resistant Mycoplasma pneumonia patient. So be very careful with azithromycin. So the next common complication, severe complications are rare with Mycoplasma. Let's see what has happened. A 8-year-old girl child, fever for 6 days, cough for 6 days, tachypnea, admitted outside, oral ferropenum azithromycin, got then IV meropenem vancomycin, admission on ICH. This was the pneumonia you can see. So shifted to PICU, looking sick, anxious, tachypnic, bilateral Krebs and bronchi. This is the classical target lesion you see. CRP 186, SGPT, SGOT slightly raised. So this was the child, his blood gas was also there. So IV meropenem vancomycin and doxycycline, we put the child on HH, high frequency, and upper respiratory valve showed Mycoplasma. So further deterioration, NIV failed, intubation, there was a peri-intubation arrest, and he had a massive pulmonary hemorrhage and death. This is another very complication. There have been cases of diffuse alveolar hemorrhage caused by Mycoplasma. So Mycoplasma is not it can cause very serious complications in the form of pulmonary hemorrhage, which cause death in the child. So our next case was 13-year-old girl with fever for 10 days, pain abdomen, admitted in a private hospital, hemodynamically stable, looking sick, lethargic and febrile. So he was again on meropenem vancomycin, doxycycline, put on HHFNC, USG thorax was done, collapse consolidation, bilateral lower zone minimal effusion. We did an USG which showed mild ascites. We did multiple investigations which shows a very high count, platelets was low, CRP was very high, procalcitonin was high, urine pus cells 10 to 15, RBC was there, albuminous was, ferritin was not that high, D-dimer was very high, pro-BNP was very high, fibrinogen, coagulation normal, upper respiratory biofire was normal. So what we had pneumonia, hepatosplenomegaly, cytopenia, high inflammatory marker, polyserositis. He has evidence of AKI and nephritis because his urea and creatinine is high, hyperbilirubinemia, but negative HLH markers. C3, C4 was done, ANA is negative, dsDNA was negative. So what we did, the child's distress increased further hepatomegaly, gallops, systolic rhythm. Then we did an echo. An echo showed thickened mitral valve reflex with severe mitral regurgitation, moderate pulmonary artery hypertension, both the atrium and ventricle was dilated on the left side, and so the child was admitted on day 3 in ICH, and his heart rate was very high, subcostal retraction, SpO2 was maintained in 3 liter oxygen, gallop, murmur, hepatomegaly. We did a POCUS, bilateral effusion with consolidation, you can see this. So this was in the way we got the child. So the child was put on high frequency ventilation, IVF was given with 80% maintenance, meropenem, vancomycin, doxorubicin started. We also started Lasix in the view of cardiac failure. Diagnostic pleural tap was done and sent for investigation, which showed a TLC count high with mostly polymorphs, glucose, protein, LDH was high, expert was negative. And this was the X-ray, there's respiratory failure, intubated, ventilated, no improvement in the pneumonia. And this was the echo which was done, and you can see in echo evidence of pancarditis, pericarditis, myocarditis, and ultimately the child developed refractory shock. The child could not be resuscitated, expired on midnight, Mycoplasma IgM came positive. So Mycoplasma induced pancarditis. Mycoplasma carditis is a very serious condition, and most of the cases will result in death. So next important thought we had that immunomodulators have no role in Mycoplasma infection. So let's take another case, a 5-year-old child who came with fever for 7 days, cough for 7 days, respiratory distress. He was treated with outside with multiple antibiotics, augmentin, ceftriaxone, piptas, azithromycin. You find these days this very strange antibiotic combination given in outside, God knows with what background thought in the mind. If you have respiratory distress, piptas has no role in lungs. Respiratory distress increase referred to us as a case of right-sided pleural effusion. So this was the issue, the complete whiteout of the right side, slightly shifting of the heart on the other side, severe respiratory distress. His SpO2 was low, he had mild encephalitis, and we did HHMC followed by non-invasive ventilation. X-ray POCUS shows massive right-sided pleural effusion, but the fluid was thin without septa, and TLC was not that high, CRP was high. I think now by this time you are noting most of the cases of Mycoplasma, the count is not that high, but the CRP is usually high, we see in most of the cases. We started on ceftriaxone, vancomycin and flucloxacillin. ICT drainage was done. 600 ml of fluid came out initially, and everyday fluid started coming, and we gave 5% albumin. The pleural fluid shows glucose 100, total protein AD, we are not supposed to do, I don't know what they have done. Cell count was high with mononuclear, and CB-NAT was negative. The child continued to have high-grade fever, antibiotic upgraded to meropenem, doxycycline, blood for Mycoplasma antibody was sent. On day 4, the further worsening of the clinical status, the child developed CNS symptoms, the child was not responding, sensorium worsened, started having multiple seizures, intubated, ventilated, seizures were controlled with levetiracetam, phospheniton and midazolam. MRI brain showed multiple ill-defined non-enhancing lesion in thalamic region involving both the cortex and subcortical white matter, just like meningoencephalitis. We did a lumbar puncture, CSF count was 50, mononuclear, glucose was high, protein was not that high, slightly high, CS negative, biofire was negative. So this was the X-ray, you can see some enhancement in the deep grey matter nuclei in the thalamus. So this was the thing. So what we did then, Mycoplasma IgM came positive, so doxycycline we continued, and we started steroid. Once we started steroids, there was significant improvement post-steroid. The child could be extubated to high frequency ventilation from mechanical ventilation. 48 hours after steroid, on day 8 of illness, fever spike reduced after steroid, gradually ICD drain output decreased, and the drain was removed on the 10th day. So this was his CT scan of the chest, you can see. So the child gradually improved from the encephalitis state. The patient also developed a reactive arthritis in the right hip. It was managed conservatively. Ultimately, this was the X-ray. He had a complete whiteout of this side of the lungs, and we could send the child on the 17th day of illness just because of giving immunomodulators. So this is another case of 10-year-old girl who has come with fever, cough for 8 days, respiratory distress for 3 days. He had oral coamoxiclav, azithromycin and meropenem. Count was 22,700, hemoglobin slightly low. CRP was very high, 186, SGPT raised. And this was the X-ray, almost the entire lung was involved, excepting this and this. So rapid deterioration in next 10 hours, more tachypnea and desaturation, altered sensorium, urine output decreased, started to pass blood mixed loose stool, further drop of hemoglobin, and whole this side of the lung was white out. So we started on ceftriaxone, vancomycin and doxycycline. Intubated ventricle central venous line secured, arterial and done, hypotensive was on inotropes, DIC blood product was given, progressive deterioration, and by that time biofire showed mycoplasma. So day 4 MODS IV steroid we started on next day of the admission. We started IV steroid, and once on IV steroid, see the gradual improvement of his chest X-rays, and she showed improvement. So this was the child, and this is the last X-ray which showed considerable improvement, and we could be able to discharge this child. So if you follow the literature, you can see that in case of refractory Mycoplasma pneumonia in children, early recognition and management with this immunomodulator agents can be with immunomodulating therapy are main strategies. So your doxycycline will cure the Mycoplasma, but doxycycline is not going to cure the cytokine storm which is happening. So these are the cases where you should give this either steroids, or this is again taken from the textbook, either corticosteroid therapy or intravenous gamma globulin, and there have been cases reported wherein Mycoplasma plasmapheresis was also given, but unfortunately we didn't come across a case where we needed plasmapheresis. But these days, if they show don't improvement, if they show even after giving antibiotics the child is deteriorating, so we give corticosteroids and IVIG. So these are a few cases of Mycoplasma which comes with skin infection. These are known as Mycoplasma induced rash and mucositis. This is a very common Mycoplasma causes, both Stevens-Johnson syndrome, and it can cause 10. The most common rashes in Mycoplasma, maculopapular target lesions. You can have conjunctivitis and you can have serious mucositis. And in the X-ray you can see this was an 8-year-old boy, fever, cough, rash for 4 days, oral ulcers, conjunctivitis, we treated with doxycycline. One thing I'd like to tell you, most of the cases in our hospital, these days we don't use azithromycin for Mycoplasma. It is showing, it's not showing improvement. So we, in most cases where we think of Mycoplasma, we start with doxycycline. So with this, my take-home message will be, walking pneumonia is often serious. It's not a walking. May cause gastroenteritis, hepatitis, glomerulonephritis, pancreatitis and myocarditis. If you have myocarditis, cases are very serious and often they lead to death even if you give immunomodulators. Lobar consolidation is the most common among pneumonias. We usually think lobar consolidation is the hallmark of pneumococcus, but not. all Mycoplasma does not respond to azithromycin. Of late, we treat Mycoplasma with doxycycline, and if there for some reason you cannot use doxycycline, there is another agent you can use, levofloxacin. But again, levofloxacin is a very important drug for tuberculosis. Don't misuse. It should be kept as a reserve drug. It may lead to severe pneumonia with pulmonary hemorrhage. If you have a pulmonary hemorrhage, it is very difficult to save the child. Steroids, IVRG, plasmapheresis shows benefit in refractory infection. Antibiotics will cure Mycoplasma, but antibiotics won't cure the cytoplasmic storm. And I will thank you again, and I thank myself that I could end it in.
Thank you.
Thank you.
Thank you, Professor Ritabrata Kundu. Sir, I think you have enlightened us, and we have realized that we have come a long way from walking pneumonia and Mycoplasma. It's now a whole new scenario. Next, for the delivering that next keynote address, it's our honor to call on stage Dr. Sanjay Ghorpare, the ID person who put ID into the presidential action modules for many years now, and he is from Satara, Maharashtra. Why I mention calls him to the stage, the topic would be connected to that area where his clinical practice is.
Welcome, sir. Welcome, Sanjay Ghorpare, sir. And the topic is about scrub typhus in children. It's more common. So I think he will highlight us about the scrub typhus in children. So I request him to start the session.
Thank you, Chairperson, sir, Dr. Natunu and Shivbachan Singh, sir. First of all, I am thankful to PIDA and the organizing team of this National PIDA Summer CME, Dr. Utpaba Kundu, sir, Dr. Jaideep Keya, and all the core committee members behind this CME. Today, the topic that is given to me is a resurgence in the scrub typhus. Of course, there is always, whenever any disease that can be in the same format reappear, or in the different format can reappear. Today just I am seeing that SBS is appearing in a different format with the jean jacket like that, and I was surprised that who is coming. Same thing, any disease or infectious, there may be a change in the disease pattern, either in terms of the similar pattern or with the different spectra. Going to the topic proper, this is a topic actually allotted to me, that scrub typhus resurgence in the Indian children. This is a real syndrome. Whenever we are going for the handling any infectious disease case or any case in the OPD or IPD, this real story many times happens, and this story happens to me really. This is a 11-year-old child brought to the history of fever for 5 days, bradycardia, weakness for 3 days, swelling of face, altered level of consciousness, breathlessness. Child was drowsy, heart rate 100, BP was okay, respiratory rate 40, pallor, hepatosplenomegaly, bilateral scattered crepes. And whenever this child was presented to me, this was the story. Actually, we were looking for anything else is there, just a drowsy child and swollen child. In our mind, when such a thing is there, of course, we always think in a rational way that these common conditions rather than uncommon things. And as usual, we are thought in terms of just Bhaskar has presented that it could be AES. And whenever we are saying that AES, n number of differential diagnoses are in our mind. So, with this broad diagnosis of AES, we evaluated this case, and these are the battery of investigation whenever we are thinking for. Hardly HB was little bit dropping. Platelet count significantly dropping 44,000 to 34,000. The season was monsoon season, and of course LFT is okay, creat is okay. Our thought process was this is a AS and this is a dengue, most probably, because going thrombocytopenia is one hallmark, and in that way many cases of the dengue where we are treating simultaneously in the same season of the monsoon. So our thought process was it could be a dengue encephalopathy. In that way our thinking process was. Initially we managed with the PICU protocol with the IV fluids, and whatever the dengue management we did, and patient was stabilized. But by the time the 4th day came and fever was persistent, and whatever the thing was in our mind that dengue was negative, leptospira we thought it was negative. On day 4, this was a story that there was an appearance of rash, and this was a typical rash, that is macular papular with the blackening in between is there. And this was picked up by one of the residents, and Bala sir always say that the PGs are our teachers. And of course, whenever we are taking rounds, many things they can ask and they can guide us like that. Same things, we pick up that this is the rash, and whenever we went into the depth of the history, the travel history, especially where the patient came, lot of cases of the scrub were in that area. So ultimately, our intention was, yes, this is definitely a case of scrub. We did the ELISA, came positive, and ultimately patient responded with the very well with the doxy with the regular dose of 2.2 milligram per kg, 7 days course. So friends, why this topic matters? When you are talking about scrub, why this matters? Number one, is the scrub typhus is now leading hidden cause of the fever in children? Number one. Scrub typhus is major cause of acute febrile illnesses in India. Number two. Third, often misdiagnosed as a dengue, malaria or leptospira in the monsoon season. Is it like that? Or fourth, when you are using the drug doxy like many other reasons, whether simultaneously these patient is taking care of indirectly. So these are the remain questions whenever we are discussing this topic, and same things was in my mind also. So I went to the various literatures, really whether there is a resurgence of this in the pediatric population. Whenever I was doing my MD in I think 1995, this was optional topics. At the end, when we were used to read all the things, and the last topics was scrub rickettsia, and hardly we were touching these topics because these were not that much common. And till what time they were not common? Ultimately till the 2010 or 2005 like that we can say that. And now we are very much alert of that. So whenever I was going to the literature, see recent studies, Eastern India 2024, these studies from Kolkata, where the cases of the scrub was hardly there. See the 4.5% of the cases presented with the undifferentiated fever coming as a positive as a scrub typhus. While northern India, of course, in the sub-Himalayan region, accounting more than 14 to 50% cases of the scrub typhus, whenever we are dealing with AFI case, that is a acute febrile illness case. So that much burden is there in the northern India, especially Himalayan region. And when we are talking about globally, how is the condition? See, when we were talking about the Susumashi triangle, that means especially Southeast Asia, Japan, Northern Australia, that was a pocket for the scrub, and now it is expanded beyond this pocket. So that is the story about whenever we are discussing about the resurgence of in the pediatric population. Now, why it happens? Is there any reason because of the resurgence? Because this disease was there previously, then there was disappearance, and now again coming up. And these are the reasons. Number one, yes, environmental and climatic shift is there. Global warming, global warming, global warming. We are talking repeatedly that yes, that increases the humidity, and during rainy season that creates a favorable environment for this bug that is called as obligatory microbes. Of course, it is one that can be transferred through the mites, and rodents are the intermediate host, but humans are accidental host. Humans are accidental host. So that's called as environmental and climatic shift. Second, urbanization and land use. What is by this? Yes, we are expanding and we are encouraging the forests. We are going in their area rather than they are coming us. That's why there is again an increase in the research of these cases of the scrub. And thirdly, increase awareness. So anybody, suppose we are discussing in the conferences, we see that this is a case, just Dr. Kunduya presented the Mycoplasma, and he's saying that resistance is coming up. Yes, like that same thing, I think 5-10 years back, Dr. Atul Kulkarni was the person, he presented lot of cases of rickettsia because he was in that area of Solapur. And we thought that yes, rickettsia is there, scrub is there. So same thing, after discussion in the various conferences, we will become more alert. Second thing, advances in the diagnostics. And ELISA is a turning point for diagnosis of the scrub, because before that, hardly IFA and all the things we were talking about, and sending sample, doing this thing was very tough job. And because of the ELISA, yes, it is easy to diagnose scrub typhus whenever we are discussing about the scrub typhus. Now, rising epidemiological trend. What is by this rising epidemiological trend? See the 2010, hardly the cases of the scrub were there. And now we are in the 2024. Average, I am taking this endemic and non-endemic zone in the Indian spectra. Just this is not an endemic area. But initially it was a tune of 1%, and now it is going to the 17 to 18%. So much rise in the overall cases of the scrub. across India, irrespective of the endemicity of that area. That's a hallmark, and actually I was surprised to see that whenever I was searching for literature, this came into discussion whenever I was thinking of that. Now, this is a recent Indian pediatric data, and this is as a state-wise. See, Tamil Nadu almost a tune of 22% cases. Himachal is highest, almost reaching the 40% cases of the scrub. Rajasthan in between the 15 to 18%. Northeast again 25%, and South India to the tune of 25%. So that's a area where endemicity is there, but irrespective of endemicity, scattered cases, sporadic cases of the scrub are happening across India. That means, yes, whenever AFI, that acute febrile illness is there, a certain presentation I will talk whenever I am going ahead of this talk. In that case, after ruling out the common condition in your mind, you can think out of box and you can go for the ELISA for the rule out the scrub typhus also. Now coming to pediatric burden, this is I'm talking about endemic zones. See, whenever we are talking about endemic zones, it is to the tune of the 30 to 40%. That means in the endemic zone, this is the first common cause of acute febrile illness. Second will be dengue and malaria. In our area is quite on lesser part, but in certain pockets of the India, yes, malaria is still there. So our thinking process should be like that. Yes, whether it is an endemic zone, non-endemic zone, history of travel is very important whenever you are dealing any infectious disease, and accordingly your approach must be. So seeing this burden of the scrub typhus to the tune of 30%, yes, we should think in terms of whenever after ruling of the common causes of the acute febrile illness. Now, in the epidemiology in the India, yes, increasing outbreaks in the multiple states, Tamil Nadu, Himachal, Rajasthan, Maharashtra and Northeast. When you are talking about seasonality, because these are the overlapping illness, we can say that enteric, malaria, dengue, lepto and scrub is another thing. That's why peak incidence during monsoon season, July and November, and it is associated with the various presentation formats. Why research matters? Why we are discussing today, there is a research of this disease. Yes, like disease may be mild disease, this may be serious disease. That's why high burden in children, because children are very much exposed in outdoors areas, number one. Number two, scrub can be a mild and can be serious, and it will cause the ICU admissions with a multi-organ dysfunction, multi-organ failure, and it is a 100% treatable disease. That's why we are discussing here, because once a dose of doxycycline, a miracle results will happen with the scrub typhus. That's why we are discussing here. And geographic expansion from rural to peri-urban to urban. Not only we can say that this is a rural disease, but nowadays this disease is transfer or travel to the urban areas also. We can say that this is a pan-India disease. These are common symptoms and signs. Yes, fever, headache, myalgia may be there, vomiting, abdominal pain may be there, hepatosplenomegaly there, and lymphadenopathy. What I shown is a classic rash in cases of rickettsia. It may be macular rash, it may be purpuric rash, but this is called as gangrenous rash in the severe cases of the scrub, and that should not be neglected, and this should be picked up in time and should be treated in time. This is already shown by Bhaskar. Same picture, we can say that eschar is a region where it can be in the groin or axilla, necrotic region at the site of bite. So whenever you are suspecting this case of the scrub, just expose the child, see the various areas, because this is a fallacy happening in a day-to-day practice. When you are taking round, we are hardly exposing the child as a new pediatrician. Older generation, yes, they used to expose the child, examine each and every area. Because of the time factor or the approach, we are not exposing child. When you are exposing child, definitely you can point out that this could be a SCR and this is the diagnosis of the scrub. Certain laboratory clues, whenever any patient of acute febrile illness is landing with you, if it is with a thrombocytopenia, elevated liver enzymes, hyponatremia, you have ruled out a dengue, you have ruled out a malaria, you have ruled out the leptospira, yes, you can think in that way that this could be the scrub case. And major complications, already I have discussed that meningoencephalitis, myocarditis, ARDS, acute kidney injury and shock may be the related complications. If you are talking about the encephalopathy or encephalitis in cases of the scrub, maybe normal MRI or maybe acute necrotizing encephalopathy like a MRI. So right from the mild to moderate to severe, any presentation can happen with this disease. Now differential diagnosis of fever with the thrombocytopenia, talking about misses out because now we are out of the era of the COVID. But when you are talking about differentiating from the scrub to the dengue, main feature is S-scar or SR, you can say that, yes, present. Platelet moderately fall in the scrub, but a severe fall in dengue. CRP is moderately elevated in scrub, but mildly elevated in case of dengue. And of course, treatment is fantastic for the scrub with the doxy, and for dengue needs a supportive treatment. Now, in case of the revolution in the treatment of the scrub happens because of these diagnostic. See, when you are talking about diagnostic in infectious disease, first week all the tests are antigen based tests. In the second week, all the tests are the antibody based tests. This is a arbitrary thinking process, we can say that. So many times, suppose this patient is presenting in the first week, very tough to diagnose on the basis of history, on the basis of epidemiology, on the history of travel, with a high index of suspicious. Yes, very well you can start a doxycycline irrespective of your negative investigation on the clinical acumen. That will give the fantastic results. That's why, see, ELISA is there, but the second week, Wilflix, just a screening test. IFA, yes, gold standard, but nowadays PCR is coming up, and in certain centers, the PCR is available. Rest of the investigation are just a supporting investigation. You can say that liver function test, X-ray test, electrolytes, etc., to manage this case in terms of the supportive management. But yes, in the critical patient, these investigation must be done, and accordingly patients should be managed with the monitoring, and proper monitoring is required in these patients. Certain word about the Wilflix test, though it is a screening test, but it may be one test, at least highlighters, but interpretation depends upon your clinical presentation, because it has got poor specificity and sensitivity, and that's why whenever you are not suspecting the rickettsia or scrub, please do not do this test. If you are suspecting, then a certain part or certain weightage can be given to this test. Now the most important part in the management of this scrub, the drug of choice, even though here mentioned that doxycycline and chloramphenicol, as per age, I am blindly say here that irrespective of any age, doxycycline will be the drug of choice. Why? Because here we are giving the doxycycline for shorter period, for 7 days, and that will not cause LH discoloration of the teeth, and hardly there will be side effects because we are giving for the shorter period. But fantastic and best results are with the doxycycline with the 2.2 mg per kg per dose, BID doses, and of course for 7 days may be sufficient treatment. Rest of the drugs, forget it, hardly required the other drugs, because majority patients of this scrub are responding very well with the doxycycline. Now, how should be our approach? With this all discussion, what message we should take whenever we are going for the in the day-to-day practice, and we are handling these cases of the acute febrile illness of the 5 days or more the duration. Yes, if there is a fever, thrombocytopenia, how should be our diagnostic workup? Rule out your regular causes, malaria, dengue, lepto, etc., etc. Expose the child, see for SR, consider scrub typhus, and irrespective of the test, I already told that in the first week certain tests may be positive, in the second week certain tests may be positive, because whatever the tests in the first week are majority time may not be available at periphery, in the second week ELISA is available everywhere. So in that case, very well you can start the doxycycline with a high index of suspicion. Now when to start empirical doxycycline? Fever more than 5 days during monsoon season, thrombocytopenia with elevated LFTs, negative dengue, malaria, and routine diseases what you are in your mind, and child is from endemic area, because these are the certain things on the basis of which on the clinical ground also you can start the doxycycline. So certain tips when you are doing in a day-to-day practice for the postgraduates, yes, always search for the SR, then think scrub typhus during monsoon season, platelet falls moderately, transaminase is often elevated, myocarditis may happen, neurological complication may happen, rapid response to doxycycline, serology may be negative in early, but in the second week will come positive as ELISA, early therapy reduces mortality, and clinical suspicion is critical. These are all tips for the postgraduates whenever they are working in the wards and in the handling the many cases in the monsoon season of the acute febrile illness. So, friends, coming to the preventive strategy, you know that this is a mild disease to moderate to severe disease. This can be a killing disease, but it has got authority treatment of doxycycline. That's why prevention is also very important. The protective clothing, avoid sitting on the grass, and rodent control and community awareness, all these should be highlighted, and this can be a prevented disease. So take-home messages, thin scrubs typhus if in the fever more than 5 days. Search carefully for SR. Pure thrombocytopenia, rule out the dengue, malaria and routine illnesses. If negative, think scrub, and in that case, if endemicity is there, very well you can start the doxycycline. So final message from whatever I have presented with the resurgence of this scrub typhus. Yes, there is resurgence of scrub typhus in whenever I am doing the MD. No cases I have seen until the 2010. The first case in my practice I seen in the 2010, and now it is going up to the tune of the 40 to 50%. What you just went through this presentation in the northern area, northern part of India, especially Himalaya, or we can say that Himachal Pradesh, etc. That area, yes, definitely up to 40 to 50%. Second, early recognition definitely save the life because specific treatment of the doxycycline is available and readily available everywhere across India. Specific serological tests are available. Beautiful is ELISA. Yes, very well it can be done at a peripheral level also. Serological tests are positive in second week of the illness. That's a point to be remembered. If you are done in the first week, it may come negative, and that will not rule out your scrub typhus. It is advisable to make the clinical diagnosis. Why? Because we must be a clinician rather than just the investigator. Expose patient, see for the history, see for epidemiology, ask history of travel, ask history of travel from endemic zone, and come to a conclusion for the diagnosis of this scrub typhus. Therapeutic trial of this doxy is justified in this situation where I have mentioned already, not in each and every case, but yes, in endemicity is there, definitely there is logic to start the empirical treatment or a therapeutic trial of the doxy, because within 24 to 48 hours, the fever will be subsided and your patient will be getting improved. Rapid depressions is strongly suggestive of the correct diagnosis, that is called as a therapeutic trial with the doxycycline. I think this is overall overview I have given with the scrub typhus. Thank you very much for patience in listening. Thank you very much.
Thank you, sir. As usual, your presentation was excellent and lucid. And I think after this period, all of us will be looking to scrub typhus in every fever with unknown origin.
Yeah.
Thank you, sir.
Yeah, thank you, sir. Thank you.
Thank you. So for the next keynote session, it is an honor for us to call on stage Professor Apurva Ghosh. Do I need to introduce him? I think this hall doesn't need any introduction, but his dedication and academic initiative has been responsible for putting pediatric research in this part of the country, and particularly the eminent position of Institute of Child Health all across the country. Thank you, sir, and I would ask Dr. Shivabachan Singh to name the topics.
Welcome, sir, and welcome for this topic, important topic of fungal infection in respiratory infection. So, already introduced by Dr. Ratanuda, so I request you to start your session.
Good morning, everybody. It's really very difficult to talk in front of the stalwarts of pediatric infectious disease like Bhaskar Shenai, Nitin Shah and all. But my talk is on pediatric fungal infections of the chest, and as you can see, many of the diagnoses that we have is on the radiology. So I will highlight many on radiology and then few on the tests that I will talk. They look very nice, but they can be very dangerous to your lungs, and Aspergillus, Cryptococcus, Mucor, Histoplasma, Candida and Nocardia. These are the cases that I will discuss in series. When you suspect fungal pneumonia, firstly, where it doesn't respond to your antibiotic, you have diagnosed a pneumonia, it's not responding, and then the situations like immune compromised host or hemoptysis or nodular or cavitary lesions or imaging. So the initial is the history that your patient is immune compromised. Second is not responding to your antibiotics, and third is your radiology. And high risk pediatric groups, all you know that primary immunodeficiency, and out of that chronic granulomatous disease is very important. And when the patient is ventilated in ICU, there is a high chance that you will have infections with fungus. So I have divided it into endemic one, and out of the endemic one, the Histoplasma capsulatum I will discuss. Opportunistic, the yeasts which are unicellular, the molds which are multicellular, and Pneumocystis xerovasi previously called Pneumocystis carinii, and then the Aspergillus and Mucor species I will discuss. One of the most important is the Aspergillus, which is an invasive nodular disease. But we see more in some other conditions like ABPA, which I'll be discussing. Mucor, we discussed a lot about mucor during our COVID seasons, mostly in adults, the mucormycosis, in diabetics especially. The Candida is usually a colonizer, but it sometimes can cause pneumonia, especially in neonatal unit when you are using antibiotics for a long time in a preterm baby with lot of lines inside. And histoplasma, wherever you are thinking of TB and it's not responding or the diagnosis is not really confirmed, then always think of histoplasma. They always mimic each other. And Cryptococcus, CNS plus lung involvement, the Cryptococcus is an important cause, and nocardia. About the aspergillosis, it has a spectrum of disease. It can be in ICH, immune compromised host, where it can be invasive. Whereas in chronic pulmonary aspergillosis, it's an immune dysfunction, and in normal host, it usually doesn't cause much of problem. But the problem when you are hyperimmune or hyperimmunity, and there is the ABPA, allergic bronchopulmonary aspergillosis, or SAPS, severe asthma with fungal sensitizations is a new entity. So the invasive, it's like any severe pneumonia, and radiology is very important. And the radiology, you see that there is a nodule surrounded by halo sign, and that's very characteristic of a fungal infection if you get. The test that we usually initially do is the galactomannan. The galactomannan you can do in the serum or you can do it in the bronchoalveolar lavage, but the serum is much less sensitive than bronchoalveolar lavage, which has a sensitivity pattern of about 85 to 90%, whereas the serum positivity of galactomannan is only 50 to 60%. The treatment is voriconazole is the first line. When it is an invasive one, always think of voriconazole rather than itraconazole. But the problem with voriconazole is that it's a fluorinated compound, and continuing it for longer time, it can cause periostitis like reactions like increased fluorine. It can be in children, and as early as 3 months has been reported when you are giving voriconazole for a longer period of time. The invasive radiology, aspergillosis radiology, I have already told you that it can have a halo sign, it can have a crescent sign and nodules, and because of the angio invasion, there can be wedge-shaped infarcts, or you can have a combined one. This is the CT halo I have already discussed. And then in chronic pulmonary aspergillosis, when you have a cavity, then in the tuberculosis cavity, there can be an aspergilloma. It can cause hemoptysis. And again, as I said that in case of invasive, it is the voriconazole, but when it is a chronic one, itraconazole is the drug of choice rather than the voriconazole. And aspergilloma can occur in fungal, as a fungal ball in lung cavity, and it can be in tuberculosis. And surrounding the crescent sign, as you can see, there is a crescent around the ball. It's called the monad sign. This is a very good study from PGI Chandigarh, that oral itraconazole versus voriconazole, and they are almost similar, but the 4 deaths that occurred are all in the voriconazole forearm rather than on the itraconazole arm. Next is ABPA. This is a case which I was treating about 24 years back in UK. This child was otherwise well controlled cystic fibrosis, but then suddenly came with the deterioration. Any child with sudden deterioration in cystic fibrosis, think of ABPA. And this child responded well with the treatment, And usually they have the high eosinophil count. The previous eosinophil count was 1000, but now it has been to 500. The previous IgE level was 1000, but in the recent ISHAM guidelines of 2024, it has been reduced to 500. And then specific IgE level, IgE specific level of 3.5 is the characteristic for the diagnosis. The treatment in this case again is steroid, but the dose of steroid is 0.5 milligram per kg rather than the 1 to 2 milligram per kg, and continued for about 16 weeks plus minus itraconazole. Cystic fibrosis in 2 to 15% cases you get ABPA, and in asthma you can get in 1 to 3%. But in about 7% of cases you can have ABPA even in normal persons, and in Japan it has been seen that you can get it into 15 to 25% cases of ABPA in normal persons. So this is the guideline that I was talking of, the ISHAM 2024. Common fungi in cystic fibrosis is Aspergillus, Candida and Cerosporium, and some uncommon, very difficult to pronounce, I cannot. So the CT features is the central bronchiectasis, that's very characteristic. But what is also important is the gloved finger appearance because of the mucus plugging, and then hyper intense mucus, ham as it is called, which is 100% sensitive. This mucus is more hyperintense than the corresponding spinal muscles, and if that is more there, then it is 100% sensitive for ABPA. Now this is another patient, a 3-year-old male child, immune compromised, persistent fever, progressive difficulty in breathing, and acute lymphoblastic leukemia. And the child had a non-productive cough, progressive dyspnea, no response to antibiotic, and CD4 count was very low, absolute neutrophil count was very low. So 3-year-old post-leukemia treatment and ANC, CD4 all low. So you can start thinking that is it a immune suppression condition, and as you can see that the saturation was low, tachypnea, bilateral coastal and intercostal retractions, and diffuse crepitations bilaterally. The hemoglobin was 7.2, the lymphocytes was 8%. Now what you see here, as I have told you, the CD4 count is low, but what you see is LDH. If you are suspecting Pneumocystis caridae infections, do an LDH, it will be very high. So that's very important. We do the beta glucan test, that's important. It can be suggestive, but it cannot be confirmative. The confirmative tests are, I will tell you later on, the X-ray is very suggestive, diffuse, interstitial and ground glass opacities. High resolution CT can give you some idea. And this is a Pneumocystis caridae pneumonia, and this is the HRCT findings in Pneumocystis caridae. So what you do to confirm that is the bronchoalveolar lavage with the monoclonal antibodies, and the newer ones are the molecular diagnostics. As you all know, you are discussing about the metagenomic next generation sequencing, which is confirmatory. In culture you will not get any growth, and the viral PCR is also negative. This is one conditions where you need a very high dose of trimethoprim sulfamethoxazole. Normally we give 6 to 8 milligram per kg, but here we give about 15 milligram per kg. Along with that, you give steroids, and definitely you will have to give the oxygen. But there are alternative drugs you cannot give because of the sulfur allergy. You can give pentamidine isethionate, you can give clindamycin, primaquine, atofeacon, or dapsone can also be given. Now this is not a common cause unless and until you are immune suppressed. 6-year-old boy with type 1 diabetes mellitus. Fever and rapidly progressing facial and orbital involvement. When the face and orbit is involved in a diabetic child, always think of one conditions, and especially when there is black nasal crusting, palatal eschar, periorbital edema, and reduced fission. With that, this will be the picture of a mucormycosis. So there was black discharge, bloody discharge, diminished fission, drooping of the eyelids. As I have already said, that the periorbital edema, ptosis and others, and CT and MRI is very, very characteristic of the erosions that you see, whether in the sinus or is in the orbit, there will be erosions and extensions. And the blood glucose is very high, and that's an immune suppression conditions. So what you see here is just the opposite of what you see in aspergillosis, where there is a dead shadow surrounded by ground glass opacity. Here it's just the opposite that you see in coral, and this is called the atoll sign, just the opposite of aspergillosis. And that diagnosis is by KOH, mounting, histopathology, and the culture shows rhizopus species isolated. The treatment diagnosis is this, and the treatment is stabilizations, antifungal, and here you need to use either IV liposomal amphotericin B or conventional amphotericin B. In children, we will prefer IV liposomal one, but it's much more costlier, and but the side effects are much less. And the surgery is one of the very important options in these cases. Very commonly, we see these type of cases, a preterm baby in an ICU for a long period of time, almost 2 months, and then culture came out to be positive in the blood and tracheal fluid also, but bilateral patchy infiltrates. Think of Candida. Candida infections, again, you will need amphotericin B or echinocandins, mycofungins or caspofungins will be the necessary one. Now this is a 7-year-old boy, mild asthma, no immune suppression. This is one condition where no immune suppression. 1 month cough, fever, vomiting, 2 kg weight loss. And many times people will give antitubercular drugs. But the history here is possible dirt play, non-endemic area, but travel related. He had a cervical lymphadenopathy. So it further leads you to the tuberculosis. But characteristic is 18% eosinophils. Now eosinophils in tuberculosis is usually not very high. And that eosinophil takes you towards a fungal etiology, and chest X-ray is a paratracheal mass. Again, that will take you towards the tuberculosis. But remember the difference between the gland of tuberculosis and gland of histoplasma. Histoplasma glands can be very bigger, larger, and can be up to several centimeters, which is not in case of tuberculosis. Is usually they are around 2 centimeters. Histoplasma can be bilateral. Tuberculosis on the whole is usually right-sided, and the X-ray can confuse you. It can be like miliary tuberculosis with hilar lymphadenopathy. So the X-ray will not give you the diagnosis unless and until you have the lymph nodes of like tuberculosis, which is usually around 2 centimeters. This is one where the tuberculosis, but on the left side. Tuberculosis glands are more on the right side, but less on the left side. But this is a confirmed case of tuberculosis. And miliary nodules in the histoplasmosis can be there. Again, it's difficult to have a diagnosis from the CT scan. You can do immunological test, but the problem with that the antigen is very short lasting. So you have got 3 tests. One is the complement fixation test, the M band and H band. The H band you can see it's short lasting, so you may miss it. Complement fixation and M band can be diagnosis helpful. But the problem again, the antibody test may persist post treatment. So you cannot use this as a part of your cure of the histoplasma. When to treat? Mild disease you don't need to treat, but moderate to severe disease or disseminated infections or immune compromise or the symptoms persisting for more than 4 weeks when it should have subsided, you will have to treat with drugs. Again, the drug is itraconazole, and you can go to severe drugs like liposomal amphotericin B or itraconazole when it's a severe disease. So this is a quick comparison which I have already done. Tree invert pattern you don't see in histoplasmosis, but you get in tuberculosis. Now 15-year-old girl with steroid resistant nephrotic syndrome, fever, cough, present for 1 month, and this was the patient in our hospital who was on treatment with steroids and mycophenolate mofetil by the nephrologist. They made the patient immune suppressed. The chest X-ray bilateral diffuse infiltrations. CT scan revealed areas of patchy atelectasis, and blood culture fortunately showed Cryptococcus neoformans. Of all the fungus, Cryptococcus is the one which can give you a blood culture positive in ordinary culture, not in the other cultures. So this patient also had a skin rash, erythematous plaque-like skin rash, that's again characteristic, and the bilateral infiltrations with miliary mottling, that's again characteristic of Cryptococcus infections. So the lumbar puncture was done, as to be done. It's important because if there is lumbar puncture positive, we will also have to add flucytosine in the treatment of Cryptococcus. And so the patient was sensitive to fluconazole, ketoconazole, flucytosine and amphotericin B, but I was treated with flucytosine and amphotericin B. We published, Dr. Giri and Rajiv Shina and Priyankar Pal, they published this. So this is a very interesting patient that the X-ray you can see the shadows, ribs are erosive changes in the left third rib, but the CBNAT MGIT was negative, CT complete collapse of D3 vertebra. So naturally, most likely, I would have also added anti-tubercular drugs in this patient. Now this patient was given anti-tubercular drugs, didn't respond, and became an empyema necessities like. So that further led us to the diagnosis that it can be a tuberculosis with empyema necessitatis, but was not responding to the drugs. The anti-tubercular drugs was not given in our hospital, it was given in some other hospital. Now after 1 month of antibiotic, it didn't respond, so question is it TB, is it MDR TB or MOTT? But we thought of immune deficiency and dihydrorhodamine test was positive, and then we started testing for nocardia and aspergillosis was positive. So this is a patient of CGD with nocardia and aspergillus positive. Now this is again one more patient who had an SLE, but the lung infection is because of the nocardia, which was confirmed. So there are a lot of tests I have already discussed, the galactomannan, beta-glucan, BAL, PCR panels and biopsy. And CT findings are very important, especially to differentiate between aspergillus, mucormycosis and candidiasis. And then clinically, in candida you can have hepatosplenomegaly, but in aspergillosis we will not have hepatosplenomegaly. Mucor, sinus is more involved, liver spleen is involved, vascular system, because it's very angio-invasive, so the vascular system is also very involved. Thank you very much.
Thank you, sir, for giving a lot of information, and thank you, the scientific team of the ID, for selecting the excellent speakers and excellent topics. Thank you.
Thank you, sir. Thank you once again.
So, thank you, Chairpersons, Dr. Shivabachan Singh, Dr. Atanu Bhadra, And may I request, please, you lead the speakers to the memento corner. Now, next session we have another crowd puller. May I request Dr. Swapan Chakraborty to please accompany them for the memento. May I request the chairpersons for next session, Dr. Jaidev Rai, who is Principal, Institute of Child Health, Kolkata, and also he is the Central IPEB member from West Bengal, and along with him, our very known member, Dr. Biplab Banerjee, please. Yes, he is here. Please come to the dais, and may I request the chairpersons to start the session.
Good morning to everybody. First session, in this session, the first topic is pneumococcal disease in pediatrics, insight into the choosing the correct PCV. The speaker, none other than S. Balasubramanian. He is also very well known to India. It is a respected pediatrician not only in the Chennai, but it is a respected to his topics also. He is a respected pediatrician throughout the India. We all know the streptococcal infection gives rise to the pneumonia, nasopharyngeal carriage, invasive type of pneumonia, everything. And for the prevention, we know there is different type of vaccine. There is a PCV10, PCV13. PCV13 also, there is different type of conjugation, PCV14. Now in the pipeline also, on trial, there is a PCV20. So in these topics, we have to think inside to go, and we have to choose the what type of vaccine has to be given to the children in which situation. Dr. Balasubramanian, please give light on these topics.
Thank you very much. Good morning to my friends in Kolkata and from elsewhere. The session today is on pneumococcal disease in pediatrics, insight into choosing the correct PCV. Before I start the session, I am going to put an open poll without any slide. How many of you use one of the following vaccines today for preventing pneumococcal disease? Please raise your hands if you are using PCV10. Please raise your hands. Okay. Please raise your hands if you are using PCV14. Please raise your hands. Please raise your hands if you are using PCV13. Please raise your hands. Okay. Is this talk necessary? Okay, let me see. Okay. What I'm going to discuss the next 14 minutes or so would be about the current PCV landscape in India and the key considerations in selecting the pneumococcal conjugate vaccine, where you have already given the verdict, and important factors to get at the verdict, summary, and of course future. If you look at the current PCV landscape, it is exciting. In fact, 2004, when PCV7 came, people were asking, is this vaccine required at all in India? Now, you know, there are so many vaccines, starting from Pfizer PCV13, old PCV10, new PCV10, and some PCV13 with tetanus toxoid as conjugate, then PCV14. So many are there. Now you have a choice of 5 vaccines, but in spite, the audience gave a verdict, we use only one most often. And of course, the future is going to be brighter. We are going to have the 20-valent vaccine approved for children very soon, though it is approved for adults in India right now. What are the considerations that you should have in selecting the pneumococcal conjugate vaccine? If you look at the differences between the vaccines which are currently available, the differences are very obvious when it comes to serotypes. The old PCV1, which is very rarely used, it lacks 3, 6A and 19A, whereas the new PCV10 of Serum Institute, it lacks 3, 4 and 18C, and old as well as the new PCV10 does not have serotype 3 at all. PCV14 does not have 6A, otherwise contains all the components which is there in Pfizer PCV13, and the technology of conjugation is different in each of them. I'll come to it later. What you should remember, the available PCVs are different, like political parties, in more ways rather than just the number of serotypes. Now, when you want to choose a PCV, you have to look at several factors starting from the serotype coverage, immunogenicity, vaccine efficacy and effectiveness, and the impact of the vaccine on the disease in the community, cross protection or direct protection, 6A, 6B, like that, whether it gives herd immunity, whether it helps decrease antimicrobial resistance, and whether it decreases nasopharyngeal carriage. These are the components one has to look at in depth for choosing the pneumococcal conjugate vaccine. Let us first look at the serotypes. Unfortunately, pneumococcus has got 100 serotypes. That is the problem with pneumococcus, because we can't have a vaccine with all the 100 antigens. It's impossible to produce in 0.5 ml or 1 ml. Technologically, it is very difficult. But their role in disease is not equal. In fact, PCV13 of Pfizer has been chosen after intense epidemiological studies, choosing the best of the 13 serotypes. And if you look at the differences, as in this table, the differences are very obvious. The most important difference now people are talking about is the difference in contribution to decrease in invasive pneumococcal disease, decrease in pneumonia, all-cause pneumonia, decrease in otitis media, mortality, antimicrobial resistance. If you look at the prevailing data, it is very obvious there is only one vaccine which has got maximum data with regard to efficacy and effectiveness. That is nothing other than PCV13 of Pfizer. There is no doubt at all. No other vaccine today has more data on real field efficacy and effectiveness. And look at the serotypes. There is always confusion. Now we are having 6B. Will it protect against 6A or not? That is always a question. But you look at the data given in our own purple book. You must remember, in our own data, we have data for the pneumococcal strains in our hospital for the last 20 years. Our own data is very similar to that. 6A constitutes nearly 15% in our own data. So very similar to what was reported in the pink book. 1/6 is 6A. And this 6A has to be protected directly and not indirectly. And you look at the Pfizer's PCV13, when it comes to reduction in IPD, pneumonia, otitis media, carriage, absolutely it is much superior, and it has got more data than any other vaccine. If you look at the data of PCV13, which has now been introduced with the tetanus toxoid as the conjugate protein, here all the data is not available in India at all. Okay? This way, the data on PCV, data of PCV13 of Pfizer is much superior when compared to the other vaccines. The next advantage of Pfizer's PCV13, look at this. You can give it to any age. Whereas all the other currently available vaccines, you can't give at all ages, including the old PCV10, which is not approved for use in adults, and the PCV13 tetanus toxoid conjugated one is not approved for use in older children as well as adults. What about antibody levels? Wherever they have used tetanus toxoid as a carrier protein, tetanus toxoid is used as a carrier protein to provide T cell based immunity and not simply provide B cell immunity. Wherever they have used tetanus toxoid as a carrier protein, not only for this vaccine, in animal experiments also, the antibody titers which were found were always lower. Whereas, look at the data on Pfizer's vaccine, where the conjugate protein is from diphtheria and it is CRM 197. Certainly, it has shown much higher antibody response and interference of the DTAP or DPT or HIB along with the pneumococcal conjugate vaccine has not been there. And if you ask me why TT carrier protein should not be used at all, the reasons are many. One, it results in lower antibody response to some serotypes. Two, if you use CRM 197, the antibody response is much more robust. Three, the effect of all this is reduced antibody response to the pneumococcal polysaccharide. So that way, Pfizer's PCV13 scores over the other PCV13. The next is the comparison of OPA, which is a very important parameter for deciding the vaccine. What does the data on comparison of PCV13 versus PCV13 TT show? Very simple. The geometrical mean titer for Pfizer vaccine has been much higher than for the tetanus toxoid vaccine. What about the WHO? Pre-qualification, Pfizer's vaccine has always had pre-qualification. Even 20 has received pre-qualification. And the 13 tetanus toxoid based vaccine has still not obtained WHO approval. And with regard to nasopharyngeal carriage, antimicrobial resistance, real world effectiveness, there is absolutely no doubt that there is much more data on Pfizer PCV13 than other vaccines. Finally, you have been having PCV7, PCV13, now you have PCV20. If you ask me for which vaccine there is maximal data on global impact, undoubtedly it is PCV13 of Pfizer. There is no doubt. Efficacy 75 to 90%. Effectiveness, real world effectiveness, Western data 80 to 95%. Pneumonia reduction even in Africa 30 to 50%. Impact, it decreases adult pneumonia. It decreases even deaths due to adult pneumonia. Decrease in resistance and mortality. And if you want to look at the best attributes of an ideal vaccine, in IPD reduction, pneumonia reduction, otitis media reduction, nasopharyngeal carriage reduction, adult pneumonia reduction, mortality reduction due to pneumonia, everywhere PCV13 Pfizer scores over others. To summarize, why do you think the audience unilaterally approves that we all use only PCV13 Pfizer today? The reasons are scientific. One, serotype 6A is an important group of pneumococcus which contributes to nearly 1/6 of the disease. Direct protection has to be given, so we have to use this. Two, the proportion of 22F and 33F, which is not there in the Pfizer PCV13, but it is there in PCV14, I mean, it forms a minuscule of the pneumococcal serotypes in India as of now. It amounts to only around 1.5%. That means 1 to 2 cases per 100. Serotype 3 infection has to be prevented. 4 and 18C are outbreak serotypes. That has to be included. And though pediatric pneumococcal infections may vary in incidence and severity, the only vaccine which has shown real world efficacy and effectiveness is PCV13 of Pfizer. Finally, I would end my session with a clinic scenario and a question to all of you. Recently, a 3-month-old infant born in Dubai came to me for vaccination. This infant had received 1 dose of PCV20 in Dubai before the Iran war broke out. I had a dilemma. What do I do for this child? Should I give PCV13? Should I give PCV14? Should I give PCV10? Or should I give PCV10? How many of you think that 1, 2, 3, 4, which is the best answer? 4. Okay. Is that the majority opinion? Okay. I am sure all of you would give in such a situation PCV 20, of course, with a written consent. In fact, I am not ashamed in telling you, for my own grandson who is 6 months old, I have given only 3 doses of PCV 20 and not 13. Though it is not approved for use today in pediatrics, if you want to give, probably you can get a written consent and give the vaccine. There is no harm. And finally, like so many new things happening with regard to media, cell phone, etc. Okay, it is often said that there is only one thing that is permanent in life, that is change. So it is time for us to change from PCV 13 to 20. I am sure the next summer CME will have a topic on PCV 20. I am sure Jaideep will invite me and we will be back here with you. Thank you very much.
Thank you, sir, for your useful presentation. In the beginning, we have seen from the audience, the maximum person is using PCV 13. From the talk, it is also reinforced. Still now, PCV 13 is the gold standard. Pfizer PCV 13 is the gold standard. But always change in the science is going on, evidence is coming, trial is going on PCV 20. In future, I think we will give the PCV 20 to the children also. Thank you, sir.
Thank you.
Now we head on to the next session. It's from the lungs and the nasopharynx to the gut, healing the gut. It's a case-based perspective study on pediatric dysbiosis, and Dr. Manjuri Mitra is going to speak on this topic. Madam, the podium is yours.
Good afternoon to all. So probiotic, I always feel that to understand probiotic, you have to have a little bit of passion. Otherwise, it has lot of phenomena. It has gone to every door. So to understand that, let us first give an overview of the microbiota and dysbiosis, which is a very hot topic in every specialty, and how urbanization is leading to dysbiosis and the role of prokinetic. So the human gut, we all know, this is just a recap. More than 1,000 microbes are there in the gut microbiota, and there's a genetic complexity which is more than our own human genome. Microbial population is about more than 1,000 trillion microbes, which leads to hemostasis, mediation, influences the metabolism, barrier function, inflammation, and hemopoiesis. The gut microbiota is basically, it has the anti-inflammatory and pro-inflammatory balance, and as a result we have so many inflammatory parts. And today we have seen that the gut microbiota, because it has become a very vital organ. Now if you look the connections with all the different organs, first let us go through the gut microbiota strains in the different areas of our system. If you go through the stomach, duodenum, jejunum and colon, as you go down, you see the colony count is increasing. As you go down, you see even the microbes have been differed between the different areas. And you also see in today's context the dysbiosis. We have gut-brain axis, we have gut-brain endocrine, we have gut-heart axis. Every organ has a gut-related. And what is most important research-wise, gut-brain axis, the gastroenterologist has taken up in a big way. Recently, I was fortunate to present a paper which I did with Dr. Uday Ghoshal, SGPGI, he was the head of the department, on IBS, presented a paper in a Neurogastroenterology and Motility Association. Just imagine where gastroenterology is taking the probiotic and the gut-brain axis. The enteric nervous system of the gut has gone to a very important area, because IBS and constipation is a very large population in India is having that. The second important thing is gut-skin axis. Now recently we have seen a couple of papers coming out, even Sandipan Dhar has done, gut-skin axis. So probiotic given in atopy to reduce the atopy march. So that is another area. Others are still in the research line. And coming to the gut microbiota, the strains of different areas in our stomach. So today we know that cancer has a targeted therapy. Today people are also working on probiotic as a targeted therapy. Soon it will come. So different probiotics will be used for different, lot of engineering is going on in defining probiotic in the targeted therapy. These are some studies which was done in India, and you can see the diverse microbial profile underscores India's vast inter-individual, inter-regional variability in gut microbiota composition. So today what we are thinking that it is estimated that over 68% of the world population will be living in urban areas by 2050. The background what we are seeing looking like Manhattan, but even in Bombay we are seeing Manhattan in there. And see how the urbanization is really changing the whole scenario. It is disrupting the structure, disrupting the function, and leading to a lot of non-communicable diseases, like the autoimmune disease is on the rise. We see how autoimmune disease is increasing. Metabolic disease in India is one of the highest one. And then the cancers, as I said, and even neurologically disorders, so this schizophrenia, depression, Alzheimer's, lot of research work is going on with the probiotic. So one of the important things which we have to understand that hygiene hypothesis now with strict urbanization, single child in the family, the amount of hygiene hypothesis goes on, this decrease the alpha diversity in the gut. What is that? The richness of the microbe in the gut is decreased. Sedentary lifestyle is also responsible for decreasing the microbes, and as a result the eminent short chain fatty acid producers are very important for our inflammatory part, which is taken care of the gut microbiota, and opportunistic pathogens are increasing. And why small size? Because that limit the horizontal transmission of gut microbes, resulting in altered microbial diversity. So urbanization itself is a problem. And then comes, there was a study, again this was done in India, to show that urban population and rural population, there is a difference. In rural population we still get much better gut integrity compared to the urban. So environmental pollutants target both the host and the resident gut microbiota, generating dysbiosis, resulting in disturbances of the short chain fatty acids levels and the host physiological response and overall the health. So this is another expansion of the food. We understand urbanization, the amount of Swiggy goes into the young generations, which lands up into saturated fats, processed meats, refined grains and food additives. Besides that, the emulsifiers all will have decrease in the gut microbiota, which is leading to the dysgenesis, deleterious effect on the production of the short chain fatty acid, which is a very important component of the microbes in the gut. Now vis-a-vis the Indian diet is generally plant-based and rich in fibers. So more and more I see the homemade foods will be coming up in the long run when we are really in the end for the gut microbiota dysbiosis going to that extent. Now more than 2/3 of Indian children receive antibiotics before reaching the age of 2 years, with exposure to an average of almost 3 antibiotics in the first year of life. In spite of having so many stewardship in antibiotics, still we land up giving antibiotic even in 1 year, because within 1 year you can get at least 6 to 8 episodes of either RTI or respiratory distress, and without giving antibiotic it becomes tough for the practitioner. But I would suggest that most of the virus infections are virus, and today I was just going through an audit, prescription audit, and I will see that over the years the prescription has decreased and the probiotic has increased in watery diarrhea. So that's a good finding which I found. So early antibiotic exposure definitely will decrease the bifidobacterium levels and the proteobacterium. So what it does, the immune system which is deranged at a very early life, within the 1,000 days of life, what it does, the immune related metabolic disorders later in life is increasing, and we know what is the status. The burden today, we are not talking of the axis, heart axis, gut heart axis. So today I'm doing a study across India, and I was surprised to see how young generations, less than 45 years, are suffering MI. So what are all this related to urbanization, all this related to our gut microbiota, which we have to think, we have to protect, and we are the only physicians we can protect, because we are dealing with the very young child at the very beginning of their life. A cross-sectional study examined the gut microbiota of 10 to 18 months old children living in urban slums of Mumbai, and it was related with the anthropometry, nutritional biomarkers and the diet. And again it showed the proteobacteria was abundant, which suggests immaturity of the gut and high inflammatory burden. So this disruption of pro-inflammatory and anti-inflammatory led to this disruption. So now with this background, how we take care of the probiotics in tackling the disease. The probiotics help maintain a balanced internal microbiota for optimal intestinal health. Now, this is one important thing which we have to understand from every aspect what we discuss to take care of probiotic. It enhances the epithelial barrier, improves the mucosal adhesion, produce antibacterial substances, exclude pathogens, suppresses harmful adhesions, and modulate the immune system. One of the most important part of the gut microbiota, it takes care of the immune system. Today we are seeing atopy in the child. Today we are seeing atopy march. Atopy child goes into allergic rhinitis, asthma. So again, if you can take care of the gut microbiota at the very young age, it does give, and there are a lot of evidences which is coming up, it does give a good gut health. So bacillus species form the resilient endospores that survive hostile environments of the stomach and GI tract and maintain stability. So the physiological properties and the antimicrobial and immunological properties basically is restored of the spore forming microgut probiotic. It tolerates the heat, acid and salt and the safe passages. And the strain OC, SIN and T exhibit varying degrees of resistance. Again, when you choose probiotic, you have to be very careful on the dose of the coliform unit and the strain of the probiotic. Every clause cannot be same. The clause with OC, SIN and T, why it is different? Because there are a lot of evidence studied with a particular probiotic. Other probiotic of the same species may not have adequate evidences, but they cannot be extrapolated. What is the industry doing? There is a lot of extrapolation of the evidences probiotic has of a certain company. So that you have to keep in mind when you are using probiotic. Use a genuine probiotic, which you have to understand. The other very important clause spore-based is the short-chain fatty acid production. So this was a study which they in vitro to identify that the clause spores do survive in the artificial juice, adheres to mucin, which is very important to take care of the immunity. And then this three important pointers, the acetic acid, propionic and butyric acid. There was a lot of other probiotics studied, and it was seen in clause T. All the three short chain fatty acids very, very robust in the clause group. And the short chain fatty acids regulate the lipid metabolism, body weight. Propionic improves the barrier function as well as the integrity, and the glucose lipid, and the butyric acid also takes care of the intestinal epithelial cells and provides energy. So this was a single center study with 3 probiotics, and it was done amongst 150 children, 6 months to 16 years, a 5 days duration on acute watery diarrhea. And we saw that the clause had the most reduced stool passage on 5th day, so the duration of diarrhea was much better in clause, but obviously we can see not much difference in the other group, but clause did better. Similarly, a systematic literature review involving 2 RCTs and 1 meta-analysis on the acute antibiotic associated diarrhea, though individual studies did not show significant difference, but the pooled analysis did show a robust benefit for antibiotic associated diarrhea. A robust meta-analysis of 11 RCTs and 3 non-RCTs also showed that the clause bacilli was effective in acute watery gastroenteritis, reducing diarrhea duration, stool frequency, vomiting. And the most important thing which I felt important is the immune response. In the non-RCTs, they did the serum levels of the IgA, IgG and IgM, which shows the immune response is also managed with this. So this is another study, again 2 groups, 2 probiotics, and the clause, the study test probiotic did work better. So this is another important area which is not so important in the pediatric age group, but now today with urbanization, I'm sure all of you see in the children pain abdomen of the small child starting from 2 years, 3 years, and they're all expressive. That is one of the pointers of IBS. So IBS in children is mostly considered as functional abdominal pain. And again, the key feature, if you see the probiotic, the gut microbiota is changed, the Firmicutes proteobacteria is increasing, that is the pathogenic bacteria is increasing, and the good and pathogens and the non-pathogenic bacteria are decreasing. So it impairs the gut barrier, aberrant immune response, molecular mimicry, which leads to even the other disorders and brain-gut axis epigenetic changes. We pediatricians don't focus too much on brain-gut axis, but gastroenterologists, adult gastroenterologists, they have a lot of research wing on the gut-brain axis, and they work a lot on the probiotics and such. So this is another important entity which we see for the gut microbiota dysbiosis is a chronic constipation, another very common in the urbanized children. You see, keep on seeing them, and chronic constipation will lead to your the bladder, bowel dysfunction, leading to UTI and leading to more antibiotic, and then the vicious cycle. So chronic constipation is also a very important entity, which is again because of the gut microbiota dysbiosis. So dysbiosis impairs the enteric nervous system. It's a very, very intense subject which I was exposed to in the gastroenterology conference, the way it has gone into depth. It reduces the gut motility, transit and mucin production while weakening the intestinal barrier, loss of beneficial bacteria and overgrowth of other bacteria. So IIP recently did mention recommended probiotics for management of pediatric diarrhea. Besides rehydration, nutritional management, zinc, probiotics are effective in reducing the duration and intensity of symptoms. Antibiotics can be given at some point of time. But again, my last submission will be, when you think of probiotic, please use the quality probiotic, because there are a lot of studies which have shown that whatever is a label claim on the probiotic, the CFU on the probiotic, the strains on the probiotic, it has shown that it is not sufficient to that. So you should use quality probiotic, which is very important. You should ensure that you have adequate evidences on the probiotic. You should use the right dosage of probiotic. Colony forming unit is a very important. You should not use low dosage, which will not change your dysbiotic impact which is happening. And you should know the species you are using. Not all Bacillus clausii can be same, not all Saccharomyces boulardii can be same, similarly the Rhamnosus gg. So this is a very important point when you use probiotics. So urbanization has disrupted the gut microbial diversity, triggering dysbiosis and compromising metabolic immune function, potentially fueling the rise of non-communicable disease. India is the #1 in diabetes, that is what we are seeing, and that is one of the reasons for this. So our gut microbiota is also important to take care of that, and we all have a responsibility to take care of our small children. I'll just give one example because Nitin Shah is there. None of my own sons I have ever given antibiotic for acute watery diarrhea, and even my granddaughters I don't give acute watery diarrhea, so I have not given till date. So 3 years, 2 years. So when they went to Bombay, I asked Dr. Nitin Shah that whom should I show my granddaughter so that I can get assured no antibiotic given, because I know, as I said, you have to have a passion for your gut microbiota. I don't want to disturb the gut microbiota of my children. So he said, I am there closer to your place, and till date no antibiotic has been given. Thank you so much.
Thank you, Manjari, for your nice presentation. One thing I want to say that for the treatment of dysbiosis, it is not only the probiotic, but the healthy lifestyle, junk to be avoided, breastfeeding has to be given, and also misuse of antibiotic has to be prevented. So properly used antibiotic has to be given. Already Manjari mentioned about that. So probiotic, when we going to the treatment of dysbiosis, it is not the clearing of bacteria. Although it is an infectious disease chapter conference, it is not the killing of the bacteria, it is changing of the ecosystem that is needed. That is the most important thing, I think, because now we are relating all the disease with UISs and the dysbiosis. Thank you for the nice presentation. Manjari, if you want to say anything?
Yeah, that comes to the end of this session. My sincere thanks to both the speakers, my co-chairperson who happens to be my erstwhile teacher too, and all the audience for their patient hearing. Thank you.
So thank you. First, thank you the partners of this session, and also the chairperson Joydev Rai, Biplab Banerjee, and our two very important speakers, Dr. Bala Subramanian and Manjari Mitro. I request Dr. Shukanta Chatterjee to kindly hand over the memento at the memento corner. Please. So now our next presidential lecture by CIP President-elect. May I request Dr. Arup Roy as the chairperson of this session.
Good afternoon to everybody. Thanks the organizing committee. Now the session for our dearest, most dearest, down to earth President-elect, Professor M. Singaravalu. He is MD DCH DNB, Professor of Pediatrics and Dean at HOD Government Medical College, Tanajur. Now the most important IIP President-elect. And he is a good social worker of this country. So, podium is yours, sir. The topics on ethical dilemmas in pediatric practice, which is most very, very important subject that will be dealt by none other than our President-elect 2026, Professor M. Singaravalu. Thank you, sir.
Good afternoon to all of you. Thank you, Chairperson, my good friend Dr. Arup, for your nice introduction. At the outset, I thank the organizing team, my good friend Dr. Jaideep and Gundu sir, and all learned speakers, my friends. And this is going to be a somewhat a different topic among the very hot discussion. Theoretical session was going on, but when Jaideep called me, why don't you talk about ethical dilemmas? So I thought, definitely a lot of youngsters are there, budding pediatrician and a lot of youngsters, but it is going to be a very hot topic for future when you are in practice. Because why? When the child cannot choose, as you all know, it is the responsibility which lies on you. Because there is a gray zone tension in pediatrics. I will give you a practical framework. Of course, ethics comes everywhere. It is not only in pediatrics. But what is specific in pediatrics, as you all know, child cannot decide on its own. Parents are the surrogate decision makers. And whatever decision which you are making along with the parents, child, the sufferer, which we can question in future, but we have the responsibility. But the conflicts of interest are real. So this is the unique in pediatric practice, as I already told. The decisions are made for the child, but not by the child. So it is highly very emotional, but there is a legality, and also we have social responsibility. This we have to think it of whenever tricky situation comes. Second thing, what are the cost of ethical error if you are not planned at that point of time? One thing, we will be losing the trust, not only to the family, to the community, and what are the legal consequences which we are going to face later on, if not immediately. And of course, once one case comes, that is enough. We will not be able to concentrate anything which we are seeing as a person practicing in a semi-urban area. How much of difficulty we face when one child comes in risk where we are not able to decide, though we know the outcome, how to communicate with the parents, and the whole OP and the whole other things will be spoiled. And of course the family trauma. So this triangle, whatever we do, it is a best interest of the child, that every pediatrician work on that. But parental opinion we have to take. It is not that authority alone, autonomy alone. And we have the professional responsibility. One thing you remember, just because you can save a child, but because now everywhere the ICU has come, the better treatment modalities have come, you can save the child. But what is the outcome? Post-treatment, how the child is going to survive and the sequelae, that you have to always consider. As I told you, I can put the word as a brutal reality in the sense means when the patient cannot decide. But yes, patient's decision, what we are going to make is very, very important. And for my postgraduate students, you all read, that is why nowadays you people are, I always tell, they can learn everything through books. It is not. What is the real life situation comes, you have to take confidence of your seniors, which will help you for your practice. So, whenever the tricky situation comes, you have to think, what is the benefit you are going to come out of it? Or we are really doing any harm to the child. That means it is a saving the life versus preventing the suffering. That is also equally important. It is not the question of saving alone when I think. So, say one typical example, you can come across so many situations. A child you are ventilating, which has gone as a irreversible brain damage. You can prolong for days, months, as far as the child is being ventilated, but the outcome, what you are going to get, what are the resources, how much the family is going to lose, the mental trauma, all these things you have to consider when you do this thing. Second, the beneficiaries, not only that, what is autonomy? See, in pediatric, of course, the child cannot decide, I told, the parents, they cannot be the absolute owners. You remember that just because I told this treatment, it is an emergency situation where if you could intervene, the child could have been survived, but the parents are not willing. If this case comes in the court of law, we are liable for prosecution. So it means that parents can decide, but not absolutely. That is a point. But overriding parents' refusal in situation where the child can be saved, you have to make, then you have to explain. That means, say for example, in an antibiotic where severe sepsis, if we give the child can, like that. But if it is an elective procedure, where you cannot force a patient, you should do like that. Then it is a conflict of interest. So ultimately the justice, fair resource and all that, long-term ICU, which I already explained to you. This is very important, the limit of authority, what I explained already. In an elective procedure, 100% you can tell the parents, if they are not willing at this point of time or they want to go to a different setup, you can. In an emergency, when the life is in danger, you have to intervene at that point of time. That always I tell you, when the road traffic, no, the all legal court notice will come, we cannot, so many people will be crossing. So it is not, so we can, in an emergency situation as a doctor, we need not see anything, we can interfere and document properly and like that. So the article 21 says the right to life of anybody, that apply for our children also. Even in IPC section 92, if you are not giving the emergency treatment when the child has reached you, you can be prosecuted in the law. So these points you have to decide just because the parents are not. So how to overcome all these things? These 4 points, it is very important. The communication, that is more important, which is nowadays we have to concentrate more. In nowadays, when I started my practice and all that, I'll be seeing very sick cases in the midnight, 12 o'clock, the child will die. The parents, they will not ask anything, they will go. The doctor did the best, he did the best. So even I will not write anything because I didn't have time to document everything. I was seeing so many cases and all bad cases will be in my hospital. But I never bothered. But over a period of time, how documentation, now we are teaching our postgraduates, even undergraduates, more than treatment, how they should counsel the patient, how they have to document everything. Then if it is needed, you have to connect with your seniors and all that with a better rapport, and you have to get their opinion and everything you heard. So you have to proceed the treatment in emergency, but simultaneously you have to, counseling should be done, documentation should be done, all these things. This is, for example, as I told you, if the same child with a septic shock, if it would have been ventilated, the child could have been survived. So you should have done that. Then the resource setting comes, later on referring, transferring, all other things are different. So that you have to know that. So these are the 4 pillars which already enumerated as a ethical principle whenever the dilemma comes. Autonomy, you remember that child cannot explain. So it lies on the parents, but it is not 100%, they are only surrogate. But in case of emergency, you can take the lead. And whatever you you should see the beneficence versus harmful. It should not be non-maleficence. Your treatment should not do any harm ultimately to the family as a long-term suffering. Of course, ultimately the justice counts. So this can be overcome practically by proper counseling, documentation, and involve in institutions. Of course, every institution now we have ethical committee. What you have done, you can report to them and get their opinion, then inform to that family. So if you do this, even in later years, we don't know when we are getting problems nowadays. Even after 5-6 years, they can come for some problems. So make it very clear by our counseling. These are 3 points which I want to insist as far as this ethics concerned. Counseling, documentation. These 2 things are there. Whatever you do, then patients will. So with what are 2 examples? So this, because here we cannot follow everything based on textbooks. Your own experience, everything counts. Say for example, in prematurity. In our days, even 32, 34 weeks, which was very difficult to make survive. Then it came to 30, 28. Now even 23 weeks, the child can be made all right. Baby can be made all right if you have a proper NICU care. And of course, they have a deadline that below 22 weeks, it is no point in resuscitating, that the chances of survival is very much limited. From 23 to 25 years, it is a shared decision. If the parents willing, we can try. After 25 weeks, 26 weeks, chances of survival is very good, where we have to do the proper resuscitation. But here you remember always, don't blindly follow the numbers. Always we ask the definition, what is prematurity of our children? 37 completed weeks. So it is all for our theory to identification. But we have to see the situation where you are facing. Accordingly, you have to make a decision. But you have to follow the 4 pillars which I already enumerated. But this slide which I want to, with the good interest of the child, you are starting a treatment. So initiating a treatment is not a lifelong contract. It means that you are doing with a good intention. You are ventilating a child. The child is, if it is recovering, progressing after some time, okay. It is status quo. It is not improving. Sometimes it may deteriorate. No, I have started the treatment. Parents should not mistake me. I have to continue. It is not like that. So initiating treatment is not a harm where if you are not able to bring the recovery, it is not you made the disease. The patient died not because of you, it is by the disease which makes a child to die. So that means that you can plan with a good intention, start the treatment, and you can withdraw at any point of time if you don't expect a proper recovery. So this is the point which all of you should remember. But before going that, you see that you are explaining it, all these pillars of which I explained should be followed. See, this you remember, withdrawal also ethically identical to withholding. It means that when you are supposed to start the treatment, when you are not done that, you have done a wrong thing. When you are going to have to ventilate the child of septic shock, where you can make the child all right once the oxygenation improves, circulation improves. If like that, a child of acute renal failure, where if you do dialysis, the child may improve. But at the same time, when you should know the stopping ventilation or stopping dialysis, where there is no hope for further progress, is also ethically acceptable. This is what which I wanted to stress on you. So the key reality, what are I making the child to survive, or am I going to make it a harmful effects leading on a disabled? But disability is not a term, should be it even as if the parents accept, and if you are sure that if I do something, the child may definitely survive, it may become a disabled child, which we can make by other means of things, means we can try, which we have to explain to the parents and get their concurrence, so that high risk of disability, it means that we should not give treatment it is not. So you have to weigh the situation and according to the family situation. So these all come in the shared decision making. Doctor has to explain the medical facts, parents has to values and their preference you have to listen, then you can have a joint decision what finally you are going to do that. This is. Coming to adolescent, another case example. See, we have to maintain the confidentiality, as you all know. Yeah, that too in adolescent, they have the liberty to explain to you, and as a doctor we have to maintain some confidentiality. But for the interest of certain thing, say for example, child having sexual health or HIV positive young adolescent coming to you, sir, please don't inform my parents, they will. So there you have to be very careful, because if you are not doing for the interest, not only for the child, for the person, for the community purpose, otherwise he will be doing lot of harm to the society. A person with HIV starts having multiple partners, he will be spreading the disease and suicidal or drug addict. If you don't tell, he will continue to do that whatever you treatment. So you should assess the situation where you have to involve, and we can breach the confidentiality. This point which we have to take that. So you have to try to convince them, but they may be telling, sir, don't tell to my father, you can tell to my mother will understand. You have to take their values and we have to communicate. So these are all certain practical problems which you come across for the best interest of not only the patient. If you don't intervene, the problem going into the community, which you have to understand and all that. So when to break, as I already told, the risk of serious harm, not only to the individual, to the community, like suicidal attack, drug abuse, and all as spreading the disease like that. So handling such sensitive cases, you have to see the home environment and encourage voluntary disclosure from the patient. Then you can tell to the proper counseling. The counseling, by telling them they may accept, then you can inform to the family at all that. So the goal of here, shift from curing the patient and making him comfort. So focus on dignity and relief of suffering is more important. So the last one point I have to say. So many times when you withdraw some life support, the child may die. So is it equivalent to euthanasia? Many times people will say, oh, I should have continued it. If I have not done that, I have done a mistake to the child. It affects my conscience. It is not like that. So withdrawal of life support, coming to legal aspect. Suppose you are withdrawing the support, child is going to die naturally. Whoever it is. Many times in adult also, everywhere it is being done. So it is legally, ethically is acceptable. So because like stopping ventilation in a persistent vegetative state, otherwise as you long continue, child will be having the life, but is not going to be any effective. Whereas euthanasia is different. Here you are actively causing the death of the child, which is not, in our country it is not legally acceptable, but in few countries it is. So the clinical imperative must shift from saving life to relieving suffering when recovery becomes impossible. So this is where ethical dilemmas comes, where you have to ask. So end of life safeguards for which you have following, you should answer yourself. Am I sure that this child will not improve at all medically? What best treatment I am going to give? And you cannot decide on your own. When there are doubts, you can take your seniors, a lot of experts, get their opinion. Don't hesitate. Just because you are entitled the degree and started your practice, it doesn't mean that you should not ask you need not hesitate at all. So communicating with seniors, their experience will definitely help you and guide you when a tricky situation comes. Always get multiple medical opinions, conduct counseling, which I already told you. So it evolves only these things and ensure rigorous documentation and all this. So with this, it is acceptable and all that. So all the communication principle which I already told. So I'll be finishing shortly. This mainly the daily ethical is social media sharing. It is very important. Needs patient consent. Just people we see many times, they are blurring the face of the child and putting that also. If they start questioning, we are legally responsible. So we have to be very careful. Of course, pharma gift already a lot of discussions are going on regarding recording consultation. That also you have to get proper permission. We cannot record truth telling and age. So these are all the everyday problem where social media, you have to be very careful and all these things. And so the final takeaway in this is, ethics is not theory, it is a bedside medicine. So you have to learn by your own experience, and child, whatever it is ultimately the interest of the child, not for individual or not only for the family. So communication, again, repeatedly I am telling, this is the day where you have to have a better communication as well as documentation. And you will not get perfect answers, everything. Only you can make a better decision based on your situation. So these are the last thing. Is it is, as I repeatedly telling, interest of best of the child? Am I preventing harm or prolonging the suffering? Is the decision reversible or irreversible? Have I documented everything? Have I communicated honestly to the parents? If you have done this, then you need not have any confusion. You have done everything perfectly. With this, I once again thank the team, especially Jaideep, for giving me this wonderful opportunity. Thank you, sir. Thank you.
Thank you, sir. Thank you, sir, for your nice deliberation, which is the most important in our pediatric practice, the medical ethics in pediatrics practice, which runs on 4 pillars have been told already: the autonomy, the beneficiaries, and the maleficence and the justice. The most important, you have delivered the nicely in short term. Thank you, sir. Thank you, our President-elect, Dr. Professor M. Singaravalu. Thank you.
Thank you, Dr. Aduprai. Our beloved friend, he has come despite his limitations. It's a pleasure. May I request Dr. Ritobrata Kundu to please hand over a memento to him. So, with this,
Good afternoon, everyone. I welcome you to the National Summer CME of Pediatric Infectious Disease 2026. Now we will be moving on to the inauguration ceremony. Now may I request Dr. M. Singaravalu, President-elect, Central IP, to please come on stage.
So it's a great pleasure to have our President-elect, Dr. Singaravalu. So we would like to start by felicitating him. May I request Dr. Ritobrata Kundu and Dr. Khea also, please sit. And a special signature memento to the President-elect from us. This is the President's Gallery of Central IP 1964 onwards, and we are extremely privileged to have the 2027 President with us. So thank you, sir. Thank you for sparing your time, and it's a pleasure to have you with us. And
say, because having all my producers, because every day I can keep in my OPD so that I can learn from each and every one of you. Thank you, sir, for making it.
And also we'd be honored to present the President with a brass bell. Brass bell indicates spirituality and divinity. When the resonant sound goes, the evil goes away, and it brings spirituality and divinity. May I hand over the bell to sir? Sir, एक बार खोल के open it, sir. Sir, sit down.
Next, I would like to welcome Dr. Ruchira Maheshwari, Honorary Secretary General, Central IAP.
Sir, again it's pleasure to have Dr. Ruchira with us. She has just flown in from Noida. So thank you. May I request Dr. Kher to felicitate Dr. Ruchira. So welcome to Kolkata. And again a bell from us, please.
Next, I would like to welcome Dr. Shukanto Chatterjee, Vice President, Central IAP East Zone.
So Dr. Shukanto Chatterjee is like a father figure to us. Sir, here, sir. He was professor and HOD of Medical College and now Vice President of Central IAP. So it's great pleasure for us to felicitate sir. Thank you, sir.
Next, I would like to welcome Dr. Sanjay Ghorpade, Chairperson, PIDA.
So Dr. Sanjay Ghorpade from Satara, welcome.
Next, I would like to welcome Dr. K.K. Arora, Secretary, PIDA.
Dr. Arora. So let's continue. Please hold on. May I request our President-elect, Dr. Singaravelu, to please address the gathering by the time, Doctor.
Good afternoon to all of you. At the outset, I express my heartfelt gratitude for giving me this wonderful opportunity to serve a great organization of IAP for the year 2027, for which I thank each every one of you for giving me this opportunity. And greetings to our team of this midterms summer CME by our Gundu sir and Jaideep and Shreya ma'am. The moment I entered, I thought whether it is a state conference, even in national conference, in plenary session, also we are not having such a big crowd. So it gives the testimony of how this CME scientifically been crafted, the topics and all that, the speakers who are involved in that. I'm really hats off to the team and our ID chairperson Sanjay Ghorpade, our HSG Central AP Dr. Ruchira ma'am, and my past presidents here, Dr. Nitin Shah is there, and a lot of seniors, my friends are there, my dear IAPians. It is a great honor for me to be here as a part of this program and to inaugurate. Definitely the topics all very important and need of the topic, and all the experts across the country has been invited, and it is a great occasion for you to learn. I don't want to talk much and take your time because science should be given the priority in any conference. So it is only a part of thing is only the inaugural session. So I thank each and every one of you for giving me this opportunity again. I wish, as it is already going on very successfully, the subsequent events also go very usefully, and happy learning to all of you. Thank you all. Thank you.
Thank you so much, sir. Thank you.
Now, I would like to request Dr. K.K. Arora, Secretary PIDA, to please come up on stage. Next, I would like to welcome Dr. Mihir Sarkar, Secretary WBAP.
So thank you, Mihir. It's a pleasure to welcome Secretary of West Bengal Academy of Pediatrics. So in the meantime, may I request Dr. Ruchira Maheshwari, the Honorary Secretary General of Central IP, to please come and address the gathering.
Respected President-elect, Dr. M. Singarvelu, sir, the Vice President, Senior Vice President of IAP 2026, Dr. Sukanta Chatterjee, sir, the Organizing Chair of Summer CME, Dr. Ritabruta Kundu, sir, the Organizing Secretary of this prestigious CME, Dr. Joydeep Chaudhary ji, and my very dear friend, Dr. Khia Uttam Ghosh, the chairperson of National PIDA chapter, Dr. Sanjay Ghorpade ji, and Dr. K.K. Arora sir, the secretary, Dr. Mihir Sarkar, Secretary of West Bengal Academy of Pediatrics. The dignitaries need to be acknowledged: Dr. Nitin Shah, Dr. S. Balasubramaniam sir, Dr. Kasi sir, Dr. Bhaskar Shinoy sir, and Dr. Yagnesh Popat, Dr. Manjari Shah, Kalpana Datta, Dr. Surendra Nath, and Dr. Manglek, and all the dear friends, colleagues. A very good afternoon to one and all. It truly is a matter of pride and privilege to be standing here today on the land of joy, a city of joy, that is Kolkata. Known for its heritage, Kolkata not only known for as culture, a city of joy, but from the vibrant Havra Bridge to the serenity of Hooghly River, and from the literary heritage to the excellent and the deep down medical knowledge, this city has definitely shown warmth, integrity, and excellence in all the fields. Coming on to this CME, I would like to congratulate Dr. Ritabruta Kundu sir, Dr. Joydeep Chaudhary, and Dr. Khia for coming up with a platform which is giving sharing knowledge or providing a sharing knowledge among experts, practicing pediatricians, and the young mind, so that they can collaborate together, they can inspire each other and mentor, and the seniors can mentor the young minds. It's high time when these such meetings should happen and the people can be in line with the evidence-based practices. Along with innovations and critical thinking, these are need of an hour for today's time. Coming to central IAP. Dear friends, IAP is going through little turmoil across the country due to certain issues known to all of you, but I request you, all of you, to kindly stand firmly with your parent organization to support for the cause, as IAP is clear in its stand. IAP is only for percolating rational medical knowledge, no here and there things with IAP. It's very clear-cut stand with IAP. I request all of you to kindly get benefited by our IAP Digi. The program, which is an iconic program under the leadership of our current president, Dr. Neelam Mohan, in which you will find that daily, day and night, afternoon and evening time, you will find continuous sessions going on, from learning together, growing together, to meet the mentors and PG clinics, many programs going on. I request all of you to kindly get benefit of these programs. To the postgraduates who are here, I know there are a lot of postgraduates in this gathering. I wish to share with you that IAP has come up with a research fund, and we have a properly structured research committee. I request all of you to kindly get benefited. IAP is providing research fund for postgraduates as well as undergraduates. So, and also to practicing pediatrician. If someone is interested, please send a mail to centraloffice@iapindia.org with your research project. Our team will definitely look into the matter and will get back to you. So this is very ambitious project, and I request all of you to get benefited. This is a project of current year president as well as our president-elect, Dr. Singravelu sir. For 2 years you will find these research project to go on. So please get benefited. Not only this, but IAP is also going for social work, charity work, other than academics. Lot of modules going on. So I request all of you to actively participate and get benefited. Again, I would like to thank you, organizers, for giving me this opportunity to come over here and share this platform with you all. Thank you very much. Thank you. Jai Hind, Jai IAP.
Thank you, Dr. Ruchira. May I request Vice President, Central IAP East Zone, Dr. Shukanto Chatterjee, to please deliver his brief address.
Good afternoon, and I must first of all take the name of our President-elect, Dr. Singravelu, Secretary, Dr. Ruchira Madam, and all the dignitaries present in the dais. But I will particularly thank Dr. Ritubrata Kundu and the team, Jaideep Chaudhary, Khea, and all that for felicitating me here after I became the Vice President. I am really thankful to you for that. And I must appeal to all of you to take this IAP to the forefront, because IAP is Indian Academy of Pediatrics. It's not Indian Academy of Politics. As we are entering into the different controversies and all that. So these things must be very clear. What Ruchira has also told, let us keep Indian Academy of Pediatrics purely academic body and propagate the academic message and do the welfare of the children of the country. So that's my short and brief message, and in doing so there could be many difficulties, but let us unite together to overcome it as an organization. Thank you very much.
I would like to welcome Dr. K.K. Arora, Secretary, PIDA.
So thank you, Dr. Arora, for being with us. So, just to share with you that our President-elect Dr. Singaravelu, he has to catch a flight. So we will have the inauguration first, then address by our chairperson. So, in a unique way that we want to do, it's a gong that. So may I request our President-elect to hit at the center. Sir. Luchida. Dr. Sanjay, your turn. Dr. Arora. No, me. And Mihir, please. So, may I request Dr. Anurag Agarwal, who is the Joint Secretary of Central IFP, to please come. So, Dr. Anurag Agarwal, please. Please. Yeah, please. Yeah. And it's your turn, please. So thank you. This sounds the inauguration, and again I am grateful to Dr. Singaravelu. You can please, we will stay back. You can please proceed for your. Thank you all. Thank you. Now may I request Dr. Sanjay Ghorpade, who is the chairperson of Pediatric Infectious Disease Academy, to please deliver his brief address to the gathering.
Dignitaries on the dais, off the dais, my all senior colleagues and delegates and all the faculties. Good afternoon. As a chairperson of PIDA, it is a privilege me to be here because this is one of the biggest chapter, more than 4,000 members, and so many stalwarts built up this chapter, right from Dr. A. Parsarthi, Dr. Jacob Jain, and currently sitting the past chairperson, Dr. SBS sir, Bhaskar is there, Dr. Utpapa Kundu sir, Jaideep, and so a number of the past chairpersons built up this chapter. And because of this, today we are here. One more thing, I definitely appreciate the organizing team of this summer CME, Dr. Uttapapa Kundu, Dr. Jaideep, Dr. Khea, and all other team members. A big round of applause for this fantastic conference, not in terms of science, but yes, in terms of the science, faculty, and number of delegates. And I appreciate that at least 400 to 500 delegates are sitting inside the hall, because this is the first time in the history actually I am seeing this like that. Actually, I attended so many conferences, 50% delegates are outside in the hall, but here I really appreciate the thing that what way the science is built up by this team and what way the faculties have chosen for that definitely attracts the audience and delegates. That's why they are sitting inside the hall. And this is not the only year, past so many years they are doing the same thing and again contributing the PIDA in terms of financial part. Of course, that is a wonderful job whenever I sing for. Friends, this year we had lot of activities. We started with the Pedicon Symposia at Kolkata. Then first specialty conferences we did, that is only on single subject conference at New Adicon, more than 300 delegates we did at Agra. This year, apart from our regular activities of the summer CME that is happening today and national midterm PIDA CME that is happening at Chennai under leadership of Dr. SBS sir, Janani madam, and all the Chennai team. Under the chairperson action plan, we are doing more than 6 national level events. Out of that, one is already been finished, that is in Agra. Second event we are doing in Hyderabad, that a single subject conference that is called as National PIDA Vaccicon. 2 days only discussion on vaccine with the authority national speakers, and of course Dr. Surendra is here, he is a person behind that. The third national, a single subject conference we are doing, that is respiratory infections. 2 chapters are joining hands together, national respiratory chapter with the PIDA, and of course we are doing in the first week of the July. Dr. Chetan is here, he is a man behind that conference. And that will again more than 400 to 500 delegates with the 50% faculties will be pulmonologists, 50% will be ID experts. An interactive discussion will be there at the Ahmedabad. The fourth national event we are planning in the Jaipur, that is the National NF joining hands with the PIDA, and name will Neo ID Summit. Again, more than 400 to 500 delegates we expect. 50% faculties will be neonatology, 50% will be the ID experts, and that will be at Jaipur in the month of the August 3rd week. One more thing actually we are doing exclusively, and that is out of box things, and this is not happened so many years, that only updates in PID. What are the latest guidelines or latest things have actually came in the picture in last 10 years? We are doing the 2 days conference at Rajkot, that is called as a PIDA update. And Dr. Yadnesh is here, a date we are finalizing soon, that will be at Rajkot, that will be only PIDA updates, and that will be discussing all the advances, what happens last 10 to 20 years in the pediatric infectious diseases. Of course, NCPID is our hallmark, and that is the national conference of our PIDA, that NCPID will be happening in the Pune. A team is working on that with 2 concurrent halls, more than 100 to 150 faculties, international faculties, and 2-day science with the workshops we are doing in Pune. We expect more than 1,000 delegates in Pune. And I will conclude my tenure with the December, and of course that is one more thing we are doing, only conference on the pediatric critical care infections. Pediatric intensive care chapter, Dr. Eber Japok, who is the chairperson of chapter, a pediatric critical care chapter joining hands with the pediatric infectious disease chapter. Again, a 2 days conference, a 2-day science only on pediatric critical care infections, and that will happening in Guwahati, a dynamic team under leadership of Dr. Rachana Das Madam, Devji Sharma, and all the team of the Guwahati. That will be in the first week of December. Here ends our tenure. These are all national events in the history of the PIDA we are doing this year. Apart from that, yes, regular journal is going on. Dr. Bhaskar is doing that. Fellowship program is going smoothly. And one more activity actually we are launching in the month of the May, that is a non-responding infections. That module, brainchild of the Bhaskar and SBS sir. We are starting the minimum 20 programs across India, at least 4 to 5 programs per zone we are doing that part. And of course, the micro is supporting that program. And that will be for the peripheral pediatrician, Tier 2 cities we are mobilizing a module on behalf of PIDA, that will be called as NRI or non-responding infections. Yes, of course, then regional CMEs, that will totally be handled by, of course, the Chetan, and he will doing the more than 10 to 12 regional CME with the help of the academic grant from Bharat Biotech. That will encourage the peripheral part of the country. So, lot of these things we are doing for our members. Yes, our PIDA members are quite active, our faculties are quite active and very cooperative, and we can say that PIDA is like a family, and we are our family members, and proud of that. Since last more than 15 to 16 years I am active in the chapter, and I do not feel anything that I am out from this family. So this is, I am one of the member, one of the part of family, and all the members along with the all seniors are always supportive, encouraging me in whatever I am doing for. With this, of course, I am wishing all the best wishes to this team, whatever the things actually up till now achieved. Till tomorrow will be again the same things with the same crowd, and lot of the discussion will be benefited to the delegates who are attending this conference. Wishing all the best wishes, Jaydeep and Dr. Ruthapapa sir and KR team, and thank you for inviting me to be here for this inaugural function. Thank you very much.
Thank you. Next, may I request Dr. K.K. Arora, the Secretary, to deliver his brief address.
Thank you, team Summer CME Kolkata, for inviting us and giving us this chance. I am very happy to say that Kolkata is like my second home. I have started, I became the member of infectious disease chapter because of Tapanda. He wanted that there was, at that time there was no representation from central part of India. There was nobody. So he insisted that there should be some active members who should come forward and propagate ID all over India. And for the first time, he invited me in 2008 in this summer CME only, and he made me one of the panelists with leading Dr. Sangeeta Sharma. She was talking something about advances in tuberculosis that time, and I was so new for the stage. I was really frightened that how I would be able to answer or put any comments on such before such an stalwart. So this is how I started my journey from this place, and I have received all the time too much of love and affection from the people from Kolkata. Secondly, our president, Dr. Ghorpade, he is doing a wonderful work. He has planned the all-year activities so beautifully. Say we had in ID especially 3 events: summer CME, midterm CME and NCPID, and plus a couple of regional activities. But now he had beautifully crafted many national activities with help of other chapters. So this will really give the chance not only to the audience but to even the ID faculties also to be more conversant with the different part of country and different groups also. So very big leap taken by Dr. Sanjay Ghorpade. We are thankful to him, and he is under his leadership. I am really very thankful that I will be able to contribute something for the chapter. With that, I'll say thank you to all. Thank you very much for inviting me here.
Thank you so much. Pediatric infectious disease chapter always strives for academic excellence. And we have a fellowship course also. So may I invite Dr. Bhaskar Shenoy, who is the coordinator of the Pediatric Infectious Fellowship Program and also the chairperson of PIDA, Dr. Surendranath, please come onto the dais. So Dr. Bhaskar Shenoy, we can stand because we felicitate you. So thank you, Dr. Bhaskar and Dr. Surendranath. So in the last year's fellowship examination, 3 fellows qualified for Pediatric Infectious Disease Fellowship. Only one of those fellows is present here today. So we have the privilege of felicitating Dr. Pratiksha Khatua from Kolkata, and may I request Dr. Bhaskar and Dr. Surendranath to please felicitate. Please hand over the fellowship certificate to Dr. Pratiksha Khatua. So with this, I request the organizing secretary, Dr. Khea Ghosh-Uttam, to please place the vote of thanks.
On behalf of PIDA Kolkata, I have the privilege to propose this vote of thanks for this summer CME. I'm very much grateful to the National President-elect, Dr. Singhara, National Secretary, our Vice President, who was also my teacher, Dr. Shukanta Chatterjee, and all the dignitaries on the dais. Of course, I have my mentor, Sir Joydeep Da, and I'm very much thankful to all the national faculty and such esteemed faculty like Dr. Balasubramaniam sir, Dr. Bhaskar Shenoy. So when we were students, we used to hear about them, and we were so used to listen perplexed by this. And of course, I would like to thank all the audience, though I think they have gone for the lunch, for such a good their presence, their interactions. And of course, I would like to thank all the sponsors and the team behind this, we 3 people, because we are at the surface, so you are seeing us. But we have a great team of us, students and the junior colleagues who are managing the CME. So I'm thankful to each and every one of us. And we wish to carry on like this with all of your blessings. Thank you so much.
So thank you. With this, we end the brief inauguration ceremony. Please proceed for lunch. And we will assemble dot at 1:45 because we stick to time. So 1:45 we reassemble for the next session. Thank you all.
So, our partnership session continues. I'd like to call the chairpersons, Kamal Kishore Singh and Vinay Achwa. Please come and take your chair. Hello. So, our partnership session starts. I'd like to call upon N. Kamal Kishore Singh. Are you there? Kamal Kishore Singh and Vinay Achwa. Please.
Hello. So good afternoon everyone. After this post-lunch session, we have got a session which have 3 topics, and these 3 are very good topics. The first is by Dr. Abhijit Sarkar from Howrah. He will be speaking on update in 6-in-1 ready-to-use vaccine, preterm data and data in special population. Dr. Abhijit Sarkar, please.
Hello, check. Good afternoon. Welcome back to the most challenging session of the day. It's the battle between knowledge and, I suppose, the lunch gravity. We'll have to make the science better, I suppose. Okay, now I'll be talking about the updates in the ready-to-use hexavalent vaccine from Sanofi, and this program is sponsored by them. Now, the vaccine, which we all know is Hexaxim, is a very well-known, respected brand worldwide. Almost 120 countries use this vaccine. And over the last more than a decade or so, its journey started. In 2012-13, It was approved and registered with the European Union. And then it received the WHO pre-qualification in 2014. In 2015-16, it had co-administration data with the meningococcal vaccines. 2018, its market authorization was renewed at the European Union. In 2020 and 21, its use in babies who are preterm, its use in babies who have HIV exposure have been studied. Its co-administration with varicella vaccine was also studied in 2022, and the journey goes on with this vaccine. Now, we are all aware this vaccine is a kind of a ready-to-use vaccine. We don't need to reconstitute it. We don't need to mix the 5-component liquid with a lyophilized HIP component. So it's a ready-to-use one. You just take it out and inject. It has got a good shelf life, almost 3 years in 2 to 8 degrees centigrade. And incidentally, it has been shown to be, kind of stable at 25 degrees centigrade for at least 72 hours also. Now, this vaccine has gone through thorough clinical development, looking at its safety and immunogenicity in different settings. It has been studied at different vaccination schedules, like 3-dose schedule with 6, 10, 14 weeks that we do in India. And 2, 3, 4 months, 2, 4, 6 months schedules which have been used in the European countries has also been studied with this vaccine. 2-dose primary schedule, booster, everything has been done with this vaccine with good response. The vaccine has been compared at different control vaccines like the GSK vaccine with Infectious Hexa. It has been controlled with Pentaxim, as well as studies against the whole cell containing hexavalent, pentavalent vaccines. The vaccine has been concomitantly used in, with other vaccines, pneumococcal, rotavirus, meningococcal, etc. Everywhere the immunogenicity is good. Vaccine has been used in different populations as well, like term infants, preterm infants, infants born to mothers who had Tdap vaccination as antenatal dose, and well as kind of HIV exposed infants as well. A few of those information we'll be discussing today as well. For the preterm, we all know that as per definition, babies born below completed weeks at 37 weeks are preterm, and most of these, almost 85%, are kind of late preterm, moderate preterm, between 32 to 37 weeks. Some are very preterm or extremely preterm. Now, the thing about preterm is that they are more vulnerable to vaccine-preventable diseases, as we are all aware. The babies have kind of immature immune system as compared to term babies. They have not received the kind of transplacental transfer from the mother, the antibodies, so they are unprotected or less protected. They are more exposed to NICU stays and nosocomial infection. They are more prone to kind of interventions like venipunctures and arterial lines and AT tubes and all. They have suboptimal nutrition, which affects the developing kind of immune system. So all of these causes more infection, mortality, and morbidity in this group of babies. So these babies should be vaccinated at chronological age without waiting. And when we look at the burden of this kind of babies in India, almost 13% all babies born in India are preterm. Almost 28% all babies born in India are low birth weight. So these are huge. In millions of these numbers are there, and these babies are really very prone to all kinds of infections. So that's one of the main reasons why we as a country are the leading cause have under 5 mortality in our country. We need to tackle this. Now, let's look at this particular vaccine's immunogenicity in a few groups of babies. Now, this is a relatively new study published in 2023 in Belgium. They looked at the vaccine's efficacy, immunogenicity in term infants, preterm infants, and also 2 cohorts. One cohort infants born to mother with antenatal Tdap, and the other cohort infants born to mothers who did not receive the antenatal Tdap. Now, when the term and the preterm groups were compared for the immunogenicity, the solid bands represent the term infants and the speckled bands represent the preterm infants. The solid bands are the preterm infants, the speckled bands are the term infants. So if you look at all the antigens, post-primary series, that is 1 month after the last 3 primary doses, they found all the antigens have seroprotective levels at par with the term infants, preterm and term, except perhaps the hepatitis B and the PRP, that is the HIP antigens, where there is a kind of suboptimal response after the post-primary doses. But then this is also made up after the booster doses. So this vaccine is immunogenic in term and preterm infants as well. So again, this particular study also looked at babies who received whose mothers received the Tdap, antenatal Tdap, the darker bands, and babies whose mother did not receive the antenatal Tdap. Again, the immunogenicity, if you can see, for the tetanus, diphtheria, whooping cough are all at par with both the groups. There is no significant clinical suppression of the antigenicity of this vaccine if the mothers were given Tdap, which is expected at least after the post-primary schedule is completed. A safety study from Italy in 2020. This is again a relatively new study where they looked at almost 339 kids, and they found the most of the adverse events after immunization were kind of local injection site reactions like redness, swelling, induration, nodule. Very less kind of systemic reactions apart from irritability and fever. So basically this vaccine is pretty reassuring in its safety profile in preterm infants usage. The same study also looked at, compared the AEFI between the preterm infants, that is group A, against group B. As you can see, just the site induration and the site nodule reactions are slightly higher in the group A as compared to group B, so that these are local reactions. So the side effects are more or less at par for the preterm and the term. A study in Chile in 2021, which they published, they looked at the reactogenicity of this vaccine against wholesale containing vaccine. Now, Chile actually switched from the wholesale vaccine they used to use in the national immunization program in 2018-19 to a cellular containing vaccine, and they kind of collected data from 2015 to 2020, compared the kind of adverse events, and they to find out if the switch from wholesale to a cellular actually reduced the kind of adverse events. Now, out of the total of some 1,697 AEFI reported in this study, 41 AEFI were recorded in premature infants, and there was a trend in falling AEFI since 2017 after the switch happened. Now, out of the total of adverse events of 41, 46% were serious adverse events, and out of this 46%, 75% of those vaccinees received the wholesale vaccine, and 25% received the acellular containing vaccines. And most of the adverse events in the preterms were apnea, cyanosis, decreased oxygen saturation, pain at injection site. And there were no AEFIs in the moderate and late preterm infants. So basically this vaccine seems to be pretty safe and less reactogenic. In Europe, they kind of reviewed data, post-marketing data, and included some 164,000 preterm infants across 9 European countries, analyzed the post-marketing safety data, and they found that vaccine is no risk with this vaccine in preterm infants, and the European Marketing Authorization granted permission for the continued usage of this vaccine in preterm infants due to its well-established safety records. A study from South Africa, 2021, so they basically looked at the immunogenicity and safety of this hexavalent vaccine in babies who are exposed to HIV, infected as well as non-infected. And when they compared the kind of immunogenicity, the seroprotective levels for these two groups of babies, they found there is no much difference between the immunogenicity of this vaccine for each of the antigens in both the groups, either infected or uninfected with HIV. Now, obviously the HIV infected ones received antiretroviral therapy. They had a CD4 count which was acceptable. I suppose that's the reason why they have got an equivalent report. Now, this is an immunogenicity study of this particular vaccine in the Indian setting. It was a phase 3 open-label multi-center study between February and October 2014 in 2 tertiary care hospitals. And they found again the antigenicity for all the antigens in this particular vaccine has been excellent, and they produce good results. Now, looking at the hepatitis B, and now why hepatitis B? Hexaxim contains a particular hepatitis B surface antigen as it kind of antigen which is manufactured on a different platform. They have used a different yeast like Hansenula polymorpha, which is different from the Saccharomyces cerevisiae, which is the standard yeast to manufacture hepatitis B antigens. Now, this antigen, due to its kind of different platform, shows a good antigenicity. It's very good response in hepatitis B groups which had the hepatitis B birth dose or not have the birth dose, both the groups had excellent results with excellent GMC kind of levels as well. So this polymorph expression system is 100% seroprotective in Indian infants and gives at least duration of protection at least for 9 years. So that's the hepatitis B which this vaccine contains. Other component discussion point about this vaccine when used with other vaccines has not got any kind of adverse events. But then when you compare the other hexavalent which is available, has shown some inconsistent antibody response to poliovirus type 2, as well as there is increased reports of convulsions with or without kind of fever if it is used with Prevenar, and that is there in their product insert as well. And these problems are not there with Hexaxim. Now, benefits of liquid vaccines, ready-to-use vaccine. As I've already mentioned, this particular vaccine does not require a reconstitution. It comes just in liquid form. You just open it and inject it. You don't need to kind of mix it. There's a study, important kind of study which interesting study which they did in Belgium. They found that the preparation time is half that of if you reconstitute. The more importantly, there is almost 5 times less events of vaccine error. That we often face. Vaccine errors like fingers touching the sterile part of the constitution vial or the needle getting twisted during insertion through a vial stopper. This does not happen with this vaccine. And the reconstitution misstep, and this is something which we may have faced. Like for example, we have opened the other vaccine we are talking about, the hexavalent vaccine. We inject the liquid component, forget to mix with the lyophilized HIP component. And then it becomes a really, it's a damage control situation and it's very embarrassing. So you'll have to explain to parents and all that we have done this out of mistake, so you'll have to correct it again. But these problems won't happen with this particular vaccine because there is no mixing and reconstitution required. So it reduces the time to vaccinate, it assures the patient safety, reduces health hazards and reduces vaccine handling error as well. So for all the stakeholders in this vaccination, it's good for the children, obviously, it's good for the parents, doctors and nurses, we are happy because it takes less time, there's less vaccine error possibility, and if it's used in the national immunization program, it's convenient for the whole public health system as well. Thank you so much for patient hearing. Thank you.
Thank you, Dr. Shorkar. Difficult topic, very nicely presented, though more statistically oriented. Thank you.
Thank you, sir.
So now we have the second session, and a speaker is none other than Dr. Nitin Shah. He'll be speaking on cholera and chikungunya, current epidemiology, prevention and control in the modern era. Dr. Nitin Shah, please.
Where's my PPT? Okay, leave it. All right. I'm so happy to come back to the second home, as I said, Kolkata, for various reasons, to meet friends and to have Mishti Doi. And thanks the organizers for arranging for Mishti Doi today. I'll speak on this very new vaccine, cholera vaccine. These are my disclosures. So, between last 25 years, as per WHO, there were 81 lakh cases of cholera in the world, which resulted in nearly 1 lakh death, with a case fatality of 1.1% in spite of ORS and IV fluids now easily available as compared to during the 1971 Bangladesh war. And not one but 97 countries in the world are actually reporting cholera every year. Now if you see last year 25, this is the world map, and you can see the Africa is the most infected area as far as cholera is concerned, some of them having more than 100 cases per 100,000, that's like 1 per 1,000. India is not that badly affected, but still has around 5 to 10 cases per 100,000 population. Now India is not one country, it's a continent. So different parts of country also have different incidence of cholera, and this is last 10 years. So you can see Maharashtra, where I come from, and Karnataka have a very high disease burden, so also Gujarat, but also West Bengal, where we are. And over the years, cholera has come down, but not gone away from our country. And if you actually see the recent paper, this is from Madhya Pradesh, where they actually reported a huge number of cases from MP. This is in Hindu, April 2025, cases from Trivandrum, one of the most developed part of the country. Then if you see in June 25, Odisha, October 25, Delhi had a outbreak of cholera. Then in AP in December 2025, this year January 400 cases of cholera in Ahmedabad alone in last 3 years, and annually 1 million cases and 100,000 deaths occur world over. We are in the current 7th pandemic which is still ongoing. Now we all know cholera is because the cholera organism, which is a gram-negative coma-like bacilli, we all have seen as undergraduates during our student time a hanging drop, something which is rare. Maybe the students today may not even know how to diagnose. But what we are recently seeing is the O1 strain, and there are two types, classical and Eltor, and each one of them have Inaba and Ogawa. When Inaba shifts to Ogawa and vice versa, intermediary you have one strain known as Hikojima. Now why am I stressing on this is because Hikojima is a strain which is used in the new cholera vaccine from the biological Bharat Biotech. Alright, so what are the vaccines available? And you will be surprised that there are several vaccines, cholera vaccines, which have been invented and used in the world, right from Bangladesh to Vietnam, internationally Dukoral, which is for the international travelers. We had the Vietnam having this M-Orca-Vax, which is then given as a technology transfer to Shanta Biotech that time to make Shenkol, which then was taken over by Sanofi, so it became Shenkol continued, and for some reason Shenkol has now been withdrawn. So we didn't have any cholera vaccine till the time the new vaccine on your extreme right, Hilcol, which has now come from the Bharat Biotech. Now we will only concentrate on these two vaccines because they are the ones which are available or are now available in India. Now I'll talk on Shenkol first because the current vaccine which is available is compared on immunologically non-inferiority to the Shenkol vaccine. And Shenkol had data both on immunogenicity as well as a field efficacy. So if the new vaccine is immunologically non-inferior, we would expect similar efficacy. So it's important to know what are the data with the Shenkol. The WHO pre-qualified vaccine, it was a wholesale inactivated cholera vaccine which had multiple strains of cholera. O139, Inaba, Ogawa, formaldehyde killed, heat killed. So all sorts of combinations of the strains were there. So it was not a single strain vaccine, it was a killed vaccine. It underwent field efficacy trial in Kolkata, where you are, Dr. Deepika Sur, and I remember talking to her, a brilliant study they had done, what we know as cluster randomized control. They took some clusters where they gave vaccine, some cluster where they gave placebo, and looked at the cholera incidence in both these arms. So this was the field efficacy done in almost 10 years back. They took more than 1 year old subjects, they gave them 2 doses, 2 weeks apart, oral vaccine without buffer. Alright, it was a cluster randomized double-blind placebo control. So there was a placebo given. So almost 17 clusters were in the vaccine arm and 1700 clusters in the placebo arm, each having 30,000 subjects which were enrolled for vaccine versus placebo. Idea was an interim analysis is 2 years. If you find the efficacy is good, continue till 5 years. And what were the data? So if you look at the per protocol, efficacy overall was 67%. In children between 1 to 5 years, it was a little lesser at around 50%. Older than 5 years was very high, 87%. And older than 15 years was 63%. And this was at 2 years. And when they recently published the paper 2013 for the 5 years data, it showed the efficacy is almost the same, persisting at 65% overall. So 67% at 2 years and 65 at 5 years. I think is a decent. I mean, there's no better cholera vaccine in the world which has higher efficacy than this vaccine had and persisting for 5 years. All the old cholera vaccine, the problem was only limited efficacy and that too persisting from 6 months to 1 year at the most. So it was more like a traveler's vaccine rather than a vaccine which you can use to control endemic cholera which is there in the world. Alright, so then came this new vaccine, a joint venture with the MSD Wellcome Trust and the Bharat Biotech from the Hillman laboratory. Hillman is the person who actually had the laboratory where he invented this unique strain of cholera vaccine, and that's why it's known as Hilcol because it comes from Hillman laboratory. So it has undergone a phase 3 trial. Because of lack of time I won't go into details of it, but suffice to say that they compared Hilcol versus Shenkol, and I showed you the data with Shenkol. So what they looked at the safety and immunogenicity and not efficacy. because that was not required as per the WHO. And a lot-to-lot consistency, so that you have a manufacturing process which is very consistent. So that's typical phase 3 trial for any new vaccine. This was very recently done in May 22 to 23 February, 10 centers across the country, and they took 1600 participants and enrolled them for safety and immunogenicity. So there are 3 age group, 1 to 18 years, that is children, 5 to 18 years subset, and group 3 was 1 to 5 years. So you had 1 to 5 year children, 5 to 18 year children, and adults above 18 years. So these 3 groups. And they randomized them to 3:1 to receive the new vaccine Hillcol or Shencol. So almost 450 subjects received Hillcol and 150 received Shencol in each of these 3 arms. So that's how you had almost 1600 participants overall in this study. And they took another 1600 only for safety, so that they know how safe is the vaccine. It is a 1.5 ml ready to use vial which you just break open like a Respule and give by mouth. 2 doses again, 2 weeks apart, like the Shencol. So what they looked at? They looked at the vibriocidal IgG response 14 days post dose 2 against Inaba and Ogawa. Though this was a Hikojima strain, it actually leads to immunization against Inaba and Ogawa strain. And the non-inferiority criteria was that when you compare the new vaccine with the old vaccine, the difference between the two seroconversion should be above -10. The lower bound confidence interval should be above -10, and that is on the seroconversion. And on the titer ratio, you look at the new vaccine versus old vaccine, and the lower bound confidence interval of the ratio should be above 0.667. Many vaccines have 0.5 as a cutoff, like pneumococcal. They took 0.667, like was seen with the HPV vaccine. So what are the data? Phase 3 data, seroconversion overall was 69.5% with Hillcol, which is in the pink color, and 67.4% with the purple, which is the Shencol. So you can see it was almost similar. There was no statistical significant difference. And if you now compare the groups, then 1 to 5 year children consistently had 69%, which was similar to 70% for 5 to 18 years and 69% for 1 to 18 years. Which means this vaccine as compared to Shencol actually did better immunogenicity even in young children 1 to 5 years, because I showed you that children 1 to 5 years in Shencol efficacy was lower as compared to 5 to 15 years. But that doesn't seem to be here because the immunogenicity was better even in that young child. So across the age group 1 to above 18 years, immunogenicity was seen in almost 70% of the subjects. That was again the Inaba, and you can see Ogawa is almost the same, 67, 66 and 69. So both the strains, seroconversion showing good results. And they continue to look at the seroconversion over 180 days. So that was just two weeks after the second dose. This is up to 180 days. You can see there is some drop, like happens with all the vaccine, for the first 60 days to 1 year, and then there is a plateau. And that's what's same thing has happened for the Ogawa as well as Inaba strain, that the vaccine are running very parallel, so the drop is very parallel, and there is no precipitate fall with either of the vaccine. These are the titers. So you can see overall titers were 195 with against the Inaba with the Hillcol, and 195 with the Shencol, and against Ogawa on the right hand side was 201 and 189. And you can see whether it is 1 to 18 years, 5 to 18 years, or 1 to 5 years, the titers were very similar. So as far as titers were concerned, they were very similar between the two vaccines in all the age groups. And if you look at the Ogawa, then again you can see the titers were a little higher, but again they were very similar between the two vaccines, so there was no statistical significant difference between the two vaccines. Now comes the safety. So subjects were observed for 30 minutes post each dose to see for immediate side effect. They were followed up on a telephonic call every day for the first 7 days for the solicited other adverse effect, and the unsolicited adverse effect, like any other side effect. It can be pneumonia, accident, snake poisoning, bite, anything. It is captured throughout the study period of the follow-up that was done. And this is a very big table. I will just make it very simple for you to say that overall side effect was seen in 12% with the new vaccine, 9.3% with the Shencol, so very different, very similar. In adults, same way in children 5 to 18 years, 11 and 10%, 1 to 5 years 10 and 10%, and overall 11 and 10%. So there was statistically no difference between the two vaccines as far as safety is concerned. And the most important side effects were nausea and vomiting and some abdominal pain. Now, I have had some phone calls from some subjects, some pediatricians who use this vaccine in Gujarat, and he said a lot of children vomit. So you should remember when you give this vaccine, like when you used to give Shenkol, it is a little bitter vaccine. So you should give them a cup of some flavored solution, like say juice or lime juice or any fruit juice, something, so that it masks the taste of the vaccine. So don't just thirst the vaccine, otherwise child is likely to vomit. You see with Rota also sometimes children vomit. So more so with this vaccine, so try to give them with a cup of some nice drink which they like in their life. Alright, that was as far as the immediate side effect. The 7 days unsolicited, fever, pain, chills, diarrhea, anything can be captured, but it was very low. You can see less than 1% of the subject actually overall had either of the side effect, and none of them were statistically significant or related to the vaccine. So what is the product profile? It is 900 microgram of the lipopolysaccharide of the V. cholera, but a very unique strain. It is not a multi-strain vaccine. It is O1 Eltor Hikojima serotype, which is recombinant strain. So they captured that Hikojima when it was shifting from Inaba to Ogawa and vice versa, and then made it into a recombinant strain, stable, and then propagate in the culture medium to make it into a stable strain, and then they kill it and take only the lipopolysaccharide in a correct measure of 900 microgram by killing it with formaldehyde and use that as the vaccine. And it is put in 1.5 ml of phosphated buffer. So there is buffer already built in, but as I said, yet you will give him with some 1 cup of nice drink so that the child has less chance of vomiting. It's a single dose in Respule, so you twist open and give it. 1.5 ml is the dose. You give 2 doses, day 1 and day 0 and day 14. But if day 14 is delayed, doesn't matter, you can give it as early as possible thereafter. It is licensed for use above 1 year of age. Recently it has been marketed, and it is to be stored between 2 to 8 degrees. So that is where this new vaccine stands. The big question is where do you use it? So you don't use it in day-to-day practice unless you have cholera outbreak or your subjects are going to a mass gatherings like Kumbh Mela or some such event, or in rural area where there are a lot of outbreak in an area where they will use it as a mass vaccination, and that is what WHO also recommends, that these vaccines should be used. I mean, you will be very recently surprised that I was just talking about this cholera vaccine in Hinduja Hospital doctor's lounge, and the gastroenterologist who was there, he said recently the master chef of the kitchen in Hinduja himself had cholera. So I was surprised that it can exist even in a city like Mumbai, and to generally a good class person, because the chef is like well paid. So you never know what diarrhea you have severe, whether they were cholera, unless you investigate. And there have been massive outbreaks of acute watery diarrhea across the country for some reason in the last 1 or 2 years. Some of them have been investigated as cholera, some of them just passed as acute watery diarrhea, but they were significantly seen even in adults. So next time when you see a child with severe diarrhea, which is out of proportion to the symptoms, think of cholera, send for hanging drop and a culture, and you may be rewarded. Reason why I am saying is because that's the only indication of giving antibiotic. Otherwise, in acute watery diarrhea, you don't give antibiotic. Thank you very much for your patient hearing.
Thank you, Dr. Nitin Shah. An excellent presentation. No wonder the house is full, even post-lunch session.
Thank you, sir.
And the attendance today I can see is even more than the voting percentage of Bengal. So next we have Dr. Jaydeep Chaudhary, and he'll be speaking on vaccines against respiratory virus.
Well, good afternoon, everybody, and hope you had a good lunch. So outside is hot, so stay cool inside. Following the cholera vaccine, I will discuss some vaccine which you definitely use in your day-to-day practice. Now, these are vaccines against respiratory viruses. When we talk about vaccine preventable respiratory infection, there are few bacterial infection and there are few viral infections. Bacterials like diphtheria, pertussis, Haemophilus influenzae B, pneumococcus. Among viruses, there are mumps, measles, then influenza and RSV. Now, I will limit my discussion to those two which are virus and vaccine preventable. So that brings me to MMR and influenza. Well, regarding MMR vaccine, I think I don't need to teach you much. It's a combination of mumps, measles, rubella, and it's also available as measles, rubella combination. Dose is 0.5 ml subcutaneously. The schedule we follow 9 months, 15 to 18 months, and 4 to 6 years. But it can be given minimum age at 6 months in certain circumstances like outbreaks and all, but then we do not consider that dose. Catch up school-aged children and adolescents at least 2 doses, minimum interval 4 weeks, and there are only few contraindications like if there is an allergic reaction to the previous dose, if pregnant lady, we should not give the vaccine, immunocompromised. So these are the overview of MMR vaccine that we use. Now government uses MR vaccine. Now this is a WHO chart that's quite encouraging. If I am just underlined, if you see from 2020 to 2024, the coverage of measles containing vaccine, right now the MR vaccine, has steadily risen. It has risen from 89% to 95 and to 97, and that's quite remarkable. A coverage of 97% of measles containing vaccine in National Immunization Program. So that leads us to the crux of the issue. So the measles containing vaccine coverage are reaching 97%. And this is the government immunization schedule, the national, where it's given at 9 to 12 months, then 16 to 24 months, and next is the latest ACVIP schedule. You can see it's the 3 doses of MMR vaccine, and this you must be aware of. Now this is the basic comparison in national immunization. The first dose 9 to 12, second dose 16 to 24. In ACVIP, we give 3 doses, 9 months, 15 months, and third dose 4 to 6 years. Again, catch-up vaccine I have already told, and if the child is previously vaccinated with a single dose after 12 months of age, then 1 dose is sufficient, and of course campaign mode in outbreaks, we have to go for the vaccines. The point is that this is the WHO position paper 2009, where it was stated that reaching all children with 2 doses of measles vaccine, this is regarding measles prevention, should be the standard for all national immunization program, because there is high transmission and high mortality risk of measles. Administered at 9 months for optimal protection during the susceptible period of infancy. The immunogenicity is better from 9 months, and administer second dose at 15 to 18 months to ensure early protection with minimum interval of 1 month. And the second dose, in the second year of life, reduces the rate of accumulation of susceptible pool and risk of an outbreak. So WHO way back in 2009, they emphasized the importance of 2 doses. Now this is regarding rubella, and this was the 2011 position paper of WHO. It is not highly infectious as measles, and even a single dose at 9 months is more than 95% effective. So a single dose of rubella vaccine may achieve elimination with high coverage. When combined with measles vaccination, it may be easier to implement the rubella containing vaccines using the same combined MR or MMR vaccine for both doses. This was the WHO stand. Now, what is happening if we are giving MR vaccine? In national program, MR is given at 9 and 16 to 24 months. In MR campaign, you are all aware, at least 1 dose of MR from 9 months to 15 years. But mumps is missing, the M is missing, the second M is missing. And mumps outbreak are on the rise. As per CDC, 1 dose of mumps vaccine, 72% effective, 2 dose, 86% effective, and India doesn't have a monovalent mumps vaccine. Now this is a publication, a very recent one, in 2023-24, as you can see here. A mumps epidemic swept across India, and there were 217 cases in Navi Mumbai alone. 91% of affected individuals never received mumps vaccine, and 185 out of 217 reported cases vaccinated with MR vaccine through national program, and only 20 received the MMR vaccine. And the median age of children affected was 6.2 years. So the perception that mumps is always benign, not a major public health burden, is not true, and India's universal immunization program still doesn't cover mumps. We need mumps control because, yes, the common symptoms are swelling of parotid gland, fever, but it is present in about 35% cases only. So the actual incidence and morbidity may be higher, and there is always probability of complications like orchitis, CNS aseptic meningitis, meningoencephalitis, sensorineural deafness, pancreatitis, and also diabetes insipidus, diabetes mellitus. So these are all possible complications. Does the strain matter for mumps? That's another contentious topic. Now, regarding the measles strain, it is the Edmondson-Zagreb or the Schwartz strain which is being used. Rubella, all are uniform, RA273, but mumps, we are well versed with the Leningrad-Zagreb strain and the Geril-Lin strain, but there is one more MMR vaccine which uses the Hoshino strain. So what WHO says, this is the position paper in 2024. This is the WHO's position on the use of mumps vaccine worldwide. Well, of course, WHO endorses the use of Leningrad-Zagreb strain and Geril-Lin strain. But it has also mentioned that other strains like Hoshino, Tori, Miyahara and NK-M46 strains, these strains are used only in limited number of cases, but WHO has recommended. Only the Yorabi strain has been discontinued. So this is the 2024 WHO position paper. There are studies in Japan using this Hoshino strain which evaluated 229 children, 167 out of 179 initially seronegative for mumps virus, induced a high seroconversion as you can see in the graph there, and Hoshino strain induced significant IF and gamma levels after vaccination with a significant p-value. This is a study in India. Is the immunogenicity and safety of a novel MMR vaccine with compared with the Edmondson-Zagreb strain. Here the mumps is the Hoshino strain and the comparator was the Edmondson-Zagreb strain. It was done in India and it was published, and the Hoshino strain containing MMR vaccine was non-inferior to the other Geril-Lin strain. And this we can see here. If we see the seroconversion of all the measles, mumps and rubella, the pillars they match. Measles are both 100%, mumps is 94.5, 94, and rubella also 95 and 91%. So this is the proportion of subject seropositive for measles, mumps and rubella at the end of the study in the two groups that we can see here. And there is also a safety and tolerance of a novel MMR vaccine in Indian children. This is a real world evidence study. It was proven safe, and as you can see here at the bottom, most of the children received it at 9 months. So coming to the basic issue, how many doses of measles, mumps, rubella component are adequate in lifetime? Well, measles 2 doses, rubella single dose, mumps definitely 2 doses, but then time since last dose is crucial for protection. If we end MMR vaccine at 15 to 18 months, then the protection will not last long enough, and there are known cases of mumps outbreaks and sporadic cases in the school-going children beyond 6 years and more. So a 3rd dose of MMR is required at school entry to give a protection during the period where mumps infection is common. The second vaccine is the influenza vaccine. It's, what we use is the inactivated vaccine. We have the trivalent one, we have the quadrivalent one. Now the universal dose is 0.5 ml. The first vaccination is 6 months to, the first vaccination will start at 6 months to 8 years. There's 2 doses at 1 month interval. Beyond 8 years is a single dose. And WHO says that India is in South Asia transmission zone, though India belongs to the northern hemisphere, and that's why we are using that. I will come to it. Now, why this change? Now, if we see the co-circulation of Victoria and Yamagata, both are of B lineage from 2000 to 2024. If you can see there, the dark column is the Victoria and the lighter blue column is the Yamagata. Now 2019 there were few cases of Yamagata. During say 16, 17, 18 there were more Yamagata cases. So it was introduced. Then Yamagata you can see is really tailing off From 21, there is no Yamagata cases reported from the world, and it was only Victoria strain that was in circulation. So, since 2020, Yamagata has completely disappeared, and that's why the trivalent vaccine was launched. We are all aware how it is decided which strain to include in the vaccine is the GIS-RS, Global Influenza Surveillance by WHO, regularly updates the guidelines to manufacturer. Southern hemisphere vaccine is there, northern hemisphere vaccine is there, and they decide about the strain. And this in May 2025, WHO has declared that at least 14 countries are using the trivalent vaccine and switching to trivalent for future season. So this was as per the WHO guidance about the strain composition. So what's the rationality? Number one, no additional antigen required. When Yamagata is not in circulation, why to add one more antigen when it's effectively extinct? Then there is risk reduction. Removing the Yamagata from vaccine reduces the risk of reassortment and unintended reintroduction, because influenza virus characteristically shifts and drifts and reassorts. And this is a way of precision vaccination, matching vaccine type to the population needed. So this is a specific. And our National Center for Disease Control has also endorsed that given these findings, it is advisable to use the Northern Hemisphere 2025 or Southern Hemisphere 2024 onwards, the trivalent seasonal influenza vaccine. This is in line with WHO. So we have moved further. In 2024 in US, there was transition from transition to quadrivalent vaccine. In 2017, India adopted this transition. So it took 3 years from trivalent to quadrivalent transition. But in 2025, the trivalent was reintroduced in US after WHO endorsement, and India has transitioned to this trivalent. So let's go in the right direction. Trivalent is the vaccination as of now. If WHO comes up with a new recommendation, we will change accordingly. So presently also, if we see the 2025 Northern Hemisphere trivalent and the 2026 Southern Hemisphere trivalent, there is some difference in the A. Though B is same, the Victoria it's same, but in the A there is slight difference of the strain that's recommended by WHO. So regarding selection of influenza vaccine, as we know, though India is in Northern Hemisphere, but it's a cliched topic, most part behaves like Southern Hemisphere. So we can vaccinate in the April-May, in the pre-monsoon season, where the Southern Hemisphere vaccines are available. But there are some situations, say a baby turns 6 months in December. So should we wait till the monsoon season for the influenza vaccine as we are recommended the Southern Hemisphere? Well, no, because the first dose takes some time to build protection, and waiting till monsoon will unnecessarily delay protection, and influenza can attack any season. So, and young infants also are at high risk, so we must not delay the vaccination. As soon as the child turns 6 months, we should give the vaccine whichever is suitable. Some other situation, 2 doses of Southern Hemisphere vaccine was given in May, June. Now the parents return in December 25 asking for a Northern Hemisphere vaccine because they plan to travel in USA for 6 months. So should we give another Northern Hemisphere vaccine? Well, there are 3 options, but no Northern Hemisphere vaccine is needed, because in one season, more than 2 doses of any vaccine, be it Southern or be it Northern, is not recommended. So we must stop this year, and maybe the next year, if the child is still in US, we may go for the Northern Hemisphere. So there are few concerns, though we are talking a lot, but still the coverage with MMR vaccine is still low, and that we all must try it. And there are WHO recommendations for MMR vaccine, influenza vaccine, for different ages, but most important is that we must vaccinate, because vaccines just cannot prevent the disease unless we vaccinate. So let us all go for universal immunization vaccination, at least to all those children who are coming to us. Thank you so much.
Thank you, Dr. Jaideep Chaudhary, a very nice and crisp presentation. So that concludes all the 3 topics of our partnership session, and thank you to all the speakers. Thank you.
Now I request both our chairperson and the speakers of the partnership session, please kindly go and take. So may I call upon the next session, which is the expert speaks. The chairperson is Dr. Shukanto Chatterjee. Dr. Shukanto.
Good afternoon. Now I request, I invite the first speaker of this expert session, Dr. Vidya Krishna, to speak on molecular diagnostic in pediatric infections. Please carry on.
Good afternoon and warm vanakkam from Chennai. Thank you to the organizers for this opportunity. So in the next few minutes, I'll be taking you through the judicious use of molecular diagnostics in pediatric infections. My only disclosure for this talk is I've taken the help of AI to design the slides, but the content is all mine. The objectives of my talk would be, we would start with comparing culture versus molecular diagnostics, and then I'll take you through the various PCRs that are available in the market and end with next generation sequencing. The key learning objective for this talk would be that we would order the right test in the right patient and learn to interpret it in the right way. So when we look at conventional or culture-based diagnostics, they still remain the gold standard because they are more accurate as far as organism identification, as well as they provide drug susceptibility. On the other hand, when we look at molecular diagnostics like PCR, though the pathogen is accurately identified, probably in some cases it even picks up the dead bacilli. So sensitivity is higher, but it doesn't give you the drug susceptibility, and also the clinical context is very important when you're talking about a PCR. The advantages obviously is that a PCR helps you in rapid decision making if you want to make an antibiotic choice, or you want to stop your antibiotics, or you want to do some infection control precautions. So in that way it's useful on the bedside. It's especially useful in sick children and in immunocompromised hosts where you really want to know the etiology so that you can stop escalating, or you can give a focused directed therapy. But as I was saying earlier, clinical context is everything when you're talking about a PCR. It's very easy to order a PCR, but you have to have a sound clinical judgment to interpret it and go ahead in treating the child. Because as we all know, a positive PCR only tells you that a pathogen is present, but it doesn't tell you whether it is actually causing the disease. So the reason is, again, we all know that children can be colonized with, say, Streptococcus pneumoniae in the throat. They could carry a whole lot of viruses in their gut. And again, HHV6 kind of pathogens can be there on your ME panel. So when you have to interpret a PCR, the clinical syndrome is important, the host is important, and the pre-test probability is very, very important. What is the likelihood that the child in front of you has the disease that you're suspecting? Only then we should go ahead and order the PCR. So the major limitations of PCR, if you ask me, is basically all of us are getting used to using PCR. So even now we have challenges, every day when I order a PCR, I ask myself, am I justified in ordering this? Am I going to be right in interpreting the report? And again, the question that we all should be asking is, are we using a good test? In our markets, we are flooded with multiple PCRs. So we really don't know the validity of many of these PCR assays which are available in the market. So if you are in doubt, please use validated PCRs, even though they are costly, and use closed systems. Like the expert is a PCR, but it is a closed loop where there is less chances of contamination. So this is a recent paper which talked about what are the limitations. And again, most of the times in studies across the world, not only in India, even if from US and UK, many times the PCR is ordered, but there is no reduction in the antibiotic prescribing after the PCR report comes. That's a dreadful waste of money and resources. So that's not advisable. And again, it's difficult for pediatricians, especially when for us to distinguish between colonizer, true infection. There is no susceptibility data. Again, cost and other things are always there. So if you have to have a sort of framework to say, what am I going to do? How am I going to order a PCR judiciously? The first question I will ask myself is, if I order this test and if it shows a report, am I going to act on it? Suppose I order an influenza PCR, then I have to stick to antivirals and not give antibiotics unless the clinical syndrome decides it. So unless I am going to do that, there is no point in ordering a PCR. We might as well continue to do what we do clinically. The second question is the clinical syndrome well defined? Most of our PCRs now are syndrome based, isn't it? So like the meningitis syndrome or a pneumonia syndrome. But if you are going to order a fever panel, most of the fever panels or PCRs which are available in the market are not validated, and it will be a wild goose chase if we start chasing those reports. What is the pre-test probability? Again, most important, because if you have a very low pre-test probability, and these tests are highly sensitive, so you're going to have a high false positive burden. The classic example is HHV6 on a CSF. Almost like many children, I think 4 to 6% of children will have a HHV6 positivity in a febrile infant if you do a CSF. So is the host immunocompromised? Here we are a little bit more liberal because we want to know what is going on. Even colonizers can, or simple pathogens can be deadly in them, so we want to use these PCRs. And there should at least be a stewardship or an infection control implication. If it's not a clinical judgment that it is affecting, we could still use PCR for a stewardship point or an infection control perspective. So we'll talk about the respiratory PCR. So now the singleplex PCRs are almost outdated. We at least have a trivirus or panel or a respiratory or a pneumonia panel. So in the following situations, I'm just going to give you some scenarios where we think we can use this. So if you have a 5-year-old boy who comes to you, say, with the following syndromes, which piece are you going to order a PCR? Just keep that in your mind, and then we'll see the results as we go further. And then what type of PCR are you going to do? Are you going to do a flu PCR or a trivirus? Trivirus is like flu, RSV and COVID, or are you going to do the entire film array panel? So you can have a child presenting to you with an influenza-like illness in the OP. You can have a CAP or a Valerie admitted to the ward, but not in the flu season. You can have somebody admitted during the flu season. You can have a child who's sick in the ICU, who's not responding to your standard therapy, maybe even requiring ECMO. You might be asked to clear a child for a cardiac surgery, and the child could have had a recent influenza-like illness. Or you could have a child like a refractory leukemic child awaiting transplant and now has a febrile neutropenia and a lower respiratory tract infection. So if you can see, if you have an ILI in the OPD, the government is against any form of testing. So at least that is what the guideline says. If you have a CAP or a Valerie in the ward, you typically are not expected to test, but you could still test if your intention is, as I said, to de-escalate or to isolate. If you have it during the season, definitely you should test. You should at least be doing a flu PCR. If you have a sick child, unusual course, I would do the full panel. Like a number of times we have picked up pathogens like metapneumovirus, adenovirus and all those things. And then it gives you the confidence not to escalate antibiotics, antifungals, and then stick to supportive care and other measures. And again, pre-surgical clearance for cardiac surgery is very important. So many times when we do this, because children tend to shed viruses for some time, it's important because you can at least give a window of anywhere from 2 to 4 weeks to delay the surgery so that they don't have any adverse effects. Again, if you are the sickest of the lot, the transplant kit, you would do the full panel because here you would use antivirals or immunoglobulin more liberally off-label than in the other groups. So the film array panel, does it truly reflect a lower tract infection is always the question because you're obviously doing the swab from the nasopharyngeal area. So answer is not always. So obviously you would want to do a BAL or a mini BAL, but this assay itself is only can be done for a nasopharyngeal or oropharyngeal sample. So for a BAL or a mini BAL, you need a different assay of which we will talk about later. So what about multiple pathogens? So there are studies on pneumonia in children like the Gabriel study and the PERT study which have shown that RSV, flu, metapneumovirus, parainfluenza, pertussis, in these pathogens are usually more likely to be found in children with infection than in say asymptomatic children in the community. And how long can respiratory viruses be shed? They can anywhere from 1 to 2 weeks to several weeks to months, especially infants, immunocompromised hosts. So you have to keep that in mind when you are interpreting the report. And can there be an asymptomatic infection or colonization? Yes, especially rhinovirus, pneumococcus, mycoplasma. So here the clinical context is very, very important. You have a PCR report, the child in front of you is not having the relevant syndrome, please ignore the report. So in respiratory infections, that's why it's recommended that in addition to just your PCR, you sort of correlate it with something like a procalcitonin, X-ray and your clinical judgment before you jump and treat based on this report. So to sum it up, so you would just avoid doing these PCRs in a classic, say, a bronchiolitis, mild URI. Don't repeat a test within 14 days. Don't do it just to know, like unless it's like, as I said, screening for, say, pre-chemo or pre-surgery. And if you're not going to act on it, please don't order it. So this is the second respiratory panel, which is the pneumonia plus pathogen panel. So here you have a list of bacteria, atypical bacteria, viruses, and some resistance genes. The problem with this is again the sample. The ideal sample is BAL. You could always do it on the endotracheal aspirate and sputum, but in children you're not going to get any of those. So if you have a BAL sample, it's the best sample to run this. In my humble opinion, this is a good negative predictive value. Finding something there is likely to be noise or music. It's very difficult for us to interpret. But when you have a negative report, at least say you have a child with ARDS or some other condition where you, like say an SLE child who's intubated and you want to immunosuppress, having a negative report at least gives you some confidence to go ahead and do other strategies than worry about escalating your antibiotics. And again here, there is some cutoff which is mentioned, like it is mentioned in a semi-quantitative threshold, like 10 power 7, 10 power 4 and all that. The higher the threshold, the more likelihood that the bacteria will actually grow in culture. The lower the threshold, it might not grow. So again, it's very difficult to distinguish colonization from true infection. So this panel, personally for me, is a stewardship nightmare unless we really know what we are going to do with it and we are convinced fairly enough that the patient in front of us has really pneumonia, there is no ARDS, there is no congestive cardiac failure, collapse, ARDS and other things which are confusing. Please do not order this panel. Reserve it for your difficult to say like you have not found a pneumonia for a long time, non-resolving pneumonia with no etiology or immunocompromised. So in those situations, probably it works better. CNS infections, again, indications for PCR are sort of acute meningitis, TB meningitis, immunocompromised host and neonatal meningitis, useless in focal infections or abscess. Ideal sample is CSF, but in some other cases, we would do a salivary or a serum PCR. We'll talk about it. So PCR obviously helps in bacterial meningitis when antibiotic exposure is there because the antibiotics reduce the culture yield from 70 to 80% to less than 50% with a single dose. And viral encephalitis, pathogens like Listeria, TB, Cryptococcus, you sort of want to rely on molecular diagnostics. The advantage is obviously the turnaround time and cost effectiveness. The most important thing in a CSF is a precious sample. So you really want to increase your results of your PCR. So the timing is very important. We all know from herpes simplex that we don't want to do it too early. We want to do it, say, like at least 40 to 72 hours, or if you have done it very early, you might want to repeat it. Avoid a bloody CSF tap. Volume is very, very important, more so in TB, we'll talk about it. And here you have to remember that even though you have a multiplex PCR, if you are in doubt, you will have to confirm it with a singleplex. The singleplex generally has got more sensitivity than the multiplex PCR. Again, HSV is a classic example. And use a validator. See, please don't use in-house commercial brood PCRs. They are likely to be prone with errors. And you need a clinico-radiological CSF correlation. So this is about the filamentary ME panel. So again, remember that sensitivities and specificities are not 100%. They are quite variable, suboptimal, especially for HSV1, H. influenzae, Listeria and E. coli. Unfortunately, we don't have much options for Listeria and other stuff. So false negatives can happen with Cryptococcus. That's why the cryptococcal antigen is preferred. HSV1 always reconfirm with a singleplex PCR before you label it as not HSE. False positives, as I said, can be there with HHV6, even with strep pneumoniae. No tropical pathogens are picked up and TB is obviously not picked up. The thing in viral encephalitis is there are at least a couple of pathogens like JAP-B encephalitis, West Nile and all that, where a PCR is not the answer. If you do a PCR for these encephalitis, you will obviously get a negative report because they have very transient viremic states. Again, for rabies, you would not only do a CSF PCR, you could even do a salivary or a nuchal skin biopsy and other PCRs. So what about the GI panel? So again, the same way, if we want to test a child, say by a PCR or a GI panel, so you have a 5-year-old child who comes to you with a acute watery diarrhea or a dysentery. Are you going to test persistent diarrhea? Are you going to test HIV positive with diarrhea? IBD child awaiting some infliximab and has some fever, diarrhea, blood in stools, outbreak in school. So again, if you go through the same, for a simple garden variety acute watery diarrhea, dysentery, please don't do, because you will invariably pick up something like enteropathogenic E. coli or something and you will be giving antibiotics. You might have normally not given, sent the child home back on ORS and other supportive measures, but having picked up, we would start chasing those and giving antibiotics, so please don't do it. Persistent diarrhea, HIV positivity, IBD child or any immunocompromised child for that matter, outbreaks, this is a very good test to do. So these are all the pathogens, but remember that the same holds true like what we spoke about respiratory. So here again pathogens like E. coli, salmonella, they can be shed for a long time, they can be just colonizing and not doing anything, even Clostridium for that matter in young children. So Cryptosporidium, Giardia, these are generally known to be more pathogenic than the others. So what about sepsis? So just a couple of minutes I'll spend on this. So imagine you have a child, a preterm or a term child who comes to you at 0 hours with fever, hypothermia and lethargy. You have drawn a blood culture, the gold standard, and then you have started on meropenem, which is the empiric broad spectrum antibiotic. Say at 12 hours your blood culture flags GNB. Okay, so what am I going to do with that? Am I going to just continue meropenem because the child is stable, or can I do something to know if my child has a resistance or some other problem that needs escalation of antibiotics? So you could do the BioFire BCID2, and that panel, if you all have seen, will identify both the pathogen and the resistance mechanism. So in this case, it identified Klebsiella and it identified NDM also. And then within 14 hours, you could give targeted therapy with Casaviastunum and the child recovered well. So BCID is a very good test. If you're talking about, it's the only validated sepsis test, a molecular test that is available in the market, so very useful to use. Expert CABAR, I'll talk about it in a minute. In neonatal sepsis, again, HSV is one of those where you would want to use PCR. And please remember, the most important thing in sepsis panels is you're not supposed to do it direct from blood. All the sepsis PCRs are supposed to be done only from the blood culture flag. So please don't send direct from blood sepsis panels. So this is the expert CABAR. All of you would have seen a report like this where it finds out NDM, KPC and all that. So you have to interpret it along with the organism ID. For example, if you had an Acinetobacter with a and then you had a negative expert CABAR report, it doesn't mean anything. It could still be carbapenem resistant because it doesn't harbor any of the above genes. And the BCID, again remember, it only has 33 targets, so it could still miss pathogens like Burkholderia, Citrobacter, Elizabeth kingae, Achromobacter. These are just a few. There are whole lots more that it can miss. So about TB, just going to spend one slide on this. So we all have talked about TrueNat, which is available in the public sector. So TrueNat now has TrueNat MTB Plus, which has a limit of detection of 30 CFUs, so a little bit more sensitive. So head-on-head comparison, again, if you have TrueNat versus Expert MTB and Ultra, it's almost as good, if not, it's not, it doesn't seem to be inferior, at least to the Expert MTB, maybe Ultra is slightly more sensitive. TrueNat again has now rifampicin resistance as well as INH resistance, it can detect separately in an assay. Expert MTB, it is going to be phased out by Ultra very soon. It was the game changer in TB diagnostics. Remember that if you are using Expert MTB in your lab, if you are doing a TB meningitis workup, you have to do at least 6 ml of CSF, otherwise your reports can be falsely negative. For Ultra, the recommendation is 2 ml. Most of the labs have now switched to Expert MTB Ultra because it has better sensitivity of 16 CFU per ml. Obviously, there are problems with trace calls and indeterminate ref resistance and other things. XDR assay is something again which is now sort of picking up in the market because more and more we are starting to worry about isoniazid monoresistance. So now slowly the recommendation is like if you have an Expert MTB positive, except on your trace calls, you can almost order a reflex expert XDR assay. So that if you find a monoresistance with isoniazid, the guidelines have now changed that you would be using levofloxacin instead of isoniazid. So helpful in that way. So again, the newer guidelines recommend that expert can be done on stool samples, NPA samples, and even in blood in HIV positive patients with suspected disseminated TB. So personally, I have used in stool a couple of times and it has helped, but yeah, we have to always wait for more information on that. The last part of my talk is on next generation sequencing. This seems to be the way forward, but still a lot of vagary is there. So when you talk about NGS, we're talking about, in common parlance, we say 16S PCR and 18S PCR and all that. The major difference is PCR, you're only looking at a predefined target, whereas in NGS, it will sequence all the DNA that is there in a given sample, be it from the sample or from the environment. So if there is a little bit of contamination also, it is going to be a big problem because it will pick up all the DNA. So it is very broad. Turnaround time is a little bit longer. Like in my center, at least it takes 48 hours for a negative report and longer for a positive report. And again, there are no globally validated NGS platforms, so validity is presumed. You might have to check with your own data. And it's surprisingly affordable. In my lab, the bacterial thing costs only 5,500 and the fungal NGS costs about 5,500. So it's not very costly at least. Sensitivity and specificity is highly variable. And again, the best clinical use when is like when I can just show you an example to say in what type of situation you would use it. So this is one child, we had a 17-year-old with a complex congenital heart disease with a parietal abscess. We couldn't drain him for a long time because he had a heart block. And then finally he got operated, by which time he had already been exposed to ceftriaxone and metronidazole for 10 days. Obviously the PEROP sample was negative, expert was negative. But then when we used the NGS, it picked up Fusobacterium nucleatum, which is a known anaerobe, which is known to be associated with a brain abscess. And for this, we had to alter his treatment and all that. So it was really helpful in ordering this test. So my last slide is, as I said, we'll go back to the basics. So if you're ordering a test, make sure that you know your pretest probability. If it is high, only then order a PCR. If it's doubtful, please think twice. Again, order it only when it will change your practice, like you're going to make some change, at least isolation or stewardship, something should be there, otherwise don't order it. Use it liberally in your sick children and immunocompromised children, but interpret with caution. And generally it's good to have a predefined, like as I said, if I have a flu positive, I am going to stop the antibiotic. Have a predefined approach so that you will act on it once the report is back. And remember that positive is just means it's present, it's not pathogenic, so clinically you have to correlate. So molecular diagnostics will keep emerging and they will keep getting newer and newer platforms, better platforms, but nothing is going to beat the clinician's mind. Ultimately, it is going to be we clinicians who have to interpret it and use it for the best interest of our children. Thank you.
Thank you, Dr. Vidya Krishna, for nicely presenting the most important topic of PCR that clinicians used to advise, but think twice before you advise. That's the clinical message. It's very useful. Now I'll invite for the next talk, Dr. Anurag Agrawal, who is considered in IAP as the rabies person, to talk on tricky situations in rabies prevention. Yes, Dr. Anurag.
So, yeah, good afternoon friends. First of all, I thank the organizers for having me, Dr. Jaideep sir and team. So it's post lunch and I saw some of you snoring besides me, and the panel given to, see, lovely lunch and cool weather, I also was trying to catch a few winks. So I thought, I knew that it was post lunch, so I made my slides in such a way that you will be answering some of the questions that will keep you awake. So the topic given to me was tricky situations in rabies. So let's see what all answers I get from the audience. Of course, the people who have heard me speak earlier know the answers, so they can keep it to themselves. I can see Dr. Nitin Shah sir smiling. So now, this is the first question for the audience. What is the incidence of animal bites in the country? And what is the incidence of rabies? And why should we know about it? Quick, quick, quick. No sir, you cannot answer. So what is the incidence of dog bites in our country? What expected? Just rough guess quickly. I have only 20 minutes, my timer has started. Sir, sir ही answer करेंगे मुझे लगा. So yeah, so before going to the next slide, just note that if you get bitten by dogs in Andaman and Nicobar, you do not need to take anti-rabies vaccination because it is rabies free, Andaman, Nicobar and Lakshadweep. Anywhere else you get bitten, you have to take a complete course as per guidelines. So rabies, as we say, once you have it, you have had it. There is no cure for it. There are just 15 to 20 cases which have survived over last 20-30 years, and they are just case reports with severe neurological residue. And other than that, the mortality from India 2004 data is 20,000 deaths. But a recent Lancet study done in 2024, it said that the deaths are between 5,000 to 6,000 cases. That is around 6,000 cases every year. And then coming to the incidence of dog bites. So we conducted study, we did it twice. We did one study which was published in BMC Public Health just last year 2025, and we found that the incidence of dog bite was approximately, annual incidence was 2.5% per annum. And a similar study we conducted in 2016, it was published, we did it in 2014, and at that time also the incidence was around 2.5% per annum. So there was a rural group and urban group and all that, so this is what we got. So it simply means that every year 2.5% of the population will be bitten. That means in 10 years it will be roughly 25%, and 40 years it should be 100%. So we people are expected to live 100 years. So rest assured, if you have not been bitten by a dog, you shall soon be bitten. Or if some of you have been bitten, then maybe you will be ready for the next bite, because it is 1 to 3 times in lifetime, right? So now, what are the routes of transmission? Quickly, bites, scratches, saliva, anything else? Sir? Organ transplantation, very good, yes, that is an uncommon mode. So before going to the answer, rabbits, domestic mice, reptile bites do not transmit rabies. So I get calls ki sir, I have been bitten by an eagle, or an eagle was flying over my head carrying a mouse, dead mouse, and the mouse fell on me and I got scratched. So these are recent calls I got. So they do not transmit rabies. Why do they not transmit rabies? Because their body temperature is different, so virus does not survive at that temperature. Squirrels, doubtful. Why I am saying this is there is one case report published in Pediatrics where a person was bitten by a squirrel and developed rabies. So association is there. Other than that, some dead squirrel samples were found to be positive for rabies virus. So maybe the squirrel carries the virus, but we still do not know if it is transmitting rabies. So one case report does not mean that it is causing rabies. So now this is the answer. Modes of transmission: animal bites, licks, scratches. These three we are sure about. The uncommon ones, aerosol transmission. So how does this happen? Aerosol. So we are all doctors. We have intubated day in and day out during our residency, and rabies can present as encephalitis. So around 20 to 30% of cases of rabies present with encephalitis. Once we intubate, second day or third day, the grandmother or somebody else from the family will come and tell you, कि sir इसको 1 महीना पहले dog bite हुआ था. So around 2 months ago, I had 2 admissions. One was with face bite, admitted with rabies. The wounds had healed. The family which brought in the child did not tell us that the child was bitten by a dog. And then third day, we were told that वो dog ने bite किया था. Another case, same story. 20 days ago, bitten by a dog. The wound was healed. Again on the face, had taken the vaccine, but developed rabies because it did not get immunoglobulin. And then the residents were standing कि सर अब हमारा क्या होगा? मैंने इंट्यूबेट किया, स्वीपर कहता है मैंने सक्शन किया, नर्सिंग स्टाफ कहता है मैंने कैनुला लगाया, daily drip change करता हूँ. So that is aerosol mode of transmission for you. So what should be done? See, the virus is excreted from the saliva. When you intubate, you go so close to the patient. So can you not get rabies? So till date, we have not seen a resident developing rabies, but this fear is definitely there, and then you have to assuage those feelings. I have seen residents going on strike after being exposed. I was also exposed as a PG, and our head of department was very considerate. He said कि डॉक्टर साहब वैक्सीन लगा लो, we will reimburse. वो reimbursement नहीं हुआ, वो अलग बात है, but the issue was sorted there and that. So we do not have an answer for it, but because it is our medical fraternity, we say that you take the vaccines and take immunoglobulin IM, right? And the better way is, जैसे सबको hepatitis B vaccine लगता है, ऐसे ही all health workers can take pre-exposure prophylaxis. Why get exposed, fall into that stress for months together and lose sleep over it? Organ transplantation, yes, sir had said, definitely. So around 20 cases have been reported across the world from US, China, Iran, wherein cornea transplantation and liver transplantation, kidney transplantation has led to development of rabies. Ingestion, the famous story. Yes, so cow's milk, and the cows dies for any reason, it is considered he died of rabies. And then what do? Quick. Remote chance, okay. So till 2018 we used to say if the milk is boiled, nothing will happen. If the milk is not boiled, maybe you are exposed. After 2018, WHO has clearly mentioned that the animal milk, rabid animal milk does not contain the virus. Right? But that is the theory or truth. But when you have 20 people standing outside your government setup with sticks in their hand, you can decide what you want to do. So this has happened. So 10, 12 people coming there, half the village is standing outside ready to make a huge noise. Then you have to decide what is practically good for you. Sexual. So the husband dies, the wife is there, she says, I have had regular sexual contact with my partner. What to do? So these are the real life scenarios we get. So there is so much of panic in the family. Again, no case has been reported wherein both the family members developed rabies. But again, just to keep them away from panicking, we say that okay, you can take the vaccine or immunoglobulin, both together. So now, how do we categorize the bite wounds and what is the spirit test? Quickly. Blood or no blood? Very good. And serum or no serum? If there is no blood but serum oozing? Yes. So, what is the spirit test? Very good, sir. I should have had some chocolates from the organizers to distribute. But BC minute hai, sir. So, categorization, simple for us. Wherever there is even a drop of blood or serum oozing out, it is category 3. It means the integrity of skin has been breached. And you need to cover it with the vaccine and the immunoglobulin. Now, the spirit test, average 1 call a week I get and I tell them, ki, please do a spirit test. They send me a photograph, sir, what is this, category 3 or not? Yeah, I know, sir, I know that. So, if you ask me, category 2 is redundant, but it is there in WHO documents, so we cannot say it openly. You made me say it openly here. So, I always skip it. I said, do the spirit test. And if there is burning or tingling, it means the integrity of skin is broken, the virus can enter, you give the immunoglobulin and the vaccine. Clear? I know what sir is saying is right, and we are not very happy with this categorization of category 2. We say it is redundant, it is 1 or 3, it cannot be midway कि वायरस है तो सही लेकिन अंदर नहीं घुसेगा, वैक्सीन का इंतजार करेगा इफेक्टिविटी आने के लिए, या तो वायरस है या नहीं है, बीच की पॉसिबिलिटी नहीं हो सकती सर. Yes, yes, I agree. But this is what WHO says, sir. And I agree with you, it is category 3 if you ask me. Yes, sir. Especially in practice, you should use immunoglobulins liberally, because nowadays what has happened is we are saying, I'll come to that question also, the cost has come down drastically. I'll come to that question, dena kitna hai. So, next. So most of the patients reporting to us are category 3. That is another way of looking at it, until and unless proven otherwise. So this is what we do. We vaccinate, we give, we wash the wound. Washing is very important. I have omitted that slide. I believe everybody knows about it. It removes around 80 to 90% of the virus. Good washing. The coat of the virus is lipophilic. It gets dissolved because of soap. Ideally it should be carbolic soap, which is not available. So use whatever soap you have. Wash the wound, definitely yes. Immunoglobulin infiltration and vaccination. So now what are the types of RIGs available and what are the dosages? So I'll just answer this question. Equine and human, two sources we have had for more than 50 years. So the maximum dose human rabies immunoglobulin is 20 IU per kg. For equine it is 40 IU per kg. And ERIG must be administered only after test dose. This is what the PI says. Will not go into this discussion. But yes, it is good if you do the sensitivity, although WHO says sensitivity is not required. Important point is, infiltrate as much as possible into and around the wounds, remaining if any should not be given intramuscularly. Right, so this is the most important statement, that you have to infiltrate all the wounds. So the case of rabies I was talking about, the one on face, bite on face, who developed rabies even after getting immunoglobulin, there were multiple bites on the face and the child was small. So the total volume could not, calculated by the weight formula, was so less that the remaining wounds must have been left. I just got a call from one of our senior pediatricians from Kerala just 20 minutes ago. He said there is a child with a huge bite around 10 centimeters on face and the total volume is coming as 1 ml. Ab main kya karu? What should be done? It is written there. So this is a daily life scenario. Sir, there is no upper limit because the equine which we have is 300 IU and the protective titer needed is 0.5 IU. So theoretically speaking 600 times, but 10-12 times you can dilute easily. We do not want to exceed the dose, because if you exceed the dose it will lead to vaccine suppression. So there is no upper limit, that's what I am telling you, there is no data as such on it, but 8 to 10 times you can dilute. उससे ज़्यादा ज़रूरत भी नहीं पड़ती है सर. Sir, for getting exposed, when you are washing the wound, you have to have cuts or abrasions on your hands. That is right. But that is not very common and we have never heard of a case wherein the mother and child both got rabies on wound washing. So yes, there are theoretically hundreds of possibilities, but वो होना भी चाहिए दुनिया में sir, है ना? So if RIG is insufficient by volume, diluted with sterile normal saline, very important, and presently available preparations are very safe. So do you want to talk about pathogenesis? Why are we saying that it should be infiltrated locally? Because there is no viremia. So here is the point wherein you can bind to the virus. You have a bite, the virus stays locally, it either multiplies or lies dormant there. That is the reason we have a long incubation period. It is multiplying locally or lying dormant. So इसीलिए हम कहते हैं कि immunoglobulin 5-7 दिन बाद भी आता है तो लगा दो. I hope everybody understands Hindi. So you can give immunoglobulin later on also. People ask me कितने महीने तक दे सकते हैं? मैंने कहा तो मुझे भी नहीं पता. But most of the cases occur within 6 months of bites. So less than 1% are after 6 months. तो 6 महीने तक लगा सकते हो. Again, that is just extrapolating. There is no data as such. Right? So once it binds to the peripheral nerves, nothing can be done. The virus will ascend to the brain and cause rabies. So now the question arises, I said ki maximum dose is 40 for equine and 20 for human. And then I said ki don't give intramuscularly. तो सवाल ये था कि देना कितना है? So we thought of this question and again we conducted a study which was published in European Journal of Pediatric Infectious Diseases, wherein we got this formula from the patients which we enrolled. So what we did was we measured the wound and gave the immunoglobulin as per the WHO recommendation that you inject it just going just below the wound till it oozes out of the wound, right? And this is what we got. It is 0.75 ml per centimeter. That is if the wound has only length, normally it's a scratch. And if it has a length and breadth both, then it is 3 ml per centimeter squared, right? right? So this is what we got, rest of it is just statistics. So you can remember 0.75 ml per centimeter. So this is what I told the doctor from Kerala कि dilute कितना करना है. अगर 10 सेंटीमीटर का wound है, soft tissue में है, तो आप around 7 ml तक का solution बनाओ और locally infiltrate कर दो. You understand the logic of this study? So now just a quick video on how to infiltrate. So what we do is we go from outside the wound. We do not want to enter the wound because you will create another portal of entry for the virus. From outside the wound, we go below it, just below it, infiltrate and withdraw the needle. Be careful, wear goggles. Otherwise, जो सर का सवाल है wound washing में, next question will be, if you get a spurt of the whatever you are injecting into the eye, what will happen? So always wear good those simple goggles we got in COVID times, white color के goggles. Same thing. So another one. Can you see the number of wounds which needs to be infiltrated? 1, 2, 3, 3, 4, 5. So all of these wounds need to be infiltrated. Right? Do not leave any wound. This is very important. So you can use a 26 gauge needle if it's a very small superficial wound on the face. This is a 23 gauge needle. You can use a thinner needle, but infiltrate all the wounds. Do not leave wounds. So just 3.5 minutes left. So now another question I get from a lot of people is कि सर ये चारों में से सबसे अच्छा कौन सा ये बता दो. So there are 2 more monoclonals available with us. This is what you people use. One is Twinrab, which is a cocktail of 2. Dose is 40 IU per kg. Another is from Serum, which is Rabishield, and the dose is 3.33 IU per kg. So this is the chart which we have, which I prepared basically. And as far as you are concerned, use any but use something. सारे अच्छे हैं, कोई खराब नहीं है. जो आपके यहाँ available है आप use कर रहे हो. Human is very costly. Equine is the cheapest, used in government setups across the country. Monoclonals both are nearly the same cost and both are good. So what do you think is the amount of category 3 bites getting infiltrated? मतलब कितने % बच्चों को infiltration मिल जाता है? बच्चों, adults. So the data which was published in Lancet was I think 10%. So 90% are still not getting immunoglobulins. So for IM route, what are the various schedules approved for PEP? WHO, NCDC, ACVIP. ये रोज की लड़ाई थी. हमने एक लड़ाई कम कर दी ACVIP वाली. So as far as we are concerned in India, we give 5 doses, 0, 3, 7, 14 and 28. WHO says 4 is sufficient. Data shows 4 is sufficient. But we went with the NCDC recommendation just to prevent confusion amongst our pediatric friends कि एक गाइडलाइन ये कह रही है, एक ये कह रही है. आप भारतवर्ष में भारत की गाइडलाइन फॉलो करो 5 डोज की. जिस दिन वो बदल के 4 पे आएंगे हम भी आ जाएंगे. नितिन सर. And day 0 is the day of giving the first dose of vaccine, not the day of bite. ठीक है. And immunoglobulin should ideally be given before the vaccine. Half an hour observe करके immunoglobulin लगा के half an hour observe करें and then give vaccine, so that any reaction, side effect you can observe. And of course the vaccine neutralization theoretically which can take place because of the immunoglobulin, so give the immunoglobulin early to neutralize the virus, then give the vaccine. Gluteal region, if any dose is given gluteal, you have to repeat it, don't count it. Does not mean that it is not effective. It is effective, but the absorption is erratic. We do not want to get confused, cause another problem for us and the patient. So you repeat it. It's a very safe vaccine that way. Sir, there are around 30 regimens, 30. If I start telling you all, it will take me one day. So what? Yes, so we are following the 5 dose. Forget the name, TRC, SX, IPC. There are no numerous. हर कोई करता है. मैं 5 ट्रायल और कर रहा हूँ. मैं सिंगल डोज की ट्रायल कर रहा हूँ सर. 4 साइड इन्फिल्ट्रेशन, उसका नाम दे दूंगा मॉडिफाइड अग्रवाल रेजिम. So भूल जाओ उसे. Single dose, what we are following is the 5 dose 0, 3, 7, 14, 28. Simple. So previously immunized, lifelong 0 and 3. I hope this is clear. This is for life. Sir, we will take your question outside. थोड़ा समझने में मुश्किल हो रहा है मुझे. We will take it outside after this. है ना, वो घंटी बजा दी इन्होंने. तो 3 मिनट बचे थे यार. चलो, ID schedule quickly. 22202, that is 037 and 28. 4 doses. This is approved by NCDC. WHO says just 1 week schedule 037. We are not following it. This is the future. We did a study. We did not find it very good. There was 90% seroconversion. So we say that it is not very good for India. This is the technique. What are the schedules for pre-exposure? 07, 28. This is what is recommended by NCDC, and ACVIP and WHO says 0 and 7 are good. So this is our study. We did on 2 sites 07. This is our study. We got 100% seroconversion at day 28 with 2 doses ID, and 2 doses is good. So we are continuing with it with ACVIP. Then single visit का कोई possibility है? So I am going rapidly. चल जा भाई. हाँ. So single dose, there is a systematic review and meta-analysis which showed that single dose also is good. More than 90% seroconversion was there, and we conducted our study. This is our study which we are soon going to publish. Day 0 baseline was 0. Day 28 out of 44 patients, 90% seroconverted, and then the ones who did not seroconvert gave a booster, and we got 100% seroconversion. Then at day 180 we again saw only 67.5% seroconversion. Then we gave them a booster of 0 and 3, and the remaining 13 who had gone below 0.5 re-seroconverted. So 1 dose schedule is also good. Now we are going for 1 visit, 4 site ID. Let us see the results. We will start the study will start maybe after 6 months. So I think we will finish off quickly. So I'll just finish off. Just to summarize. So most of the cases reporting to our OPD are category 3. Please do spirit test in case of doubt, and use any RIG, but use RIG. चारों में से कोई भी, but use करो. Monoclonals are the future, being cost effective, safe and available in unlimited quantities. There is no role of administration of immunoglobulin IM, and awareness is the key to prevent rabies death. And One Health approach, we have not discussed this, so I'll leave it out. Thank you so much. Just some photographs.
So,
thank you, Dr. Anurag, for nicely accommodating the talk within the specified time. Thank you very much.
So I request Dr. Shukanta Chatterjee, Vidya Krishna and Anurag Agrawal to go to the memento handover session. Kya, please hand over the memento. So our next is again a panel, challenging situations in vaccination. Our moderator is Dr. Nitin Kumar Shah. Nitin K. Shah, sorry. And our panelists are Dr. S.G. Kasi, M. Surendranath, Sanjay Lalwani, and B. Rajshekhar. Surendranath, please come.
So now we have the next 45 minutes for panel discussion, and the topic given to us is challenging situations in vaccination. And I welcome the panelists, Dr. Kasi, Dr. Sanjay Lalwani, Dr. Rajshekhar, and Dr. M. Surendranath. Dr. Surendranath, if you can take the chair, please. All right, so I have some set of questions, and if you want to ask any question, please do get up and ask. There is no problem. I thought the challenges in vaccination practices are 4 different types. One is the ACVIP recommendation and some differing recommendation by international agencies or by the previous committees, and there is confusion as to what should the pediatrician use. Second is shifting from NIP to private practice and vice versa, because the schedules are different, the vaccines are different. Third there are errors which happen in the vaccination. And the last but not the least, there are challenges using certain vaccines per se, like meningococcal, pre-exposure rabies, and so on and so forth. So I will try to take as many questions as possible, and maybe our panelists can be brief, then we can take many questions. So first I will start with Dr. Sanjay. I mean, the Dr. Anurag Agrawal himself said that the previous committee and Dr. Kasi said 4 doses for post-exposure. Then they now have made 5 doses for post-exposure, very willingly saying that if the government changes to 4 doses, they will change again back to 4 doses. And for pre-exposure, 3 versus 2. So it leads to a lot of confusion of members. What do they do? I mean, previous committee was wrong, current committee is wrong, or the next committee will be right or wrong in changing the schedule so frequently. What's your take?
So I think, good afternoon. I think the audience did hear Anurag's talk on rabies. When Dr. Kasi and me and Rajshekhar were the part of ACVIP, we look at the guidelines which were given. As we all know, rabies is very fatal disease with 100% mortality. The WHO recommendation was reduce 1 dose in post as well as pre-exposure. So the recommendation came that time was instead of 5, you give only 4 and eliminate the 28th day of the dose. Now the recent guideline says that rather to confuse the pediatrician at large or the family physician, let us follow the national guidelines. So the National Center for Disease Control says that for the...
No, we know the background. The question is, what should the pediatrician do? I mean, was Dr. Kasi's committee wrong, or...
I don't think so, any committee was wrong.
This is a practical question every pediatrician will ask. So, every third day I get a phone call, sir, should I give 4 or 5?
Yeah, so as on today I am in my practice started giving 4 doses and I am still sticking to 4 doses.
Dr. Kasi?
First correction, this 4 dose came when Dr. Bala was the, not me.
Okay, so Bala and Kasi 4 doses?
Okay, now, just because we have changed back to 4 doses does not mean 5 doses does not mean 4 was wrong.
Correct.
There is adequate data to show that 4 doses is sufficient.
Yes.
The recent committee has changed over to 5 doses, if you read the position paper, to avoid confusion among the rank and file of the pediatrician. No new data has emerged.
Exactly.
It's not on any scientific basis. It's only for guiding the pediatricians to have a uniform practice parameter.
So has the confusion increased or decreased after the change?
No, I think now it will decrease, but the problem occurs if the NCDC goes to 4, then what we have to do?
Exactly. So I think let's resolve to say that in rabies, there is no tomorrow. So do as much as you can. Like someone said, Kutta pass hoke chala gaya, what should I do? Take vaccine if you are worried. Like that, 4, take 5. Problem was when vaccine was in shortage in the Western countries, that's the time when this research started, can you avoid the 5th dose? Because between 4th and 5th dose, there is no increase in the antibody titers. So what are you giving 5th dose for? And the study done in Thailand, where all the protocols for rabies have started, they showed that not a single breakthrough rabies happened between day 4th dose and the 5th dose of the vaccine, which means the 5th dose was actually superfluous. That's why it was dropped, but it's okay if you give 1 extra dose, there is no harm in doing it. That's same for the pre-exposure. Okay, Dr. Kasi, the next controversy, HPV 1 or 2 doses. The recent ACVIP guideline published in April, I don't know how many of you have seen, is ahead of publication, says 1 dose for females 9 to 14 years or 15 years, and for males still 2 doses. And for females may be given, not should be given. Take home message for the pediatrician. What should we do?
Now, if you look at the data for conversion to 1 dose, it all began with the 1 post-hoc analysis, 1 observational cohort study, not very high level of evidence. These 2 studies showed that as far as the endpoint of persistent infection is concerned, there was no difference between 1 and more number of doses. Now, to have better level of data, subsequently we had a number of RCTs,
Yes.
Kenshare, Doris, etc.
Escudo, especially Escudo.
All of them, Escudo also.
Especially Escudo, very
Yes.
recent.
Yes, very recent one, 5 years follow-up data.
Prospective 5 years follow-up.
Yes.
Yes.
Now, all of these have shown that 1 dose is non-inferior, both as far as clinical endpoints and antibody titers are concerned.
Correct.
And there is persistence of antibody titers till at least 60 months,
Correct.
Escudo study. So I think fairly robust data that 1 dose is going to work. Probably on this basis, the ACVIP has said that girls 9 to 15 may be offered 1 dose. That is the wording in the recommendation. Now, boys have been excluded. Probably all these studies involved girls all these studies involved only cervical cancer related endpoints. But we must remember there is non-inferiority of antibody titers between boys and girls. There is no reason why you require different levels of antibodies to prevent HPV related non-cervical cancers.
Correct.
So I think maybe the ACVIP wants more robust data in boys to make a recommendation for boys. But I think what data we have is probably enough to recommend one dose for boys as well.
If you look at the original 2-valent and the 4-valent vaccine, there was not a single efficacy data in men. They were always non-inferior on immunobridging between females and the males, and up to the age of 45 years. So I don't think so. You need a differential recommendation for boys vis-a-vis girl. It should have been the same. So maybe even for the boys, I mean, because the ACVIP says you may be very reluctant, but there are many recommended. UK uses one dose till 19 years. Australia uses one dose till 20 years of age. I don't think so. They are lesser wiser than we are. And I think we have no data from our
even
country.
the CDC has recommended one dose
CDC
now.
recommends one. WHO also says one is off-label, two is labeled for up to 20 years. And that's not only 14 years or 15 years, up to 20 years. So I think if you're using an HPV-9 like vaccine, which parents cannot afford 3 doses out of question, even 2 doses, give that 1 dose, which is going to be very helpful, especially for females, because there the coverage of extra 18% makes and breaks the incidence of cervical cancer in the next future 20-25 years of that person's life. So I think if someone cannot afford, boldly give only 1 dose. If someone can afford, maybe you can give the second dose. That's choice left to you. But at least for HPV-9, 1 dose is enough. All right, Surendranath, typhoid. Yes, sir. So routinely, I would give 1 dose if I am using HPV-9, unless the parents can afford and understand, and if they say okay, then I would give him second dose. But otherwise, I will be happy with giving only 1 dose. I mean, that's what I have started doing in my practice. Surendranath, typhoid conjugate vaccine. World over, WHO also is thinking of second dose. Committee actually suggested to add the second dose. ICVIP still says 1 dose. 1 dose or 2 dose?
Yeah, present data shows that there is a decreased antibody level at the age of 5 years. Those are given the typhoid vaccine below 2 years. The data is there.
Yeah.
So data is available that there is waning immunity is there. And
not only waning immunity, waning efficacy.
Effectiveness data also, I mean, shown in Pakistan, where transmission of the disease is very high. The efficacy fails by 2 years or 3 years.
Absolutely.
So
Malawi study, Bangladesh study, all have shown the efficacy drops to non-significant in children who have received their first dose at a younger age.
Yes.
The Bangladesh study shows even older age also, the efficacy dropped to less than 50%. Why is SCVIP still reluctant to give the second dose recommendation? Maybe Dr. Rajshekhar can answer that, because he's in the ACVIP now. By the way, all 4 who are on the dais have been or have been in the past in ACVIP.
So because of ACVI shutdown and because of the studies were not that validated. That was the reason, and they were going to come up with the other when the studies become.
Or you will wait for the WHO to recommend and then you will copy paste.
The studies were showing the confidence interval was not fitting and all this.
Not very convincing.
Yeah.
How many of you use 2 doses in your practice? Okay, let me ask you how many use only 1 dose? All right. So many are there only using 1 dose. Should understand. Please read 2 studies. One from Malawi, one from Bangladesh, showing effectiveness or efficacy over 5 years follow. And you will be surprised to see that the efficacy drops to not significant after 3 to 4 years of the dose given in children who are younger when you give. And all of you must be giving typhoid conjugate 1 year. So that's why you will see breakthrough typhoid in them. If you have given the second dose in 4 or 5 years of age, maybe you will be, that will be much better. So that's the controversy. All right. Dr. Rajshekhar, ACVIP also says no mention about RSV antibody in full-term babies. And we know that while in preterm and very small babies, RSV incidence is very high. But because they are small of the total birth cohort, an actual number of cases of RSV, bad RSV that will happen are more in otherwise healthy full-term babies. So why there is no mention, and what should the pediatrician do? At least expose the parents who can afford to RSV monoclonal antibody, or strictly follow only the ACVIP guideline?
No, sir. Coming to the Indian guidelines, coming to the scenario of India, having a varied landscape, logistics, and then or epidemiology.
No,
now,
we are not talking about public health. We are talking about individual.
Individually, as per the situation, we can offer them. It's a shared discussion for the healthy term.
But that's not mentioned in the ACYP guidelines.
So that is not, we have to recommend it. It is recommended for high risk.
But there is no mention on full term at all.
Full term is that is, sir,
like the NNF guidelines says that it should be given to high risk babies. They define 6 or 7 high risk and say for those parents who understand, can afford, even full term should be offered 1 dose. I mean, that's a sensible guideline, but ACVIP has just fallen short of that type of guideline. That makes the pediatrician worry that it's not required for full term.
It doesn't mean that not required, sir. The situation is different, sir. We have got a vaccine, new vaccine.
It's not a vaccine, it's a monoclonal.
That is a different, it is a monoclonal antibody. It is not a cost effective when it is given
but
to
for an individual cost effective.
So that is a value effective, rather it is a value effective.
The cost effective is at public health. The government wants to introduce this cost. For a person who buys
we cannot say it is not cost effective. One admission of bronchiolitis will cost them 2-3 lakhs in a hospital sometimes. So you can't say cost effectiveness when an individual comes. As a national program, that's a different.
So today one cesarean section costs 4 to 5 lakhs rupees in a decent hospital in Mumbai. Why would that family not afford 40,000?
That's a shared discussion accepted.
But that's not mentioned.
It is offered because whenever the
but that's not mentioned in the ACVP guidelines.
Sir, suppose we come to the meningococcal also, we are not, we are just offering it. We are not recommended only when there is an endemicity.
All right, so not recommended but can be offered to full-term babies for because parents who can afford. Yes, sir. Is that what you Kasi, what would you be doing in your practice?
See, I mean, forget my practice. Now let's look at the data. We don't have robust population level data about RSV prevalence in our country. Only one study, the Mahan study done in Maharashtra, has shown something very different. It has shown that infection is as common in the second year as it is in the first year. Hospitalization due to RSV is more common in the second half of the first year rather than the first half. Now, of course, this is not representative of the whole country. But if we take this data into consideration, what is the idea of giving every normal baby a dose in the newborn period? So, where is the data to suggest that is going to help everyone? So, I think let's not go for ACVIP bashing in this session.
If you see study from major tertiary care hospitals and you look at the RSV incidence in hospitalized full-term babies, not preterm.
Do we have the data in our country?
Dr. Chitkara, will you like to mention about your studies from...
Sir, severity is not there. Sir, hospital infections...
Sir, they are hospitalized means they are severe.
Admissions because the total cohort...
RSV is the one where we have robust data in this country.
Absolutely.
Even ICMR has given us surveillance for 30 years. Unfortunately, many of us are doing these studies or have done these studies, but Indian journals don't post because they think they know everything and RSV is all extrapolated. But this is one disease with a very robust data in this country. And the first 6 months and then followed by 6 to 12 months is the peak time for the disease.
Sir, but
in fact, there was one...
sir, the high risk, the severity of disease is more in the high risk than the normal health.
That is all
admissions
agreed, but number of babies with RSV severity admitted in hospital are more full-term than preterms. Because for one preterm, which is 15% of the cohort, there are 85 more children who are full-term. They may even get 1% of them. The number of children who will be getting RSV will be so much.
Sir, epidemiology, we have the peak is different, there the temperate climate is different. We don't have an epidemiology also, sir. So when to give that vaccine?
Sanjay, last remark before you go to the next question.
I think the audience at large, this particular molecule, what Nitin is talking about, actually will be a game changer. Last year, in our own NICU, we have given at least 35 babies Nirsevimab. And I think it does make a lot of difference because they got admitted and in the NICU only they got through the other babies. So giving that 40,000-50,000 worth monoclonal antibodies, not going on ventilator, much less stay in the NICU, I think it's a good product on the floor. Now, whether to give for the term babies, I think counseling needs to be done to parents one-to-one. And I think give the option and tell them that this is the possibility. When you have a drug which is proved its efficacy, and I think so from the pediatrician's perspective, we see a large cohort of preterm babies getting born and surviving today and getting repeated admission in the first year of life. They spend 5 times minimum the more money and the trauma
Yeah,
associated.
preterm, absolutely, there is no problem.
I
Okay,
think we should counsel.
let's stop here. And Sanjay, one quick question. We didn't have data on 3+1, which means the booster dose for the PCV13TT, which is the Chinese vaccine marketed by 3 or 4 different companies, and the PCV14 from biologically. Now we have data submitted to the ACC. ACC has approved for both of them the data. Now that's not come on the label. It will come on label very soon.
So the biological E has been the DCJ approval is 2+1.
SCC, not DCJ, SCC.
It's not yet come, but they have put the trial is over. We are just waiting it for the.
Correct. No, but the data is available.
Yeah.
What I mean. So you think it will come as a booster in very because see for PCV10 of serum there was data from Gambia which made the committee of SCVIP saying that okay, because there is some data you use it till 2 years, but that was not true for PCV14. Now that data, I think the SCVIP should.
I think so that if it's an Indian manufactured vaccine and if the data for the booster will be available, the DCGI will give the clearance and it will be a part of the NIP. That's
but
my
it is
opinion.
still till only 2 years of age and not beyond. All right. Let's move to the NIP to private practice and vice versa, which is the real practical issue that a pediatrician follows. And maybe we can quickly give answer because there's no controversy as in the first section. So Kasi, someone has said FIAP in the public health, 1 or 2 doses, now comes to you, wants to shift entirely to vaccination.
Okay.
How many full dose IPV will you give and when will you give?
I think, say, FIPV versus IMIPV.
Correct.
Different doses, different routes of administration.
Correct.
Okay? So it's very difficult to sync the two of them. In general, 3 FIPV doses versus 3 IMIPV given at 6, 10 and 14 results in 100% seroconversion with all the 3 serotypes.
Yes.
With both the routes. Antibody titers are much higher with the intramuscular route.
Correct.
Now, if you come to the NIP schedule of 6, 14 and 9 months, at 18 weeks, that is 4 weeks after completing the second dose, the seroconversion against type 1 is only about 70-72%, lower against type 2.
For type 2 especially.
For type 2. And type 3 is also about 70-75. But if you take 3 IMIPV, your seroconversion is 100% following priming. So definitely, the other thing is you must remember the NIP schedule, FIPV is a risk mitigation strategy. We are also using OPV. It's the combination which is working.
Correct.
So now and the other thing is, generally both the CDC, Australia, they consider 2 fractional dose as equivalent to 1 IM dose. So now the problem comes if a child has taken the 6 weeks vaccine and then comes to you.
Yes.
Now taking these consideration, he requires 3 more IMIPV.
Correct.
That one cannot be counted.
So suppose you taken 6 weeks and now comes to you, you can easily switch to IM.
Then that one FIPV is not equivalent to 1 IMIPV.
Correct.
You need to give 3 more IMIPV.
So that will be advanced. So you can give it 10 weeks, 14 weeks and the first booster that there is no wild polio.
No, then the
You're not
gap
worried.
between the two is too large.
But there is no standalone IP
So
available.
that means you can give 10 weeks combination vaccine.
14
That means your first IMIPV is 8 weeks.
Correct.
In that case, you require only 1 more dose if it's 8 weeks interval.
Correct.
So 2 choices, either you postpone the 3rd dose to 8 weeks, may not be very safe.
Correct.
But if you look at the in-between efficacy of a primary doses, the difference between the 2nd and 3rd dose is not too much. The 3rd dose is important to maintain antibody titers till the booster. Maybe not a very bad choice.
Correct.
The other way is, you give again at 10 weeks and 14, but also give OPV also.
Absolutely.
Otherwise, you tell them it's not possible, go back and complete it in the
And give the booster also with IPV
yes.
in the first and the second boosters.
Yes.
Okay, fine. All right. PCV, Dr. Surendranath, 2+1 in public health, 3+1 in private practice. Someone has taken 2 doses and now the 3rd dose is given at 9 months, but before that he switches to you. Will you give him the 3rd dose which is due, or you will wait for 9 months, or will you wait for only for the booster?
No, if he comes after 10 weeks, I'll give the 3rd dose of IPV, definitely.
Okay, and then
3rd dose of PCV.
And then you will give him also the booster dose
Booster
of PCV.
dose at 15
and
months,
if he has
I'll-
taken 6 weeks, 10 weeks and 9 months, all 3. So
in-
after that he comes to you. Now will you
in
give
that-
an extra dose in the primary or just give the booster?
2+1 schedule of 6, 14 and 9 is quite good enough for
Correct.
the seroconversion.
Correct.
The last dose can be a booster dose, the antibody level is well.
So there you don't give an extra dose, you will just give the booster. All right, perfect. All right, Dr. Rajshekhar, Someone has taken one MR or both the MRs in public health, now comes to you, understands that mumps is equally important. How many MMR would he receive?
Sir, if the age is, suppose he has come at 18 months.
Say he's taken only one MR at 9 months, now he comes to you.
Now I'll give 3 doses.
3 doses of MMR.
First I'll give the first one.
When?
First
At what
MMR,
age?
the one he comes to me.
15 months,
15
okay.
months. Second I'll give after 1 month. Again I'll give it the preschool age because there is an antibody waning of the mumps and he goes into
And
school.
if he's taken 2 MR, the second also MR at 12 or 15 months and now comes to you.
Then I'll give 1 dose now and 5th year I'll give another one to because there's a immunity decrease. The antibodies are decreasing after 5 years.
So any mumps antigen taken beyond 1 year, 2 doses are sufficient, but 3 are better. And in fact, some outbreaks which have happened in USA where they have taken 2 doses as child at 12 months and 15 months or whatever, they also give to adolescents and young adults in the outbreak area because
clustering
mumps doesn't have to have a very long term antibody. So I think it will be individual intelligent choice as to how many doses of MMR, but at least 2 doses beyond 1 year should be given. Yes, Dr. Kasi.
US data should not be blindly accepted by us. US has very high coverage. There is no natural boosting.
Yeah, and
here
yet
we
they
have
get-
lot of natural boosting.
And yet they get mumps outbreak.
Yes. So here we have so much of natural boosting. So I don't think an adolescent dose is really necessary.
No, not now. I'm saying because they use even 3rd dose, which means you need at least minimum 2 doses of MMR beyond 1 year of age. So if someone has taken MMR at 9 months and just takes 1 more MMR at 15 months, that's not adequate as far as mumps is concerned. All right. Rota, Dr. Sanjay, the national program gives up to 1 year of age. WHO says even up to 2 years of age you can give because the intercession risk is far lesser compared to risk of dying of diarrhea because of retrovirus. Can I do that in my private practice or strictly stick to that 14 weeks and 6 days for the first dose and 32 weeks for the last dose?
So I think for the audience, first dose 14 weeks, 6 days, the last dose 32 weeks. The NIP allows the first dose up to 1 year and the WHO allows it to use after 2 years. The study shows that if you give up to 2 years, the number of death averted due to gastroenteritis versus those due to interception, it's 150 raised to 1. So there's a sure shot advantage to give the coverage. We in our practice, on a private practice, still follow the 14 weeks, 6 days and this thing. And I think we continue to follow it till the recommendations come on the board. But I'm sure if there are so much benefits next time, the ACVI
Don't look at him, look at your left.
Yeah, okay.
So remember, the Serum Institute's Rota vaccine for the last dose is licensed till 52 weeks. So you could, that's the only leeway you have for the 3rd dose. But for the first dose, no, I wouldn't venture unless SCVIP says that based on now, if you can copy the rabies 5 doses, you can also copy the rotavirus doses. And I think that was missed by Dr. Anurag Agrawal's team. Now maybe Rajshekhar, you are for the 3rd time in the same ACVIP. You are the senior most member.
100% mortality, so don't touch rabies.
All right, Dr. Kasi, the public health doesn't give hip booster in the 15 months. Whereas we give hip booster because we give combination vaccine. And I distinctly remember UK was the first country to drop the booster, trying to reduce the number of doses from 4 to 3. And they had miserable outbreak of hip in the 2nd and 3rd year because they thought the booster was the most important. So they reintroduced booster. And for when it came to PCV, they were smart to drop one primary rather than booster. Now, a lot of children in our country are not receiving hip because they are taking vaccine from the public health. If they come to you, would you give a hip containing vaccine?
Certainly. I mean, a booster at 1.5 years, 15 to 18 months is necessary for hip. And I think, as you said, even in the pre-introduction study of hip,
correct,
in India, 23% of all hip cases were in the 2nd year of life.
Correct.
Now, you gave the example of UK, where they started with only priming without a booster. They had outbreaks in the older age groups, and then they came back with a booster. But if you look at data from Gambia and Kenya, things are different. Even with 3 priming doses, they have got sustained protection till almost 14 years. But there is some waning of antibody titers, so outbreaks may occur. So I think it's a wise choice to give a booster at 16 to 18 months.
Those who have taken primary series vaccine in the public health, if they can take that 1 dose of 15-month booster with you, you convince them, saying that because they will be not giving IPV, neither they will be giving HEP in the 15 months, whether you can do that by giving the booster. Many parents would agree to spend that extra money only for that one dose with you.
But I think the single HIP is not available. You have to
No,
give a
not, so
combo.
you'll give combination, no? Right, okay.
That's all.
So last question on the NIP to private and vice versa was use of IPV. Again, at 5 years, government doesn't give IPV, Surendranath. So what will you do for those patients? Because that's the last chance for you to give an IPV containing vaccine. Standalone IPV
In
is
the
not
private
available.
practice, we are giving the tetravalent vaccine only.
So you will give a tetravalent DTAP IPV. Dr. Kasi, you disagree, agree?
I'm neutral in this. Now, I think this 5-year booster came during the time I was...
During your tenure, sir.
No,
you can't have two faces.
No, I can't have two, but you can always gain more knowledge after you have made a decision also. Now, there are two aspects in polio protection. One is seroconversion. If you have seroconverted, you are assured of protection against paralytic polio lifelong.
Correct.
But if you have very high antibody titers, you may also have better intestinal immunity. From that point of view, I think a booster at 5 years is going to help, because it's really going to jump your antibody titers to very, very high levels, which will remain elevated for almost another 8 to 10 years after that.
In fact, the titers go up more than what was happening post 3 primary doses. So that is the powerful. So I think the pharyngeal immunity and the intestinal immunity, which are both important to prevent VAP as well as CVDPV, should it occur. I mean, we are very lucky as a country that we don't have CVDPV. There was one AVDPV, by the way, in Bombay last year, but there's just one AVDPV. Whereas there are several countries in Africa which have outbreak after outbreak of CVDPV. So we cannot be resilient till entire polio is out from the world, not only wild but even the vaccine derived and the circulating vaccine derived polio virus. All right. I will jump to the fourth section because we have just 15-20 minutes. How much time we have? Anyways, 17 minutes, okay. But I have to catch a flight. All right. So, Dr. Rajsekhar, meningococcal vaccine. Now pediatricians are without patients. Lot of vaccination has gone to public health. Everyone has started giving meningococcal vaccine to almost every baby. So what's the role?
So
Forget the SCVIP. SCVIP has very clearly said, what will you do in your practice, or what should a pediatrician do? Is he right in giving it to every patient?
So coming to that context of meningococcal, what context is, it is a vaccine which can prevent a disease and it's a serious disease.
Correct.
Then comes the question, if you have given the vaccine, suppose what happens is that I have given the first dose or second dose, we are a low endemic zone, 2%. We are less than 2 as a WHO guideline. We don't recommend meningococcal vaccine in the normal. If the pediatrician has given it as an offering vaccine or something, this works on only 5 years, 3 to 5 years. Then after that, we are not recommended any booster also. Where will that child
Unless
go?
in immune compromise.
Unless in, that's why I'm talking about the non-violent. You talked about the RSV antibody. So we have not recommended it.
So what's the point in giving those 2 doses or 1 dose at all?
That's what.
No, so I heard Dr. Yevle saying in one place that if I have to give, I will give 2 doses at 9 months and 15 months. Then I'll give it 5 years and 12 years, 2 more. But that's the only way I can protect them till they are out of my pediatric practice.
Yes.
After that, I give it to adults, then let them do what they want to do.
That's what. So that
is that a practical way, or is that too much to do?
I personally think so that what Nitin told, I think meningococcal vaccine is given for a pediatrician primarily because the vaccines have dried up in practice. There is no indication of giving meningococcal vaccine into day-to-day office practice. It may be in northeast states or some, but just taking, I think, look at the sale of meningococcal vaccine. Every pediatrician's file has meningococcal.
Let's not talk, we're discussing only science. Dr. Kasi,
I don't use it
do
routinely.
in your practice? Let me ask you only one question.
I do not offer it routinely.
But if the parents ask,
but if a parents ask for it, I explain.
Perfect.
If they still want, I will give the vaccine.
Surendranath.
But again, I will try to convince them not to take it because of the reasons what Dr. Rajsekhar said.
Yes, Surendranath.
If you take, as far as the disease pattern is concerned, they are
Yes,
more.
sir, you give it or don't give. I want to personally.
I will offer it. I will offer it.
You will
sir.
offer it, okay. I have not printed the vaccine in my vaccine file, so I don't expose it upfront on my own. But there are several parents who have heard through WhatsApp group, and they will come to you and then don't deny. I think any vaccine which is licensed available should not be denied, because some problem can happen and there will be trouble. And I will tell you, there have been incidents of meningococcal disease very sporadically in every part of the country. It's not that it doesn't exist. So we can't be saying so many antibiotics. I remember there was one child admitted in Yevle's hospital, child died in 24 hours, CSF grew meningococcal. There was one more in Hinduja, there was one more 5-6 years back in Hinduja. So like that, there are too sporadic to make it as a recommendation, but don't deny any vaccine which the parents directly ask. Can we leave it there? I think, yeah? Okay. So Mike.
We have recommended only for high risk. About normal we are not talking. So that way only this
RSV is not as uncommon as meningococcal. RSV I see at least 3 or 4 every month who are admitted. Forget about OPD patient. So that's the difference between the two.
I think ACVIP is more bothered about the cost, I think.
All right, Sanjay.
That is
Dr. Agrawal is here and he is very strongly recommending everyone should take pre-exposure prophylaxis. In today's time when there are so many dog bites, he said in your lifetime you should be lucky if you are not bitten by one animal. What's your take on pre-exposure to everyone?
So I think there is a recommendation for pre-exposure. I think if anybody has a pet dog at home, then he should get pre-exposure, left, right and center pre-exposure.
So there are community pets, now there are society pets, there are building pets, there is PETA which is preventing the pets to be removed and all sorts of things. And it's a menace. I mean in my building there are 15 cats and we are only 15 people staying in the building. So there are more cats than people in my building. Okay, now cats generally are not ferocious, but dogs can be very ferocious. So seriously, I mean, injecting a monoclonal antibody in a wound is painful for a child, for anyone for that matter, and it's expensive, and if it's not available, detrimental. So pre-exposure should come in a big way. What is the IAP stand on pre-exposure, Dr. Rajshekar? Is it considering or any idea?
It is only in the high risk people. Not the pre-exposure profile is for the general population.
Pre-exposure, no. Okay, maybe. So, Dr. Agrawal, you missed the bus when you were a member. Now you have to blame yourself.
He was also against it, sir.
All right. Third important question, Dr. Kasi. You are in Bengaluru, there is no JE. I am in Mumbai, there is no JE. There is JE in the New Bombay in the public health. There is JE in the neighboring district in your area and same in Pune. So, do I give JE in a non-endemic area which is very near to an endemic area? Because people travel.
Yeah. WHO has very clearly said that if an individual is staying in a non-endemic area which is adjacent to an endemic area,
correct,
and there are environmental conditions which are conducive to JE transmission, one can consider giving JE vaccines even if there is no defined JE burden.
Correct.
Very clear about that.
But I'll give you an example, like say in Bengaluru or in Mumbai.
Yes.
Neither there are pigs nor there are wedding birds.
No, there are pigs in Bangalore, quite a lot of pigs.
You have pigs? Okay, we don't have any pig in Bombay.
No, we have. Pardon, what is the pen division?
Adjacent geographical district.
Geographical district, borderline, borderlines only.
Like Mumbai and Navi Mumbai are physically connected adjoining district.
So I'll just give one example. I think I have spoken about this before. Let's take that in Tamil Nadu, you have Kadlur district and Tanjavur.
Yes.
Both rice growing, paddy fields. Kadlur was endemic, Tanjavur was non-endemic. They did seroprevalence studies in Tanjavur. In 1990-91, it was 1.6%. 2 years later, it was 5.6. 15 years later, 32% and then 56%. And today, Tanjavur district is now endemic. Now, if you look at the JE map of a country, I remember 2000 to 2010, 14 states.
2006, when I was the president, sir,
Yes.
there were only 8 districts which were JE endemic.
Then it became 24. Today, 28 states. Now, if you see the JE map of our country, there is no state which is not JE endemic.
Except Gujarat.
Gujarat also now comes on the map now.
Chetan bhai?
No, Gujarat also is in the map.
No JE.
Gujarat is in the map.
Not a single district in Gujarat is JE endemic.
Okay. So I think almost the whole of the country, and I think it's not long before JE becomes for everyone.
So I think JE is a safe vaccine. It is cost effective because it is under DPSU and only 2 doses. I think that's something which you should do more often than meningococcal, which is you are doing for your own purpose. All right. 4th question, Surendranath. Flu, trivalent or quadrivalent? Because there is one brand which is still quadrivalent. They are saying, no, quadrivalent is better. Yamagata may can come back tomorrow. Then what will you do, etc. And as Dr. Kasi was asking, suppose there is a 6-month-old child who is never exposed to any flu vaccine quadrivalent in the past, so has no Yamagata immunity, should you at least give him a quadrivalent or a trivalent?
We should follow the WHO recommendation, sir. because Yamagata strain has been not seen since almost 4 years, and as the antigenic shift or drift are concerned, Yamagata B is very rarely drift or
Not
shift.
even rare. Since 2022, I think
seen.
not a single case
So
in the world.
a trivalent is definitely
Okay.
recommended compared to the quadrivalent.
So I think everyone should shift to trivalent, no matter what you say. Of course, you can use quadrivalent. There is nothing against using, but that is not because it's an advantage. It's just because that brand is available. Tomorrow that brand also will become trivalent, and then you will have no controversy at all. Dr. Rajshekhar, IAP says flu vaccine till 5 years. Government India in past had said up to 8 years. What do you do beyond 5 years? Because a lot of pediatricians do continue to give flu vaccine even beyond 5 years. Because not that you don't see severe flu in children above the age of 5 years. So I understand as a recommendation you may not say, but for a practitioner, what should he do?
Sir, basically why the thought has come? Because after 5 years we only give to the high risk children. Now the thought has been evolving that there is a age shift, sir. Now influenza is increasing after 5 years. Around 2 years the age shifting there, and complications are increasing, co-infection is increasing. I think so because ACY needs the data, so all the data can be gathered in the next week and go more than. These are put for thoughts.
So I think till 5 years at least you should give to everyone. Beyond 5 years for high risk, again you should give. But beyond that for normal children, again it's one-to-one basis.
One-to-one basis. Because now the reason also, another reason is that the school going children are getting, last year we saw everyone, and they come and transmit the disease to other in the 20% we get that.
Correct.
I think that one-to-one is a very abused statement.
Yeah. Shared discussion.
But
I think we have to be...
One-to-one is where whether either you want to give the vaccine or the parent want to take the vaccine or both want to take the vaccine, then you discuss. If both are agreeing, there's no one-to-one. If none of them wants to give vaccine, then don't even discuss. Like I don't have meningococcal on my file, I don't discuss. Parents don't ask, forget it, quits. You want to add? No, that's it. Yeah, okay. So, yes. That's what we said. Up to 5 years, definitely. Beyond 5 years, in high risk, definitely. Beyond that, parents' choice. You discuss with them what's the advantage. You say flu is much less after 5 years, but you still want. They feel that every viral infection is going to be prevented by flu vaccine. I mean, that is what you have to tell them. At the school, they are going to get this recurrent infection, and there is no other choice. Most of them are not flu; they are other viruses. All right. I have 7 minutes, so I had 4 more questions on something which is drastic, which I think should not happen in any clinic, but keeps on happening. Dr. Rajshekhar, expired vaccine. You put a sticker, put your foot into the mouth of the patient, and now what do you do?
So first of all, expired vaccine is an error or not? It is an error. Second, valid or invalid? It is an invalid dose.
Correct.
So we have done it. So we have to 4As, we have to accept
So if it's killed vaccine, you repeat when?
If it is a killed vaccine, we can repeat on the same day or any other day.
And if it's live vaccine?
We repeat after 1 month.
4 weeks, perfect. And now how do you counsel the parents?
Counsel parents. So that 4A approach,
yes.
You have to
just tell them what are those 4As. Huh?
4A approach is first we have to accept it, naturally we have to accept it. Then we have to apologize. But today, apologizing and accepting, we have to take 1:1 as you always tell.
Correct.
Then assure that nothing is going to happen.
Correct.
Because there is no adverse effect.
Correct.
Then we have to administer the vaccine.
And I will add just fifth that now you are anticipating a medical legal case.
That's what, sir.
Because lots of cases, at least 10 cases I know I have been helping them to fight in the court of law, and mostly nothing will happen, but it's a tremendous tension if you have a case against you. Somehow we are still
Nitin,
not...
I think another question which comes about expired vaccine is the expiry is April 26. I think the validity is till April end.
Night.
I think 30th April, because lot of time...
No, if a date is put, it is up to that date. If the month is put, it is the last date of the month.
I think that you should take into consideration.
But folded hand, there is no law which says that you have to put the sticker.
Yeah, that's
not a single law. So please don't put sticker.
That's I am not.
And if the parents, some parents will ask because the previous at least look at the, I mean, immunization is your bread and butter, and now you want water to survive. If that also you don't do carefully, then what are you doing? It's like surgeon cutting the wrong leg.
Studies have shown that if you check something 3 times, the chance of making a mistake is 0.
Correct.
If you check it twice, chances of making a mistake. If you check more than 3 times, there is no advantage. So either you check it 3 times or 3 people should check the label. You will never make this mistake.
So here the system makes the vaccine and hands it over to you. And that's the next question to you, sir.
If you are administering the vaccine, it's your responsibility to see that it's not an expired dose.
So next question is to you, Dr. Kasi, that the system made a vaccine and given to you saying that this is hepatitis B and you have injected intramuscular, it actually was BCG. Now what do you do?
No, please repeat it.
System made a vaccine to be given as hepatitis B at birth, you injected it, and then she said, oh sir, it was BCG.
Okay. Now, one, is it harmful? Second, will it work? These are 2 things.
Yeah.
Harmful, certainly you're given a massive load, 1 full vial, 10 times the usual load. You may develop an abscess over there, which you will have to treat it like any other BCG adenitis. Second thing is, will that vaccine work?
It will.
There is no reason why it should not work.
Yes.
Invariably in all these patients where it was given by the subcutaneous route, tuberculin test turns out to be positive, you don't have to repeat the dose again.
And the worst is that in corporate hospital, instead of BCG, an onco-BCG is given. But that's even 100 times more potent than the actual BCG. So this mistake should be avoided. Sanjay, wrong timing for the live and the killed vaccine, how do you now correct? Like suppose live vaccine was given within 2 weeks of interval of one another.
So I think...
so which one is invalid, the first or the second live vaccine?
The second one.
Second one. And then when do you repeat the second
You
one?
wait for 4 weeks more and then repeat.
4 weeks after the mistake?
After the mistake.
So 6 weeks from the first
so
vaccine.
I think killed vaccine you can give anytime, live vaccine 4 weeks apart, same antigen 4 weeks apart.
Correct.
Combination of live, killed anytime you can give.
So only rabies is the only exception where you give back to back, but otherwise 4 weeks. And
I
live, to killed and killed to live, there can be no need to have any gap.
No, nothing.
Perfect.
I think one thing, Nitin, before what Dr. Kasi sir told, in a busy practice, most of the time it's the nursing staff which makes the vaccine and gives it. Let's be very practical. This is, make an habit of the sister to be trained and she should show you the ampule before you inject.
Correct.
Because what is giving expired vaccine happens very commonly.
Correct.
And the people sue the doctors and ask for, we have had so many issues asking for some amount of compensation. Make it a habit that let sister dissolve. I am not against it. But she should show the vaccine to a pediatrician and please do not be in haste unless you see yourself.
Correct.
Or she mutters expiry, then sir check Influvac. I think whatever it is.
One more caution is that the syringe in a pre-filled or a syringe pack, the syringe is a different expiry than the vaccine. And every time you go by the syringe and the needle expiry rather than the vaccine expiry, because the needle is given separately. So all sorts of mistakes can happen. Be careful. Don't stock more than 4 or 5 doses in your fridge. I'm sure all your dealers will be happy to serve you every day if that is required. So don't stock so much that there will be a expired vaccine in your fridge. And the last question that I have, and we are almost finishing, is you give a wrong vaccine at a wrong time. Like suppose Dr. Surendra, someone is given Menveo. I'll take the brand name because at 9 months instead of Menectra. Is going to work, and what will happen?
It's going to work definitely. The permission is not there as far as India is concerned.
Correct.
The same vaccine is given for infants in the UK and USA.
Okay. So what do you tell the parents? You need to repeat it or you do not repeat it?
I don't think we need to repeat it. It is only a off-label vaccine which is given.
Correct. So Menveo is licensed from 2 months of age onwards internationally for immunocompromised, 2, 4, 6 months. So it will work at 9 months, but it's not given license at 9 months in our country. So Mike.
If it comes at 12 months, will we give Menveo or Menectra?
We will give you Menectra because still second Menveo is second mistake. First mistake the parents may pardon, the second time they will not pardon. Okay. Alright, so I think that's all the question I had on the challenging situation which we have faced day to day. Either any question, we have 2 minutes. Yes, sir. One question, yes. Correct. Sir, 1-to-1 basis. Thank you everyone, thank you the panelists.
Thank you, sir. Now I would like to request all of you to please collect your memento from the memento corner.
There is another session. Hello? Who is? Tea will be served in the hall. Please stay back. There is another important session. क्या हुआ? Why? Session থেকে announce করবে। যেটা আমি আছি আমি কি করে আসবো? তিন চার দাদা কোথায়? অ্যানাউন্সটা কর, অ্যানাউন্সটা কর। ভ্যাকসিন যাবো আর আমি তো আছি, আমি কি করে অ্যানাউন্স করি?
So the next session we have is a quiz program with on-spot prizes. It's called Vaccine Samvad. Moderator being Dr. Chetan Trivedi sir, and experts Dr. Rashna Das Hazarika ma'am, Dr. Paulup Chatterjee sir, and Dr. Khea Ghoshuttam ma'am. I request all the delegates to come back to the hall for this session.
Tea break was what? The tea. So there is again a disconnect. Voice whatever, it's fine. Just photo session.
Good afternoon. As you have been listening to all the stalwarts all throughout the day, and they were just, giving you knowledge. Now the question is how much knowledge you got it. So it's your time to answer, because all these quiz questions, whatever I have made, I was not aware that these all sessions are going to be there just before this session. So I think it is all answers, you are knowing it. Only thing is you have to have a presence of mind, because ultimately it's a MCQ. So there may be some quiz like accept or true or not true. So to read it and then you answer it, you are definitely going to win the prize, and we have 10 prizes. So most of the time what happens that those are faculties, they are also participating and they are getting prizes. Now I have found a way out of it, because there is an option. I can go beyond 10 names also. So I will go till 20 and we will give it 10 prizes. Those who are not a faculty, we can give the prizes to them. So faculties, they definitely can participate. And so it is about the vaccine samvad. So it will be samvad between me and you. And of course, whenever there is a confusion and we have expert faculties, they will answer it. Dr. Rashna Das Hazarika, Dr. Pallav Chatterjee, and Dr. Khea Ghosh. So now first, I think you are allowed to keep your mobile in your hands. I'll just, yes. Okay, so first slide will come on the screen and you just scan this Menti code. And just stay there. I will ask the first question. At that time you have to give the name to your device. I think everybody is aware and most of you must have attended these sessions because it ultimately, genesis of this session was in Kolkata only. The first session we did it was at Kolkata. Anyway, so everybody is ready. I think 56 people have joined as of now. Still people are joining. And those who are coming late also, they can join because there will be a QR code which will be flashing all the time. Okay, good. So I'll just go for the first trial question, and of course the trial question will be very easy. Hope if somebody gives a wrong answer, that means it's a technical problem on his side, his or her side. Okay, the first question is there on your screen. Let me see how many ready. Okay. Now give name to your device. Option came to your that. Give name to your device. Okay. So question 1. It is there on your screen. In which state the most hyped assembly election is going on presently? Do you need options? I have to keep the question such that if anybody is not aware, ask the person sitting next to you. Okay, so now the system is working properly. Nobody has tried other way. You know, somebody must have given a wrong answer. 2 rights because I am from Gujarat. Anyways, so now the quiz number 1 first. So this is first, I will put it on here and then it will come to your screen. Just read the question at your ease. Which of the following statements is true for the JE vaccine? Genvac is inactivated cell culture derived SA1414-2 strain JE vaccine. Genvac has got DCGI approval for single dose. GEV is inactivated cell culture derived kolar strain of JE, and Genvac comes in 2 strain, 3 microgram and 6 microgram. You read the question, now it will be there on your screen. Let me see how many of you are ready. Okay, now the question will be there on your screen and you can scan the bar also, well, like QR code also if you have not joined. Okay, now the question will be there on your screen. Which of this following statement is true for JE vaccine? And here the clue is, faster you give the correct answer, more points you get. So more chances of you being in the leaderboard list. I hope everybody should answer. Okay, good. Okay, so there is a confusion. What is that confusion? Is it a wrong answer from my side? Because only 12 people have given the correct answer. Yes, who will take that? JE endemic zone? Dr. Rachna.
So JE is actually, you have answered A, no, maximum people. This is not SA1414-2. This is the kolar strain. So therefore A is a wrong choice. GEV is again not kolar strain, and it does not come in 2 strengths. It comes only in 1 strength. So B is the correct answer. Though DCGI has given approval for single dose, but if you ask me, I'm not comfortable. I always give 2 doses, 1 month apart.
So even Government of India and ACVIP is not comfortable with that. So this is why the DCGI gave approval, because /2/3 data, it shows that even at 56, so 28 and 56, you see the seroconversion, 96%. And then it goes down at 368, around 65. But still, when it was compared head to head with SA1442, that was a Chinese brand which was there in the market at that particular time. Even seroprotection you see, 98, 99%. But then it goes down. So what we know that Government of India and ACVIP knows that you need a long protection to be long-lasting protection. So if there is a waning of an antibody, which should not be giving for single dose only. That's why we are continuing with 2 dose. But Genvac is having a single dose license, DCGI's approval. Okay, so this is again GMT. Okay, now next, flu. Pardon? Okay, it will come when the question will come. When the question will come, just see the question now. Okay, which of the following is true for influenza vaccine? Influenza vaccine, inactivated influenza vaccine as an absolute contraindication for subject with egg allergy. Recently, Yamagata strain dropped from quadrivalent influenza vaccine. History of GBS is a contraindication for influenza vaccine. oseltamivir given within 7 days of influenza vaccine interfere with the uptake? Now this question will come on your screen and there is a QR code if you can scan it. Okay, so just now I think everything was discussed 10 minutes before. So hope everybody will give the correct answer. Yes, yes. But short-term memory, those who are having like me, they also can answer this. Which of the following is true for influenza vaccine? Yes, majority of us, they know the answer and we have discussed it. Anything to discuss, Pallabda?
No, nothing, only that egg allergy is not an absolute contraindication for...
It's a precaution.
It is a precaution. And GBS is definitely not a contraindication, and oseltamivir causes no problems with the vaccine.
So there is a confusion. Somebody called me and showed the photograph of the purple book showing that this oseltamivir within 48 hours, it is a contraindication for this. But it is not that. It was given in live attenuated section. So it is not for inactivated. For live attenuated, yes, oseltamivir. Otherwise, oseltamivir will not interfere with the vaccine, or vaccine will not interfere with oseltamivir. So that's the thing. Another two, egg allergy and GBS, both are precautions, not the contraindications. So as of now, contraindication only is anaphylaxis to either the vaccine or component of the vaccine. Okay, now next, rotavirus. Which of the following is true for rotavirus vaccine? A. Rotavirus vaccine is no more contraindicated in patient with past history of intussusception. Efficacy of rotavirus vaccine is same all across the globe. There is no increased risk of intussusception with Rotavac, and Rotavac 5D is having VVM2. Okay, you understood the question, you saw the answers, and now it's your time to answer. Which of the following is true regarding the rotavirus vaccine? You can read it out and answer it. Past history of intussusception, is it a contraindication or not? Efficacy is same across the globe. There is no increased risk of intussusception with Rotavac, or Rotavac 5D having VVM2. Still so much of confusion. Okay, then it is a good question to be asked.
So there is a mixed reaction.
Oh, yeah.
So
first and third
you can
option.
See, we have a here for the first and the C. See, there is no increased risk. There is, of course, there is in normal children, even if those who has not received any rotavirus vaccine, there is always an increased incidence of, incidence
it's the same.
of intussusception is same. And it occurs in the 5 to 7 months mostly. So if you give rotavirus vaccine, see the incidence is actually 1 to 4 in 1,000 live birth normally. And in rotavirus, if you have given rotavirus vaccine, it is 1 to 6 in some of the studies. So more or less it is same. It is not, it's said as not an increased risk.
But still it remains the contraindication if there is a history If there is a history of intussusception, you will not give it. But why I have put this particular option is because we know that whatever intussusception occurs, it is occurring after within 21 days of the vaccination, either 1 dose, 2 dose or 3 days dose. So if you compare the relative incidence of intussusception, that is in that particular time versus all time, if there is no statistical difference, then there is no increased risk of intussusception. So you know that Rotavac, it is phase 3 trial was in a very small numbers. So it was not powered to give whether the intussusception is occurring or not. So this was self-controlled case series was done by Rotavac company and 727 hospitals, 589 infants, and they tried to analyze what is happening. So what they found is no increase intussusception risk was found in matched case control study. And now one more study which has come recently, that is impact of indigenous rotavirus vaccine in universal immunization program in India 2016 to 20. We know that during this period, it was all Rotavac was given in the NIP. So what they found, you know that whenever vaccine has been introduced, it is coming after phase 3 trial, and there is the effectiveness or efficacy data. And what is really happening once you start using in a national immunization program, that is effectiveness. So what they found, an effectiveness of 54%. So effectiveness closely matched to the efficacy reported in phase 3 trial. So that was one. It sustained for at least 2 years of life. That is period of highest rotavirus burden. And it showed strong cross protection against other serotypes also. And positivity rates fell from 40 to 20. So that means this paper is such a unique paper that it gives effectiveness persist.
And also those who have given correct for there was a variation in the efficacy of the rotavirus vaccine globally. So it is actually not true. It is not the same throughout, because the efficacy of rotavirus vaccine is always high in high endemic, high economical countries, whereas in low to middle income countries, it is always low. This is because of most likely because of the maternal interference. So in low to middle income countries, the mothers who are exposed to so many communicable disease, they transfer more antibodies to the babies, and thus there is interference with so in lower or middle income countries, we have a lesser efficacy for the rotavirus vaccine. And I think some of them also give a correct to the VVM2. So regarding VVM2 and VVM7, so Rotavac 5D is a more heat stable vaccine. So we have VVM7 instead of VVM2. VVM2 was in Rotavac, which was very heat, it was very sensitive to heat. Whereas Rotavac 5D is a more stable, you can keep it in room temperature, 2 to 8, not room temperature, sorry, 2 to 8 degree, not, you don't have to keep it in minus 20 degree, and it stays. So VVM7, the vaccine vial monitor is 7. I hope everyone knows what is VVM, what do you mean by VVM2 and VVM7. So it is more heat stable, so VVM7 is given for Rotavac 5.
So there is a journey from Rotavac to Rotavac 5D. So there what happened, initially there was 0.5 ml and minus 20 degree was requirement. And there was no buffer, no stabilizer. They added both. So what happened? The volume became 2 ml. And yeah, they could preserve it till 2 to 8 degree. But then what happened? They observed that because it is a naturally attenuated strain which was found in the neonatal nursery of AIMS. So what has happened? This natural attenuation, because of that, the infantile pH, which is usually, it kills the rotavirus. That's why you need a buffer. But this, because of naturally attenuated, it sustained infantile pH. And that's why even without buffer, only with stabilizer, we were able to bring down the temperature requirement to 2 to 8 degree for 7 days. So that's why it was more stable, and that's why what happened, that this vaccine has come with 0.5 ml, and you can keep it for 2 to 8 degree and VVM7. So that is the all concept of this thing. Now question number 4. Which of the following is true for type B TCV vaccine? There is no established absolute correlate of protection for typhoid disease in or vaccines. In type B TCV, typhoid VI antigen conjugated to non-toxic mutant of diphtheria toxin, ACVIP has now recommended 2 doses, second dose at 3 to 5 years interval, and it has a data for 3 months to 45 years, this type B TCV. You choose your correct answer. It will be there on your screen. This has also been discussed. Which of the following is true for type B TCV vaccine? Is there any established correlate of protection? Is it conjugated, type B TCV conjugated to diphtheria toxin? ACVIP is given second dose recommendation, or this type B TCV has a data 6 to 45 years of age only. Which one of this is correct? Okay. So majority of you got incorrect because there is diphtheria toxin. What is it?
It's tetanus toxoid.
It's a tetanus toxoid. And many of you have believed that second dose recommendation has come from ACVIP. So I think the session just before that.
Just finished, yeah, the session. Though the studies are there, ACVIP has not sat down to give this recommendation as yet.
So in recent purple book which is published, they have still considered single dose recommendation because 7-year data is there. But why I have kept this particular question is, one is because type R TCV is having a huge number of trials, particularly this brand. There is Oxford Human Challenge study. You know, they selected the 18 to 60 years of the adults in UK where typhoid is not that common. And they have not suffered from the disease as well as they have not taken vaccination. They have given vaccine and then they have given the solution of typhoid bacilli to drink. And then they saw what is the effectiveness it comes. It came to 87%. So that is what, from there they have started. 9 to 45 was initial label. Now it is 9 to 65 years. And now there is an age extension study which has proved that it can be given beyond 65, that is up to 85. Yes. So now label has changed to 9 to 65 years type R TCV, but next label will come 9 to 85 years. So that is age extension study has been there. And finally, why two-dose discussion is there? Recently in March 2026, the SAGE meeting was held, and there they discussed that with very high incidence of typhoid fever, evidence of waning is more evident in infant and children vaccinated less than 2 years of age. That is one. And second thing, what they have mentioned, read it below. SAGE recommended that countries consider introducing booster dose around 5 years of age in a setting with very high typhoid incidence in children who received a primary TCV at 9 to 24 months of age. In other incidence setting, where the primary dose of TCV is administered before 24 months, a booster dose may be considered if any evidence of waning protection is observed among vaccinated cohort, especially in area with a high dose and high prevalence of antibiotic resistance. So that is a food for thought. This is not out. Maybe in May there will be a recommendation will come. But as of now, ACVIP has looked at the evidences which shows that 7 years persistence of antibody. But the problem with typhoid is we know that there is no absolute correlate of protection. That means you can't say above this antibody you are not going to get typhoid. Why? Because we know that typhoid is inoculum driven disease. If you have a more inoculum measure, then you can get it. And at the same time, we don't know what is the cutoff. And that's the reason this all discussion is going on. What has been found even in Bangladesh and a Malawi study, that if the vaccine is given before 2 years, there is a waning of immunity, antibodies. So it may be required at 5 years, you may need a booster, but as of now, there is no recommendation. Anyways, now go to the next question. A child comes with, now rabies again. Child comes with category 3 bite. History of 2 doses of ARV given, 0 and 3 days, and then he stopped it 2 years back. What should be done? 2 dose day 3 and day 0 and 3, 2 dose 0 and 3 with RIG or monoclonal local infiltration. Restart the schedule with ARV 4 or 5 day schedule, whatever you like. Restart the schedule with 4 to 5 dose with RIG or MAB infiltration in the wound. So now this is a tricky question, and the question will be there on your screen. The person has received 2 doses, 0 and 3, then he has stopped. Now he has got category 3 bite. What will you do now? At least hope everyone should be able to answer it, right or wrong. अनुराग है क्या? Okay. So those who have given other choice other than right, what is the explanation? What could be the confusion in their mind?
See, there was a discussion that even if you give 1 dose or even 2 doses, you do not need a rig or any other this thing after that. So that is the reason why it can be considered as a pre-exposure prophylaxis. However, with a category 3 bite, it is always better to err on over-treating rather than under-treating. So here the vaccine was given only 2 doses and not the full
and that too 0 and 3 days.
And so
see, important here is, yes. What is pre-exposure prophylaxis? 0 and 7. Or you can say 3 dose, 0, 7, 21. So this 0 and 3 is re-exposure prophylaxis. If suppose patient has already received pre or a post exposure and he got a bite again, he has taken 2 dose 0, 3, that is re-exposure prophylaxis. So this is the only, so it is incomplete schedule. So when you say it is not complete schedule, you have to just do as if it has come for the first time. And here almost 2 years back, right? So there should not be any question of giving lesser dose or not giving monoclonal antibody. That's why we should be doing the same right thing. Correct, but still in this case, because it is not been valid dose, we have to give RIG also. Because 0 and 3, no. Because what we say, if you are giving 3 dose schedule, 0, 3 and 7, after 7 days if the patient comes and if you don't infiltrate, right? So you have given 2 dose at 0 and 7, right? Here it is given only 2 dose. So they may be, inferior seroconversion. That's why we can't depend on that. Okay, next question. A diluent for which of the following vaccine is sterile water? There is only one option which is correct. So Indirep, BCG, varicella or Q dengue. Diluent for which of the vaccine is a sterile water? There are 4 vaccines. Indirep is a rabies brand, BCG, varicella, any brand, and Q dengue, which is seeing in the horizon. So yeah, okay, yeah.
So I think I didn't expect this result. I thought at least in BCG no one will give sterile water.
Yes, because
so
everyone
knows
that
BCG is always with normal saline. So anyway, because you have to actually follow the whatever diluent is given with the pack. Don't take out the vial and do on your own. It's always better to follow. So in all the 3 except varicella, we have normal saline. In varicella, we have sterile water because if it is dissolved in normal saline, the sodium and chloride interfere with the viable live viral varicella viruses, and there may be some decrease in the potency.
So what happens, even in rabies brand, there are different brands having different diluents. So if you say even normal saline, it's not all saline. See, if you say BCG is 0.45, Q dengue is 0.22% normal saline. So it's a different saline, but it's a normal saline, it may be saline, not a sterile water. So that's the question over is, only varicella is having a sterile water with it, but you have to use whatever diluent comes with that vaccine. Okay, now about dengue vaccine. Which of the following is true for dengue vaccine? Dengue vaccine recommended to be given to individuals now into 45 years of age irrespective of serostatus. Butantan is a single dose vaccine. Indian vaccine Dengue is a 2-dose vaccine, and Tech 003, that is Q dengue, is tetravalent inactivated vaccine. Which of the following is true? Now the question will be there on your screen. Choose the answer correctly. Now so much of discussion on dengue vaccines is happening. Okay, so maybe dengue session is tomorrow, and that's the reason we got this less number of correct answers. Maybe these questions would have been asked tomorrow. So, yes, anybody would like to take it?
Actually, dengue vaccine is recommended to individuals who've already infected, because they found that if you give it to non-infected individuals, you have more problems in the patients. So that is the reason why it is practically not available now. Butantan, of course, is a single-dose vaccine. The Indian vaccine, I'm not sure, I think it's 3 doses. And TAG 003 is actually a quadrivalent inactivated.
So here the catch is, it started a journey from, dengue vaccine. Wait. Let me clarify. Dengue vaccine was the initial brand, Sanofi brand, where it was recommended, it started into existence, and then they were cases where those were vaccinated when they were naive. Previously they didn't have the dengue. First time they were given the vaccine, and then when they got infection, it was very severe. That was antibody dependent enhancement. That's why what WHO said, no way, you can't give it, you have to check the serostatus. If you are not able to, because that is not practical, you can't check the serostatus of everyone. So they said that those countries where the seroepidemiology says that 80% of them, they have been seroconverted by 9 years, then you can give that the vaccine in the market. So there is less chances of ADE. So that's why dengue vaccine is not recommended without looking at a serostatus. Butantan is a brand which has been studied in Brazil. It is a single dose vaccine. It is having very good result. Only thing is it is against serotype 1 and 2. It has been studied more. 3 and 4 there is no data. So that's the thing. Indian vaccine dengue all. This is same technology transfer from that Butantan to India. Panacea is making it, and that is again a single dose. So once if comes up with the reports and data, if it is showing the data against all 4 serotype, it's good. Now TEC 003 is a tetravalent. Yes, it is a tetravalent vaccine, but it is live attenuated. It is not inactivated. So that is a catch over here. So it is live attenuated tetravalent vaccine, TEC 003. So that was a catch. That's why I am saying everybody is knowing everything, but still when it comes to MCQ, you err on the side of getting a wrong answer. Okay, next question. What is true for chikungunya vaccine? Vimkunya is a live attenuated chikungunya vaccine. Ischik is a viral like particle vaccine. US FDA recently suspended Ischik chikungunya vaccine, and Vimkunya is licensed for 2 years and above. Now this question I put it because Dr. Nitin Shah was going to take session, but he didn't take it. He only talked about the cholera vaccine. Okay, fine. What is true for chikungunya vaccine? I have given more time to think and give the correct answer. You can Google search ChatGPT. Okay, if you search ChatGPT, then only you will get a correct answer. Because this is so recent that US FDA has recently suspended Ischik vaccine. So it was the first vaccine, it came into market, it was very good vaccine, but after giving the vaccine there were adverse effects, there were few deaths. So that's why it was, they suspended it to be used further. Vimkunya is a virus-like particle. So Ischik is live attenuated, and that's why there was a problem. To surpass this live attenuated thing, Vimkunya was made virus-like particle. Vimkunya is licensed 12 years and above. Ischik is licensed 18 years and above. And why we are discussing? Because there is one more vaccine which is in pipeline from Bharat. This particular vaccine is going to come, single dose vaccine, 12 to 65 years of age, shelf life is 24 months, 2 doses to be given 0 and 28, intramuscular, but the data is yet to come. But looking at the initial safety and reactogenicity profile, it looks promising. That's why we may have the good option about the chikungunya vaccine also in near future. So that's why this question was kept, future vaccines. Okay, now this should be known to everyone if you have attended Nitin Shah's session. Which of the following is true for cholera vaccine? Shankol, single dose oral cholera vaccine. Shankol can be given as early as 9 months. Hilcol, single strain oral cholera vaccine, and Hilcol, single dose oral cholera vaccine. We had previously Shankol, now new vaccine which is brand has come, Hilcol from Bharat. Which of the following is true? Okay, so majority of them have listened to Nitin Shah sir. Shankol was previously, already it is there in the market. Hilcol is a new brand. Both vaccines, all the vaccines are 2 dose, 0 and 14 days, to be given after 1 year, not before 1 year. So that last is also gone, not at 9 months. It is a single dose Hilcol. No, it is also 2 dose. Now the question is single strain. As the sir said, no, Shancol, multiple strains have been utilized. While here it is Inaba and Ecojima. The Ecojima is in between strain. Inaba and Okaba. It is a transitional strain which gives response of antigen response to both. So what happens? Naturally, Ecojima doesn't exist because it is in a transfer zone from Inaba to Okaba. So this Ecojima has been stabilized and they have utilized this for the manufacturing of this particular vaccine, Hilcol, which is now available for oral use to be given 2 doses, 0 and 14 days. And as sir said, it is a bit bitter, so you have to give something which is tangy to drink along with it. So that was about cholera. And now going for the last question. So this is what I was just talking about. There is Ona by Nikaba, dual expression, and because it is simple manufacturing practice, it is very safe vaccine. Okay, now next. This is directly, it will come to you. Last question. It is again very simple. It has been discussed a lot in last session about HPV. According to latest ACVIP guidelines, choose the correct statement regarding HPV vaccine. A single dose to be offered 9 to 20 years of age girl, single dose 9 to 15 years immunocompetent girls and boys, single dose 9 to 15 years immunocompetent girls, 2 doses 0 and 6 to boys more than 15 years. Consider all immunocompetent in all options. Okay, so still half of them they have given the correct answer. So here the question was, sorry, single dose to be offered 9 to 20 years is WHO recommendation. WHO says 9 to 20 years single dose. Oh, sorry. By mistake it is there. It's C only. Single dose 9 to 15 years immunocompetent girls and boys. That is what is expected. But it is not been come, it has come in a ACVIP. Anurag, thanks to Anurag. Only you are having a gender bias. 9 to 15 years only girls. 2 doses, no. More than 15 years, again they have kept the same thing. So less than 15 years, even boys, 2 dose. Above 15 years, 3 dose. Now this is all about immunocompetent. Whenever there is immunocompromise, it is a 3 dose. Right? And whenever we think about the dose, now, I don't know why you have changed from 9 to 14 years to 9 15 years. Till now we have been discussing 9 to 14 years. Now it is 9 to 15 years. It is 15th birthday what you have showed. So it is 14 years and 364 days. It's the same, but it is a bit confusing when you use new terminology. You take a mic.
So, bringing a change is difficult. So the data is very right for 9 to 20 years, but the data is only for girls. There was no data on boys. So we said, okay, we'll go strictly by the studies, and to bring a change, there is a lot of resistance. So we said, let us break it up into 2 parts. We do it 9 to 14 years and 364 days, so 15 years ho gaya wo, and let the next team do it till 20 years and boys and all that. So data is available only for girls across the world, and the data is robust, and around 80 countries have shifted to single dose. So that is the reason we also shifted in our guidelines. And
now my question is, suppose person has taken 1 dose in government, if he comes to me, should I give 1 more or not?
So this is again your choice. वो ना 1-to-1 discussion वाली बात है.
Okay, fine. I got the answer. Thank you so much. So now, time for the results. So all learned faculties, experts in vaccinology, don't jump. I'm not going to call you. I'll at least first give you the list of the people who have top 10. Mrutyunjay Das, always. Yop, what is Yop? Who is Yop? Yagnesh Popat, yes. Barefoot, who is walking barefoot? Who is barefoot? Yes, come here, come here. You come with the shoes only. Don't come barefoot. S. Mukherjee. Please come. I'll see if the face is unknown, I'll call you. Tiger baby? Where is tiger baby? Who is tiger baby? Okay, fine. Hello? Yes, come, hello. Come here. PG, tiger baby is lost for follow-up. PG, please come. Bratish? Bratish? Yes, please come. Ziltan, what is that? Yeah, please. Carl Gustav. Who is Carl Gustav? Okay, I'll go beyond this and will give you 10 people should be there here. So please come, those who I've announced name, please come here, we'll count and then we add कितने लोग हैं? 1 2 3 4 5 6. ओके, सो हम कहाँ तक पहुँचे थे? हाँ, कार्ल गुस्ताव के बाद एस, हु इज एस? ओके, फाइन. नहीं, इट इज एस ओनली. जी एस? ओके. हसैन अली मियाँ, प्लीज. सौरव यादव? सौरव यादव? यस, प्लीज. नहीं, कहाँ हो गया? 2 4 6 8 ही हुए ना? हु इज कमिंग? ओके, कम कम. मेरे पास 10 गिफ्ट है. हो गए? कि एक बाकी है कोई? सर, योर नेम? GS. हो गया? एक कम है. 5 3 6. एक नाम और है ना? कौन रह गया? सौरभ बोला ना लास्ट में मैंने. तो उसके बाद अभिषेक माझी. यस प्लीज. चलो, हो गया 10. कम प्लीज, कम ऑन द स्टेज. राउंड ऑफ अप्लॉज फॉर देम. We'll give the prizes. Yes, good to you. आप आ जाओ. अरे प्लीज सॉरी. जगदीश पोपट, आ जाओ. You give the prizes. Come. Jagdish, you give the prizes. Please come. पीछे कहाँ है? अरे नहीं. थोड़ा मिसमैनेज हो गया.
एक बार क्लिक कीजिए પછી they don't allow you to.
ના. एक मिनट आ रहा हूँ.
I would like to request the experts to please collect the memento.
Good evening, everyone. I request everyone kindly settle down. So, myself, Dr. Preetha Dash, currently working as Assistant Professor in Pediatrics and Pediatric Gastroenterology at Institute of Child Health, Kolkata. So, it is a pleasure to see such a distinguished gathering of experts, colleagues and friends here at the Pediatric Infectious Disease Conference, Summer CME 2026. So after a day filled with intensive clinical discussions, complex case studies and deep dives into the antimicrobial therapies, we thought it is a time to shift our gears. They say all work and no play makes a very dull symposium, and we certainly don't want that. So tonight we are stepping away from the stethoscopes and diving into a fun-filled games with our friends. We have a series of rounds lined up that will challenge your wits and hopefully provide a few laughs along the way. So, without further ado, let's get the energy up and get this game session started. Thank you. I'll hand over the mic to the first game. Okay. Okay, so first we'll start with the memory game. I'll hand over the mic to Dr. Sneha.
Hi, good evening everybody. So we'll be playing memory game. It's a very simple game. There will be a slide projected. It will contain names of either a bacteria or any antibiotics or anything. 8 names will be there. You will be given 20 seconds to memorize the names, and then the screen will be turned off. You have to remember the names. I'll just randomly give you some numbers and you have to tell me what name was there in that particular number. Okay? Yeah. ये side. It's a memory game. You will be given 20 seconds.
So requesting all of you to settle down because you have to see the screen. Only concentrate for 20 seconds, not much. You have to remember, let's see. Whoever raises the hand. Dr. Mrityunjay has raised.
Who will tell me what was there in number 3?
And only then Dr. Popper. No, no.
Ma'am. Yes, that's correct. Oh, sorry.
Okay, okay. First, Dr. Rajshekhar. नहीं प्रीथा की नहीं नहीं वो आपको जल्दी जो हैंड रेस पहले करेंगे हाँ पता नहीं एक्चुअली यू गो स्लोली ठीक है वो एक्स्ट्रा बाद में दे देंगे जो मिले
ट्रायल राउंड ओके
नो नो फिर तो But you have to, whoever is it. For Dipti, it is always this.
So actually, we will show the slides for 20 seconds and then we will ask the question that what is number 3 or number 4. Yes. Then you will raise the hands and first one who will be raising the hands will answer. And if correct, you will get the prize. Okay. So,
sure. Shall I move to the next slide?
नहीं no cheating please sir sporting होना चाहिए थोड़ा off इतना टाइम मत तो कम करो बहुत टाइम दे रहे
Okay, so who will tell me what was the name in number 4?
Dr. Popper.
Yes, that's correct. Dada, time. Next slide.
No, just wait. Okay.
Number 7. Arey.
ठीक है उनको दो
Yes.
GBS
that's correct. और कहाँ है हाँ टाइम Okay, next slide. Number 5. That's correct.
Please, सामने आ जाओ. You three of us, 3 of you. Please sit in the second row.
Next slide. Number 8. Is everybody?
No, I think. पहले उठ
Gap. Okay, next slide. Number 2. No, he said first. Ma'am, he said first. Okay.
You got one.
Okay. Okay, next slide.
Tell a number.
Number 8.
Sir, Dr. Agarwal.
Sir.
Clear cut. Sir, share कर लीजिए. Is it over?
I think one is left.
Huh? और है?
One more is left. Last. So this is the last slide.
Please. एक मिनट 0-1
No.
ये तो दे दिया ना.
नहीं 8 है.
सारा हो गया क्या? स्लाइड नंबर
Okay.
बहुत सारा गेम्स है. So call up.
Now we'll be playing our next game. It's called Call Upon Game. I'll hand over the mic to my colleague, Dr. Pritha. So the next game is Call Upon Game. So I will be showing an object on the screen, and whoever has that object with him or her will raise the hand, and the first person to be having that will get the gift. Okay? Whoever comes first.
With the object on the dais.
Okay, so run and come with the object in your hand to the dais and get the gift. Okay. Timer nahi kichu. So let's start. So whoever has a red handkerchief, please check your handkerchiefs fast. Red one.
Anyone has?
Okay, so
prize is vested.
So a different color. Should we ask for a different color? Different color. Yellow. Gray handkerchief. Okay, so next. Whoever comes first on the dais. So please, whoever comes first. Ma'am will decide.
Dr. Agarwal has stepped on the dais.
Okay, going to the next one. A 10 rupee coin. Okay, that's great.
you, sir. Okay, attention, the next one. So, a size 10 shoe. Whoever got, come and show us the size of your shoe. No, just size 10, that's it. Okay, so fine. Next one. A picture of your spouse or children in your wallet or purse. Great, so okay, so the next one. A pen that writes any color apart from blue or black. Anyone who has got something other than blue and black? Red, green. Anyone who has got a pencil in the bag. Okay. Oh, okay, so the next one. A picture of you with a celebrity in your photo gallery. No one yet. Please come. Okay, so ma'am got the prize. Great. Then the next one. Any of these apps in your mobile phone, shadi.com, book, please come, whoever. Okay, so that's fun. Going to the next one. Anyone wearing 4 finger rings on one hand. You can change also if you have. So you can change and put it in one hand and show us. Okay. So let's settle down and go to the next one. Next one. Anyone wearing two different colored socks? One hint is that you can change the socks also if you want. So this proves that sometimes silly mistakes can be the right choice. No, sir, who got the prize? He has got a blue one and a black one. Okay, so great. Next one. Wearing a Titan Raga wristwatch. I have got. Okay, so the next one is a tattoo on the body. Anywhere. So he's showing his picture with Sachin Tendulkar. So yes. So I don't think anyone has got this. This is for you, sir. Okay. Great. So the next one. Next one. HDFC Bank debit card. Okay. So the next one. A yellow colored phone cover. Anyone? Red color. A red colored phone cover. Green, fine. Okay, so wearing a Rolex wristwatch. Who has got it? He has got a yes. Fossil. Okay. So next one, okay. So carrying a green colored stethoscope. Anyone carrying a stethoscope right now? Okay, that's the end of this game. Thank you so much. Hope you enjoyed this game. So.
So good evening all. So I will deal with the names of our faculties of this conference basically. Okay? Display record. Oh, nothing the rules. The questions will be displayed and you have to guess the faculty. Okay. So, guess the faculty. When beauty needs a name, who is already there? No, think cow. There are two answers, but I have willfully omitted one answer. No. Think like cow. When beauty needs a name, who is already there? So, one clue. He was present today in the first session with me. Dr. Rupam Das. When beauty needs a name, it was always hiding in plain sight, right in his name. It's not there. Okay. So, the next question, think cow. When the sun rises, who does not need an introduction? Yes, Dr. Bhaskar Senai. Bhaskar the sun, like the sun, he lights up every room he enters. No introduction needed. We'll get the prize. No price of guessing yourself.
Thank you.
Okay, next. Very easy. When two Ks are enough. So, sometimes two letters say it all, and these two are absolutely iconic. Like the singer KK, here is our KK sir. Okay, question 4. When dharma needs a direction, who is already guiding? When dharma needs a direction, who is already guiding? Yes, Sri Krishna. Very good. The eternal guide of the Bhagavad Gita. His name carries the wisdom of the ages. Excellent, sir. Excellent. 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 Okay. When order and rhythm come together perfectly, who fits in naturally? When order and rhythm comes together perfectly, who fits it naturally? So Dr. Rita Badakundu. Rita means cosmic order or rhythm. Woven into the fabric of universe, his name carries the rhythm of the cosmos itself. A bit tough. Okay. When victory is needed, who already has it in his own name? So I have some different answer. It is Dr. Sanjay Ghorpare. Because Sanjay means victory, he does not just aim for victory, he carries it in every syllable of his name. There's a different question for that. When devotion meets music, who composes the moment? Very easy. Yes. Dr. S. Balasubramaniam sir. A name synonymous with the melody, devotion and timeless artistry. The music plays itself. And Balasan plays the music of infectious disease in the auditorium. So that happened to me always when I go to South India. When I book a cab in the South India, the driver came rapidly. Professor, sir. No, I am not that professor actually. So when the night turns calm and thoughtful who quietly takes over. Dr. Nitin Shah, quite calm and over present, just like the night that holds the world in peaceful stillness. When joy meets depth, Dr. Jadid Chaudhary, joy and light, a name that practically radiates warmth into every conversation. Please come, sir. So that should be in the background, please. Okay. When love drives science, who is already leading? When love drives science, who is already leading? The questions are getting tougher and tougher. It's Dr. Anurag Agarwal. When passion and love for medicine meets, his name says it all before he even speaks. Okay. If you are looking for the holiest destination in India, who is already there? This one first. Dr. S.J. Kasi. He carries within his name India's most sacred city, all pilgrimage in every introduction. Sir, please come on the stage. And this should be taken in the background. Sir, this should be in the background. The stage should be in the background. Yes, in the background. When the sun rises again, who brings the day forward? Dr. M. Surendranath. Surendra, Lord of Light associated with the sun. The sun never needs a reminder to rise, and neither does he. Okay. When awareness sharpens into action, who steps in? Dr. Chetan Trivedi. Chetan means consciousness, awareness. Awareness is the first step to action, and his name embodies the spot perfectly. Next, when conversation need a little extra flavor, who adds it? When conversations needs a little extra flavor? Rasna. Okay, this way. With Dr. Rasna Das Hajarika. Rasna means taste or flavor. Every great conversation has a little extra flavor, and she brings it naturally. Please take this photograph with the background. In podium में आ जाइए मैम. Okay. When calm meets mystery, who carries the shades? Think a bit deep. It's Dr. Syam Kukreja. Syam is dark, associated with Krishna. The color of deep devotion and quiet mystery, just like the name of the beloved Lord, isn't it? Okay. When attention to detail matters, who notices everything? Who told it? Yes, sir. Chitkara. Chit means mind, attention, consciousness. A mind that misses nothing, his very name is hardwired for the focus and awareness. Chitkara sir, nahi hai na? That should be taken in the background. Okay. The next one, it will be a bit easier. When death is challenged, who has already won? That side, from that side. Dr. Mrityunjay Das. Sir, please take it on background. Take this picture on the background. Okay. When a yajna begins and the आज चारटे आचे ठीक है नो प्राइस प्राइस नहीं है ऐसा ही होगा टू प्राइस okay last two questions no prize total 22 is there okay when fear disappears who is already there from that Dr. Avesa when the fear ends he begins a name that embodies courage in every letter. Next question, when victory repeats itself who carries it forward? Jayant, who told? Yes, Dr. Jayant Joshi. Jayant is victorious. Victory is not just an outcome for him, it's literally his identity. Okay, no prize. Okay, just for fun. No prize. No prize. When a new beginning is born, who represents it? Dr. Janani Sankar. There is no prize. आ जाइए मैम. Last question. Last. Huh? Okay, no prize. So, I was not able to make for all faculties because I just met 2 hours back. When friendship becomes divine, who stands beside you? Friend. Dr. Gopal Bandhananda. No. So if there is a sudden rain and all the floods, only one faculty will be able to go back home. If there is sudden rain and floods all over, so only one faculty will be able to go back home.
Okay, so after this brainstorming session, we go to our next session, which is Find Your Partner. So we have already distributed the chits with you. Don't open, sir. Please don't open now. So after we start the timer, open your chits, find the matches, find your partner. Suppose, for example, I say one has got a chit saying Delhi, and another one has got India. So that is a, yeah, any topic like that. Okay. Okay, so start. Open the chits, see the name, and find your partner. So the first three coming to the whoever comes first to the dais will get the prize. First three couple. First three couple. Okay, we got the first one. Second. Okay, so we got the second couple. Great. We have got one more prize. So the third is remaining. Great. We got fourth one. Fifth. One more extra prize we have got. Great. So 5. That's the end. That's it. We got 5 couples. Sorry. Rain Man. Movie. So it's over. We have got 5 couples. Thank you. 5 prizes. We don't have more than that. Thank you. Please settle down. The first one. Okay, so let's settle down. So
we are giving 2 extra. 4.
Okay, 2 more extra prizes from Kia Madam. Okay, so let's settle down. So I have an announcement to make. Tomorrow is Kia Madam's birthday. So we have arranged a little ceremony for that. Yes, आज ही काटेंगे केक. So they are bringing the cake. After the cake cutting, ma'am.